morning, everyone, and welcome to our third annual conference on student mental health research this morning. My name is Sherry Billets, and I use she, her pronouns, and I will be starting us off this morning. So just before we get started, I wanted to let you know that you can turn on the live captions in the Microsoft Teams through the three dots on the top right corner and click the Turn on Live Captions. So as I said, my name is Sherry Billets, and I am the Director of Counseling Services in Campus Wellness at the University of Waterloo. Campus Wellness is committed to enhancing and supporting wellness for all in a safe, respectful, and inclusive environment. We enhance wellness at the individual, community, and systems level through advocacy, building capacity and partnerships, providing dynamic programs and services, and strengthening communities. Just before we get started, I'd like to start us off with a territorial acknowledgement. And although this is a virtual event, I'd like to acknowledge that the University of Waterloo's main campus sits on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee peoples. It is situated on the Haldimand Tract, the land granted to the Six Nations that includes 6 miles on each side of the Grand River. We are going to be hearing opening remarks from Dr. Vivek Goel, our President and Vice Chancellor. On September 22nd of this year, our President acknowledged the university's unique and important role in committing to work toward truth and reconciliation, ensuring that Indigenous knowledge and ways of knowing are represented in our research, our learning, teaching, and community building through the formal commitment ceremony. I'd like to welcome Dr. Vivek Goel now, President and Vice Chancellor of the University of Waterloo. Vivek is going to kick off our conference today with welcoming remarks. Good morning, Vivek.
Good morning, Sherry. So thanks for doing the land acknowledgement and noting the commitment ceremony we had a few weeks ago. And as I've learned more and more about the Indigenous cultures and their approach to well-being, we have so much to learn from our Indigenous elders, our Indigenous communities, about how they balance their existence on this land and keep as well as possible through the way that they treat the land and everyone around them. So it's my pleasure to welcome everyone to the Student Mental Health Research Conference. We are focused on building positive mental health for the entire University of Waterloo community. I'd like to thank you all for joining this virtual conference to explore important issues related to student mental health research. Student mental health is one of the most pressing concerns across university campuses right around the world, and we are no exception. Mental health was a growing concern even before the pandemic. And as we've all witnessed over the last couple of years, learning within a pandemic environment has taken its toll. It has affected everyone's studies. This fall term, it's been such a pleasure to see our students back on our campuses and taking part in university life in full. But I'm also acutely aware that many of our students are still dealing with the health ramifications of the past 2 very challenging years of remote learning and other pressures resulting from the pandemic and so many other events throughout the world. We are committed to supporting our students' health and wellness as they undertake their studies through initiatives such as this, the Wellness Collaborative, our commitment to the Okanagan Charter, and the implementation of recommendations from both the Committee on Student Mental Health and the President's Anti-Racism Task Force, among many other supports and resources. We are also enhancing mental health literacy. It is a priority that we included in our most recent strategic plan. Today's conference aligns with that priority by bringing together members of our community to share knowledge and build connections as they relate to well-being in our work, research, studies, and the promotion of mental wellness. At Waterloo, we are committed to creating a campus where everyone belongs, where we all work toward equity and strive for a culture of authentic inclusion, even when it is complex and challenging. We know there's often an additional mental toll on racialized and other equity-deserving groups as a result of ongoing impacts of colonialization and structural racism. In 2018, the University of Waterloo signed the Okanagan Charter. It was the fulfillment of a recommendation from the President's Advisory Committee on Student Mental Health. Within that charter, we are committed to promoting health and wellness across our campuses through regular research and education events that include faculty, staff, and students. These events have sought to address key themes such as mental health strategies, suicide prevention, equity and wellness, harm reduction approaches to substance use, and the mental health impact of the pandemic. While I'm pleased that we have accomplished a lot since signing the charter, I also recognize that there is still much more to be done. Removing the stigma attached to mental health remains a challenge. With that said, I'm encouraged to see the number of participants attending this conference now in its third year. Your dedication to our students and our community is pivotal to sustainably addressing these challenges into the future. We are heralded for our experiential learning opportunities and innovative research, but it is the students, staff, and faculty who make this institution what it is. It is vital that we continue to look out for one another and check in with ourselves to ensure we are all doing okay. Strong communities look after one another. They encourage and assist those who need support and champion those that excel. Thank you for your commitment to these important initiatives and research. Enjoy the conference. Thanks.
Thank you, Vivek, for providing the broader context of well-being at Waterloo and how our institution is committed to the well-being of everyone in our university community. I really appreciated the comments that you made about us all taking care of one another, and that it really does take a community of individuals to support the mental health and well-being of all. So thank you so much for your comments. As the Director of Counseling, I've had the amazing opportunity to work with a passionate and dedicated multidisciplinary campus wellness team, along with others on campus and senior leadership across the campus, and can say that there is a strong commitment to supporting student well-being and mental health across and for all. Our work includes important upstream prevention work, such as examining structural barriers to well-being and also looking at the social determinants of health. Today's conference is part of Thrive at Waterloo, and there are three central goals of Thrive. First is to enhance mental health literacy. The second is to build healthy habits and self-care skills. And the third is to foster a supportive and inclusive community. Through Thrive, we encourage everyone to share responsibility for promoting mental well-being on campus and have open conversations about mental health challenges all year round. Today's sessions are a great way to harness the strengths of our own university community to support student mental health. Our hope is that this will spark connections and synergies within our teaching and research. Thank you for joining us today to further advance our collective efforts in this. Before we start our first session, I would like to remind you of some important logistical items. One is that the same link for the conference will be used for the entire day. When you leave to take a break, you can jump right back in. So if you have to leave for a bit, you can come back in at any time using the exact same link you used this morning. All the presentations for today are being recorded and will be available on the Thrive website later this month. The format of our conference today consists of presentations followed by Q&A periods. Audience members can submit questions through the Q&A function at any time during the presentation. Moderators are monitoring the chat and will ask questions to the presenters. Let's work together to keep comments and questions curious, kind, and compassionate. Over the course of today's agenda, some of the topics may feel difficult to discuss Feel free to step away if you need to take a break, or if you need to take some time for yourself. We will be putting some resources in the chat so you can access them at any time. So just to get us started off, I'd like to welcome today's first presenter, who is David Grant. His presentation today is titled "Staying High While I Survive: The Relationship Between Substance Use, Trauma, and Psychotic Disorders Among Young Black Men of African Ancestry." I'll just read over a little bit of David's bio before he introduces himself. David Grant is a current PhD student in the School of Public Health Sciences at the University of Waterloo under the supervision of Dr. Chris Perlman, where he is focusing his research on treatment, assessment, and conceptualization of Black youth, mental health, and illness. Some of his research interests include substance misuse, personality, psychotic, mood, and trauma disorders, geriatric mental health, psychosomatic research, and psychometric research. David is also a registered social worker with a master's in social work and a specialized knowledge in psychiatric illnesses such as addictions, particularly from Black people from the African diaspora. David's research is particularly grounded in his clinical work, as he concurrently operates his own private psychotherapy practice. Additionally, David previously worked as a social worker in an ethno-specific program for Black youth entitled the Substance Abuse Program for African Canadian Caribbean Youth, a concurrent disorder program in the Child, Youth, and Emerging Adult Department at the Center for Addiction and Mental Health. Wow, David, we're very fortunate to have you this morning. You bring with you a lot of practical experience with you, so we're really looking forward to hearing from you today. Thank you for sharing your work with us today, and I'll turn it over to you.
All right, my pleasure. Thank you, Sherry, for the wonderful introduction. I'm assuming everybody can hear me. I turned my mute mic off. Okay, great. So yes, thank you. It's a pleasure to be able to speak to everybody here today. I want to get right into it. You know, as Sherry mentioned, my name is David Grant, and my background is in psychotherapy, you know, as a social worker. And so today's presentation, we can essentially envision it as that of knowledge translation. I really want to share not only two case examples, but even literature on the respective issues that I will be speaking about: psychotic disorders, trauma, as well as substance abuse, and understanding how they are all related to one another, particularly for young Black men of African ancestry. And just to be clear, when I say African ancestry, that also includes those who descend from the Caribbean, who descend from South America, as well as the continent, as well as multi-generational African Canadians here who, let's say, predominantly reside in Nova Scotia, for instance. I just want to help people understand that there are foundational similarities as it pertains to both the issues as well as the phenomenon of how Black people experience and understand mental health and illness, as well as some respective barriers that present their way when it comes to trying to receive help for their respective mental health needs. So I hope people can see my slides. Can everybody see my slides? I'm going to presume so. So, staying high while I survive: the relationship between substance abuse, trauma, and psychotic disorders amongst young Black men of African ancestry. So I want to start with two case scenarios. So just for people's knowledge, the identifying information here is not fully accurate in order to protect the confidentiality of these respective patients, you know, with whom I worked in the past. So the information itself is accurate in terms of some of the pieces, but I did distort some pieces just to protect the identity of the respective patients. So let's start with Mukisa. Mukisa was born in a country in East Africa to married parents. He migrated to Canada in his adolescent years, particularly first to the Maritimes, followed by various middle-class neighborhoods in the Greater Toronto area. Mukisa, according to family members, and as well as himself, was essentially a straight-A student. He was personable, he was likable, he was very popular both in his school as well as in his neighborhood. no issues, as well as Mukisa never mentioned any sort of behavioral issues that he experienced both in school as well as in the home, other than, of course, mischievous teenage behaviors. But however, as he began to become settled in the Greater Toronto area and and started to become accustomed to the urban life, as one would say, he found himself drifting towards a life in, as they would say in quotes, the streets. He became involved in street-related activities such as drug trafficking, and found himself thereafter exposed to, unfortunately, traumatic incidences, including street violence, from being physically assaulted to witnessing physical assault, to seeing people get shot, to being threatened with weapons and all the sorts. And unfortunately, his continued engagement in street-related illegal activities led him to being incarcerated for a period of time. And then when he came out, we saw his mental health issues, unfortunately, began to take a toll. But it was during this time that he was experiencing these street-related violence where he began to experience trauma-like symptoms, from hypervigilance to paranoia to even re-experiencing the flashbacks of the respective traumatic incidents. And in order to begin coping with that, he began to abuse cannabis. It started recreationally, then it turned into a coping mechanism. But unfortunately, concurrently during that time, he was also beginning to develop psychotic symptoms. Now, it's very difficult to tell whether the psychotic symptoms came as a result of the cannabis or if it was possibly already present. But nonetheless, unfortunately, the psychotic symptoms ended up progressing into a worse, essentially substance-induced psychosis, leading to 2 different admissions to the hospital. And he was diagnosed with cannabis use disorder, unspecified schizophrenia spectrum disorder, as well as BPD or bipolar disorder 1, but it was a provisional diagnosis. So that's case study number 1.
Hi, David. Sorry to interrupt. Just wanted to let you know we're not seeing your presentation in full screen.
Okay, not in full screen. Okay.
Maybe if you switch to presentation mode.
Give control. Okay, it should be. Okay, let me. Something being shared, not shared. Okay. Can people see now?
Perfect.
Okay, great. So this is case study number 1. Thank you for pointing that out, Sherry. Okay, great. I'm happy everybody can see now. So this is case study number 1, as I mentioned. And so case study number 2 is Abeyo. So Mukisa was 22, Abeyo's 21, so around the same age, born in a country in West Africa. But he was raised, contrary to Mukisa, raised in a single mother household. He arrived first in the US in his infant years, and spent his infant to adolescent years residing predominantly in a very violent housing project. This housing project was infamous for violence. And when I say violence, I'm talking every form of violence, from seeing dogfighting, from seeing police brutality, from seeing intercultural violence, unfortunately, from hearing shootings, from seeing shootings, you name it, he saw it. And on top of that, he also experienced early childhood sexual abuse, which of course further aggravated any sort of pre-existing trauma-like symptoms he was experiencing from the various forms of violence he was witnessing. And while he was also witnessing and experiencing these various traumatic issues, he and his mother were living in abject poverty. He talked about how not only were they living in poverty in the US, but when they arrived in Canada in his mid-adolescent years, the poverty only worsened further, where they experienced chronic homelessness. Unfortunately, his mental health was beginning to take a toll around his adolescent years, where he started to struggle with depressive moods, and it began to worsen as soon as his mother unfortunately passed away in his later adolescent years, where he began to see the progression of him using, again, what began as a recreational usage of cannabis, transitioning into a more excessive and dependency relationship with cannabis, as well as concurrent psychotic disorders, particularly hallucinations and delusions and the sense of paranoia that was beginning to manifest around this time. And unfortunately, he experienced such a very significant psychosis that not only led him to be involved in the criminal justice system for a respective incident as a result of the psychosis, but also led him to admission for experiencing psychosis, and he was diagnosed with schizophrenia. Those are 2 case scenarios of individuals I work with, where we see, again, these themes of trauma, psychotic disorders, and cannabis use all manifesting, in these young men's lives. So let's talk about, what does the literature say about trauma, psychotic disorders, and substance abuse? So if we start with trauma, there's a growing knowledge of the of researchers investigating the impact of PTSD, or specifically for trauma, but specifically PTSD on people's neurobiology, or essentially the impact on one's central nervous system or nervous system. And so when we think about trauma, we oftentimes think about PTSD, but we also need to consider ASD, or acute stress disorder, which is when somebody has experienced trauma and they start to experience trauma-like symptoms and it's diagnosed within the first month. That's what differentiates ASD versus PTSD, which is post 1 month of experiencing those trauma-like symptoms. Because PTSD typically is the go-to diagnosis, because people don't either recognize or don't seek out help until later on. This is why we are more knowledgeable about PTSD versus ASD. We also understand trauma. It manifests differently for everybody. For some people, their response to trauma or thereafter is that of deactivation. What is deactivation? Dissociation, emotional numbing, really essentially stonewalling, just shutting down in conversations as part of that freeze mode, and as a sequence of fight, flight, or freeze. Or we have the other extreme, hyperarousal, so experiencing that hypervigilance, that paranoia, really just being on edge, because even if the traumatic incident is not occurring at that moment, your body is still reacting as if it's still currently happening. When it comes to who experiences trauma versus who doesn't, researchers have also demonstrated or noted that it may be related to somebody's gene makeup. Some people's genes, and they're unsure of what specific gene, but some people's genetic makeup makes some of them more susceptible to experiencing trauma versus others who may be a bit more resilient. Just because 2 people or 3 people experience the same traumatic incident does not necessarily mean that they're going to go on to experience trauma-like symptoms and therefore be diagnosed with a respective trauma disorder. Now, when it comes to the relationship between cannabis, trauma, and psychotic disorders, researchers do note that experiencing trauma, particularly early in one's life, as a child, for instance, actually increases the risk. Because of the damage to the developmental process, it increases the risk of possibly, again, not guaranteed, but possibly developing psychosis in the later future. And we'll talk about the relationship between cannabis and PTSD, or trauma-like symptoms, in the next slide. But when it comes to young Black men, this therefore starts to give us an understanding as to why young Black men, who unfortunately have to not only in some cases experience trauma, but on top of that experience racial trauma. When we think of police brutality, when we think of their experiences in the healthcare system, when we think of many of their experiences in school systems, that racial trauma, which is no different per se from psychological trauma, but you add in the racial piece, which is chronic, which is long-standing, what makes somebody very paranoid about is somebody mistreating them because of their racial makeup, that exacerbates their already pre-existing trauma-like symptoms, and therefore we can presume increases the risk exponentially. So then, when we now think of cannabis, with cannabis use, oftentimes cannabis use disorder exists comorbidly with other disorders, for instance, depression, anxiety, or even psychotic disorders. In Canada alone, there is a growing number of Canadian youth smoking cannabis. According to one recent study, Canadian youth arguably have the highest, or even one of the highest, depending on which study you read, of cannabis use rates in the world. So that goes to demonstrate that our youth are using cannabis at quite a significant rate. Cannabis is known as a possible risk factor to possibly initiate or even aggravate psychotic symptoms. Now, there is the debate on whether it's causality versus association. Does it cause psychosis, or is it just strongly associated with the rise or with the initiation of psychosis? This is what research is still trying to debate. As I said, cannabis use disorder oftentimes is comorbid with trauma disorders like PTSD. Why? Because as we can see with these young men, it sometimes is a way of self-medicating, of soothing those very anxious feelings, those very traumatic flashbacks. And in order to cope with that, this is where the cannabis use goes from recreational to a coping mechanism. And so then when we think of what's Black youth's usage of cannabis, the research is still trying to figure out, still in the infant stages of trying to figure out what is the usage pattern. One research study, for instance, done here in Ontario, noted that Black youth, both native and foreign-born, do have higher usage rates than, let's say, white youth or even East Asian youth. And so the question is why? Why is that the case? And again, if we look at these two case scenarios, could it be that they're using it to cope with the traumatic life, unfortunately, that is set forth for many young Black people? Could it be a way of escaping this very traumatic reality? Maybe not for everybody as extreme, but nonetheless, this focus of understanding the experience of racial trauma. And then lastly, when we think of psychotic disorders, we understand that psychotic disorders is a part of the neurodevelopmental process. We know influenced by environmental factors, gene variation. They're still trying to figure out what specific gene may cause psychosis. We know that substance abuse and even early childhood trauma can aggravate psychosis, but does it cause it is the million-dollar question. This is where people are still trying to debate. So when it comes to young Black men who experience psychotic disorders, unfortunately, while their symptoms may not vary significantly than other groups, how Black men are perceived dictates how they are treated, unfortunately, in the healthcare system. And so when we think about, when we understand that, this is where we start to understand why the studies start to demonstrate that young Black men are more likely to enter into healthcare settings through legal or medical coercion than other groups, why they unfortunately are perceived as more violent and threatening, and therefore that can dictate what sort of treatment and how even they're assessed. The fact that, for instance, case study number 1, he never received a diagnosis of PTSD, it could either be because he never talked about those symptoms, or it was never asked about. So this is where we have to understand how are we conceptualizing, how are we understanding and assessing our young Black men who are coming in wanting help. How do we help them? So what are the implications? We have to understand that there is clearly an issue. There's clearly an issue with how young Black men are being treated in these respective health realms, how their issues, their symptoms are being perceived, what sort of diagnoses are we using to essentially represent and describe what these young Black men are experiencing. Are we asking the right questions? The second piece is, what are we doing about the psychoeducation on cannabis usage, not only in Canada generally for Canadian youth, but specifically in various Black African diaspora communities? How are we explaining to them the association with the increased risk of developing other comorbidities like depression, like anxiety, or using it to cope with comorbidities like PTSD? And then the third piece, when psychometric instruments, which I've used many of them, including the patient health questionnaire, which is used to understand depression, or GAD-7 used to understand anxiety, and DAS, the drug abuse screening tool to understand drug abuse, are these congruent with cultural concepts of health and distress? We have reached the point where there's enough literature and the consensus to understand that culture and mental health cannot be separated. They're inextricably linked. So are we using psychometric instruments, despite them being so-called standardized, are they actually congruent with other populations that are not Western European, which is what the population which the instruments were based off of? This is where we have to really understand, we have to do further research. So then in conclusion, what do I say? More research, of course, needs to be exploring the prevalence of psychotic disorders among first-generation Black young men and women of various African diaspora communities. This is one particular avenue that I plan to pursue throughout my PhD. We also want to look at the possible gender differences among young Black men and women. Do young Black men experience psychotic-like disorders in the same way as women? Do they experience certain symptoms over the other gender? This is where we're trying to figure out. Again, I reiterate, there needs to be more exploration on these Western-based psychometric instruments, not to say that they're fully wrong and need to be, we need to throw out the baby with the bathwater, but maybe understanding and critiquing some of the aspects that may not be congruent with other non-white or non-Western populations. This is how we build strong instruments, and this is how we actually treat people of various other ethnicities in a very equitable manner. And lastly, when we look at clinical implications, we have to look at clinical implications not only in the healthcare settings, but we also have to look at it here on campus or on various campuses throughout Canada. We have young Black people, both internationally and domestic, who are coming with various mental health needs that need to be sorted out. They want to come and they are trusting. Unfortunately, many struggle with chronic mistrust because of experiencing traumatic incidences with other non-Black health professionals, in some even cases, Black professionals who unfortunately adhere to Western standards. So we have to really understand, how can we meet the needs of young people on campus who may be suffering in silence? How do we help meet their needs in a way that's not only culturally congruent, but of course is best practice care to ensure that their holistic needs, including their psychiatric needs, are met? And this goes for nurses, social workers / counselors, as well as psychiatrists here on site. So thank you very much for listening to my presentation, and I hope it was informative.
Thanks so much, David. Wow, that was really informative, and lots of implications for the work that we do, as I talked about, in campus wellness. So really, having a multidisciplinary team who work with young Black students, and some of the implications that you talked about, and really looking at the way we assess, the psychodiagnostic tools we use, are they appropriate, given the Western view of them, and are they, transferable in the way that we do provide help? So very inspiring and I think very important work that you're doing. So thank you so much for sharing that.
My pleasure. Thank you.
So my role now is to ask you some questions from the chat. So I might just give a minute, because people have probably been listening and not putting their questions in the chat yet, but just maybe we can just give it a minute and see if any questions emerge from the group. I might start us off with one.
Okay, sure.
Yeah, and I really love that you used two case studies, Mukisa and Abeo. Like, you really used some practical examples and really humanized the work that you're doing. And I guess I just wonder, because you're a psychotherapist as well, how has your research informed the way that you've been working with individuals through your private practice?
How's my research informed? Oh, so on that end,
yeah,
it's what it's done is it's sometimes difficult to say if it was the research that informed my practice or it was the practice that informed my research, because it's almost a very dialectical process, right? And so if we're looking at how my research informed my practice, I would say it helped to expand my understanding of the issues that my patients or clients are presenting with in more detail. I guess you could say it's that more deductive standpoint, right? So when I'm looking at the research, I'm looking at, the vast literature as it pertains to respective issues or symptomology, or how to, treat these respective peoples. When I'm in practice, I'm trying to actually, make it more clinical. It gives me more insight into not only what they're presenting, but what's the background behind it. Right. So especially if we're having youth, for instance, coming from West Africa, coming from the Caribbean systems, and I'm understanding not only contextually in this respective context, but understanding what's also being carried over. And you see that when they talk about issues back home, for instance, if they were born back home, or if they were born here, but you see some intergenerational stuff of things that were linked to their back home, right? And with me having that research background, it helps me to put things into perspective. Even for myself, there may be things I know, obviously, intuitively, I'm of African Jamaican descent, and there's going to be things, obviously, I know culturally, but there's going to be other things that I may not know, for instance, somebody who's Afro-Trini, somebody who's Afro-Colombian, whatever it may be. And so that research background helps me put things in perspective, not only understanding the trickle-down effect from colonialism and enslavement, but even in more recent times of economic devastation as a result of the residual effects, looking at poverty, look at job insecurity, look at even the mental health systems that are unfortunately underdeveloped in those respective regions. So that's how the research has really informed, because I take those big ideas and make them more practical to look at the everyday behavior patterns and even thought patterns and why that's the case, and then how therefore to treat it. I hope that answers your question.
Yeah, absolutely. And I love how you said that they work together, like they both inform one another. So it sounds like, you know, the work that you're doing all around really fits with who you are as a person, and it all kind of has synergies together.
Yes.
So I'll just wait one more second to see it. No questions so far.
Okay.
So if we don't have any questions that come in the next minute or so, wondering how folks can get in touch with you. So if people have questions that they maybe didn't want to ask in this format, is there a way we can get in touch with you to ask our questions or spark ideas together?
Sure. I mean, they can always feel free to shoot me an email on my Waterloo email. I guess I can even type it in the chat. My Waterloo email, they can reach out to me via LinkedIn. You know, I mean, I'm also on Instagram. I use obviously my professional page. So if they are just having questions about, you know, the psychotherapy process and just questions there, they can always get in touch with me there, you know, at Global Mind Emancipation on Instagram. So I can type that in the chat thereafter, and that can be shared. So no questions here. They can feel free to share it there.
Okay, well, I'm seeing that actually 2 have come in. People wanted to make sure that they got their questions in, so this is great.
Great.
So the first comes from Carolyn Abramowitz on campus. Do you have any sense of whether legalization of cannabis has affected the nature or prevalence of psychotic symptoms?
I would say yes, in my opinion, because I think it has given young people, I think generally, not just Black youth, but I think young people generally almost this insidious pass that because things are legalized, now you can not only use it, but you can abuse it, right? And abuse it at a young age. I mean, the fact that I'm seeing, you know, 14 and 15-year-olds who are already vaping and already, you know, smoking spliffs and doing bongs at such a young age, and you weren't, in my opinion, weren't seeing as high of a prevalence of this occurring before the legalization. I think people have used it as a way of, you know, almost exercising that autonomy, and then unfortunately concurrently to cope with as an escape their respective mental illnesses. So it unfortunately increases the risk of experiencing psychotic disorders, in my opinion, starting at a younger age, because the abuse is beginning also at a younger age. So I think, yes, there is a possible correlation between the legalization of cannabis and, you know, the prevalence of psychotic disorders amongst young people. Great question. Thank you. I hope that answers it.
That definitely does, and we have another question along a similar vein. So it comes from Sarah Perosa. She says, "Great presentation. Has the link between cannabis use and psychosis diagnosis been scientifically proven? Has the link between acute stress disorder, PTSD, complex PTSD, and psychosis diagnosis been scientifically proven or explored?"
The answer to both of those is yes. They have been linked and they have been explored. You know, in my reference page, I have a couple articles. One, for instance, is Pathways to Cannabis, or Pathways of Cannabis to Psychosis, where they explore the association between cannabis usage, particularly the excessive usage, and psychosis, and the same thing in terms of cannabis to PTSD. You know, it's sometimes often, you know, the chicken or the egg, right? Did the PTSD come and then the cannabis use disorder, or did the cannabis use disorder because of the PTSD, right? So it is scientifically proven. There have been both neuroimaging studies as well as RCTs to explore this phenomenon, and so there is various studies to demonstrate the association. Now, the causality piece, as I mentioned, is still up for debate on whether or not cannabis causes these respective illnesses, but there is an association, and studies have demonstrated that.
Great. Well, it looks like that's those are the only two questions that were put in the chat. Wanted to really thank you for your time this morning, and I have a feeling that we'll be hearing much more from you in the future as you continue to do this really important work. And we're fortunate to have you as a PhD student here at the University of Waterloo. Thanks so much.
Thank you. All right, take good care.
Okay, so next up we have our next presenter, who is Danielle Fearon. Her presentation today is titled Characteristics of Emerging Adults with Trauma and Inpatient Mental Health. Danielle Fearon is a third-year PhD candidate in Public Health and Health Systems at the University of Waterloo. Her thesis focuses on patterns of substance use amongst individuals with traumatic life events receiving psychiatric services in Ontario. Danielle has an interest in the use of administrative data sets to assess health system utilization, quality, and performance. Prior to beginning the PhD program, she was an analyst at ISIS, where she strengthened her interest in statistics and SAS programming. Danielle also holds a master's in health studies and gerontology, a master of public health degree, both from the University of Waterloo. So another really great presentation for all of us this morning. Thanks, Danielle, for taking the time to be with us this morning and sharing your important work.
Great, thank you so much for having me. I'm delighted to be presenting today on emerging adults. So first, I just wanted to describe the sample that I'll be discussing. So emerging adults, the population of interest the typical age range is between 18 to 25. And this age group, and this group in general, is distinct from other groups because of some of the differences in terms of their life stage and their self-perception. This period is marked by a transition from childhood and to adulthood, and it's marked by certain things like financial independence and changes in one's living arrangements. We also see common disruptions during this time. So disruptions in terms of their psychological development that could be have a more pronounced effect during this time. So traumas that these individuals have experienced as children, as well as traumas that they're currently experiencing as adults, make these individuals more vulnerable to mental illness. So next we can talk a bit about traumatic life events. So increasingly we're recognizing that our experiences and exposure to trauma, so in this context I'm meaning stressful or harmful events, can have long-lasting impacts on our health. The impact of trauma can be subtle or it can be destructive, and how an individual interprets these events depends on their characteristics as well as some of the broader socio-cultural factors. When an individual is exposed to trauma, emotional responses are very common and normal. We also see delayed responses such as fatigue, sleep disorders, fear of the event reoccurring, as well as anxiety. Some possible examples of traumatic life events are on the slide. So directly witnessing or learning of an individual's exposure to serious injury, sexual violence, or threatened death. But I'll also be getting into a couple different more types of traumatic life events later on in this presentation. But for the purpose of this study, I'll be focusing specifically on underlying trauma that may or may not be diagnosed. If symptoms are persistent for an individual, things like emotional numbing, hyperarousal, and experiencing traumatic life events and functional impairments, a formal diagnosis like David just talked about, PTSD or ASD, might be made. So what's been done in this area? So some of the previous research on this topic has focused on the implications of trauma, things like community-based trauma or childhood trauma, as well as their relation to behavior. So criminal behavior, for example, self-injuries, substance use patterns. We've also seen a lot of focus on different populations. So children, adolescents, older adults. There's also been a focus on some of the psychological and biological symptoms associated with trauma among this specific group. As well, we've seen the use of self-report surveys or small sample sizes. However, the consequences of exposure to trauma in emerging adults still require some further investigation, which is one of the purposes of this study. So the key aim of this study is to present and summarize some of the common characteristics among inpatient samples of emerging adults with trauma. Specifically, some of this analysis sought to look at some of the baseline characteristics. So I focused on some of the demographic and social characteristics of emerging adults and how they differ from other adults aged 26 plus, as well as what types of trauma are common in emerging adults and how do these different types of trauma vary from other adult groups. In terms of the design of the study, I used a cross-sectional retrospective design. So I dichotomized age into two different groups, so 18 to 25 being the emerging adult group and 26 plus as being other adults. So any individual that had a first hospital psychiatric admission in Ontario was used for the study during the observational window of January 1st, 2015 to December 31st, 2019. And the key source of data here was OMERS, which is the Ontario Mental Health Reporting System. So this is a database that's held by KDE, the Canadian Institute for Health Information, and it's based on the RIMH, which is a standardized, which stands for Resident Assessment Instrument, Mental Health, MH. So this is a standardized assessment tool that's mandated for all inpatient psychiatry in Ontario. And the assessment tool is completed by a clinical staff person that's overseeing care of the individual. And it contains 396 different domains that relate to the individual's mental health status, their substance use behaviors, their physical and social health status. As a part of the RIMH tool, it also includes some comprehensive approaches to support care planning. So one of these is the clinical assessment protocols, so that's CAPS. So this is, these are not medical diagnoses. However, when they're triggered through algorithms, they highlight some of the clinical issues for individuals. So the one that I'm focusing on specifically as the outcome variable in my study was traumatic life events CAP. So there's three different levels of this CAP, the first being not triggered. So these would be individuals who have not experienced traumatic life events or have, but have not had stressful enough events to trigger the CAP. And the second level is triggered. So there's prior traumatic events as well as immediate safety concerns. So prior traumatic events is more of a historical trauma. So these are individuals who have experienced one or more traumatic events. As well as the immediate safety concerns are individuals who are in current immediate danger due to their current abuse. So now I'll get into some of the results of this study. So this is just a general graph here of the characteristics of all inpatient psychiatric admissions during my observational window of 2015 to 2019. And all these inpatient admissions are stratified by age and sex. So for most age groups, we see that males are slightly more likely to be admitted than females. And the average age of all inpatient psychiatric admissions during the observational window was 44. As well, we see 52% of admissions were male. So if we just focus in specifically on the emerging adults group, the average age of admission was 20.73 and approximately 54% of admissions were male. So this next graph highlights the frequency of trauma among psychiatric admissions, and it takes into consideration some of those age and sex-related differences that I presented on the last slide. So each column, how you interpret this, is that each column represents the total percentage of trauma per age group. So for individuals in the emerging adults group, that 18 to 25 age range, we see 25% of all admissions have traumatic life events enough to trigger the CAP. And of these, 15% are female and 9% are male. And for the next column, we see approximately 39% of adults in that 26 to 45 age range as presenting trauma. And of those, 22% were female and 17% were male. So one thing that's interesting to note here is that although I just presented in the last slide that we see more inpatient male admissions, more females, which is presented in this slide, present trauma, which is interesting to note here. So now I'm just going to focus in a bit more on just the emerging adults group. So this slide presents some of the characteristics of emerging adult inpatient admissions. So at admission, so there's two different graphs here. So the first one just looks at some of the baseline characteristics, and the second one looks at some of the primary diagnoses of these emerging adults when they are admitted. So at admission, we see 16% of emerging adults as living alone. We see 70% as being either unemployed or having an unknown employment status at their time of admission. We see that this was a highly educated sample, so 46% had at least high school education. And so the second graph is focusing on those primary diagnoses. So when I say primary diagnosis, I'm referring to the main diagnosis or condition that had the main responsibility at their admission time. So noting that an individual may have a secondary or other diagnosis as well. So the highest category that we see here in terms of this group was mood disorders. And so I clustered both bipolar disorders and depressive disorders for this group, and so 39% presented mood disorder at admission, as well as schizophrenia was the second highest there with 17%, and substance use disorders as the third most likely. So as I discussed previously, those clinical assessment protocols are very important to guide care planning. So this just presents some of the other concerns or care needs for these emerging adults who reported trauma. So it's really interesting to note here that 74% of emerging adults had challenges with their social relationships, with some of those broader social relationships, as well 66% were at risk of self-harm. And some of the other factors here that I highlight are risk of harm to others, challenges with finances, and support systems at discharge. Okay, so this next graph is a radar graph. So this presents some of the types of trauma emerging adults presented in their inpatient admission. So it's to interpret this graph, what you need to look at is basically how close that bullet is to the outer circle. So that highlights the greater likelihood of someone experiencing a type of trauma. And I'm depending on your screen, it might be a bit small, so I'll just go over the different types of possible traumas experienced, starting from the top and going clockwise. So the first one is child-related traumas. So it's, for example, custody challenges or adoption issues. The next one is death of a close family or friend. Then distress about others' health, economic hardship, poverty, failing or dropping out of school, immigration or refugee status, living in a war zone or violence area, parental abusive substances, problematic or severed relationships, then review hearing, serious accident or impairment, and then victim of crime, excluding assault, victim of emotional abuse, victim of sexual assault, victim of physical assault, and witnessing severe disasters. So it's interesting to note in this one is that the most common form of trauma for emerging adults was emotional abuse, and that was approximately 25% of this inpatient sample, or just over 2,600. And secondly, having a parent with abusive substances was the second most likely with 18%, and then failing or dropping out of school with 16%. So now I was just comparing the traumatic life events experienced by emerging adults to adults over the age of 26. So adults over the age of 26 here are in orange, so you can kind of compare and see some of the differences in terms of the traumas they experience. So it's kind of interesting to see how, as an individual ages, a variety of life events accumulate to create trauma in their lives. So for adults over the age of 26, 10% had experienced the death of a close family member or friend, whereas only 5% at that time of emerging adults had experienced this. We also see some very expected changes. So things like the influence of refugee or immigration status as being more common in other adults, the stronger influence of severed relationships or divorces, and economic hardships as well. But what I really want to draw your attention to here is failing or dropping out of school. So it's interesting here that 16% of emerging adults that were hospitalized reported failing or dropping out of school as a traumatic event, whereas only we see 6% of other adults reporting this trauma. So this comparison provides some meaningful parallels to our campus environment. So if not addressed, failing or dropping out of school can be a very traumatic experience for emerging adults. And similarly, we also see emotional abuse as being prominent for both emerging adults with 25% and as well as other adults over 26. So approximately 19% there in other adults. So some of the purposes of this study were just to highlight some of the differences we see between emerging adults and other adult groups. So we saw more males in emerging adult admissions in comparison to other adult ranges. We also saw that it was common to have mood disorders as a primary diagnosis. Emotional and parental abuse of substances were key triggers for traumatic life events in our inpatient admission sample. As well, failing or dropping out of school was a very traumatic event for emerging adults. So these results reinforce the need for more targeted interventions. Just as an example, we can think about more identification of students struggling and support those that are experiencing abuse. As well, the results highlight key areas for priority of harm reduction strategies. Thanks so much for listening.
Danielle, thank you so much. That was very informative and very interesting, and I really like the slides looking at the difference between emerging adults and other adults and some of those distinct differences and how your research is really important to students, the student population, as being successful in school is definitely a protective factor for students. Great. So I'll just wait and see if any questions emerge. I have one, but I don't want to start us off if there's another one that comes up in the Q&A. Well, maybe while I'm waiting to see if others come, and you might have said it in your introductory slides, but I am wondering, because you looked at sort of the prevalence with male and female, and many of our students identify as non-binary, and I wondered if there was any differences noted with individuals who identify as non-binary in some of the studies that you looked at.
So not necessarily in some of the studies I looked at, as well as in how the data set is clustered. We separate it into like individuals who identify as non-binary are grouped into generally female versus male. So that's just an interesting stratification and something that really needs to be considered as well. We can definitely pull that group out and see some of the differences that they experience.
Okay, great. Thanks for answering that. So I do have a question that came in. It's from Jillian Watkins, and it says, great presentation. When comparing emerging adults and adults over age 26, were you able to look at when the traumatic life event occurred and whether there were differences between the groups?
Yeah, so for the purpose of this study, I clustered them into either a trauma or no trauma, but generally speaking, we look at trauma in 3 different levels. So that second level of prior traumatic events would kind of highlight whether if an issue is historical, if it happened prior to their admission, or if it's a current abuse. So including that strata does highlight some of the differences in terms of the traumas we see. For the purpose of the subsample, I used a smaller stratification, but you can definitely see some of the differences, and we definitely see a lot of more prominent concerns, especially among the immediate safety concern group.
Great, thank you. And we have another question that's come forth from Jerica Little. What types of longitudinal trends and outcomes would you be interested in exploring next for emerging adults with trauma after their initial admission to hospital?
Yeah, so this study is kind of like a sub-study of what I'm actually focusing on. So what I'm really focusing on is patterns of substance use among individuals with trauma. So that's something I probably would be very interested in applying also to different age strata, because I think it's very interesting to see how those patterns of substance use change depending on the age group. So that's something I'd be focusing on in a bit more longitudinal context.
Great, thank you. And another question's come forward as well. Do you have a sense of whether the school problems dropout occurred before and possibly led to mental health trauma symptoms, or whether the school problems were due to mental health and trauma symptoms? And this comes from Carolyn Abramowitz.
Yeah, that's such an interesting question, and it's really hard to determine because so when I look at the different factors of trauma, like I presented in that radar graph, really it's not just one of the traumas that is contributing to the individual being there. I'm sure for some individuals it may be, but what we generally see is a composite measure, like accumulation of all those traumatic events as causing the individual to be there. So not just failing or dropping out of school. I think what it's important to note here is that that was a key aspect or a key association with emerging adults and among the population, but it's just a part of the overall trauma that these individuals are experiencing. So for example, like we might see an individual that failed or dropped out of school also as having difficult parental situations as well, or emotional challenges as well. So yeah, it's a very interesting question, and we can definitely stratify it and see if there's even more associations there, but I do think it's more of a composite definition of trauma.
Great, well, I don't see any other questions that have come forward. So Danielle, I really want to thank you for all your very important research that you're doing, and I hope that we'll hear from you again in the future. It'd be great to hear where you go from here and some of your other findings that you have going forward. So thank you very much.
Thanks so much, appreciate it.
So now I'd like to pass things on to our next moderator of the day, Kalpita Gaitonde. Welcome, Kalpita.
Good morning, Sherry. Thank you. So yes, I will carry on from here. Just to introduce myself, my name is Kalpita Gaitonde. I work as a health promotion and evaluation specialist within Campus Wellness, and my pronouns are she and her. And as Sherry said, I will be taking over from Sherry right now, and then I'll be, introducing the next two speakers, and we'll go from there. And to start off with then, right now, what we have the next presentation that is coming up is called The Prevalence of Anxiety Amongst University Students During COVID-19. And the presenter is Shefali Liyanage. And is Shefali online right now? Do I see her online?
Yes.
Hi. Wonderful. Nice to see you, Shefali. Welcome.
Nice to see you.
How are you doing today?
I'm well. I'm doing well. How are you?
Yeah, I'm good. And I'll just introduce Shefali to all of you, and then I'll hand it over to her to present her slides and to go on from there. Shefali Liyanage is a former undergraduate student in health studies, and she's interested in quantitative approaches to health research. Specifically, the article she'll be discussing today is focused on undergraduate student mental health, especially during the pandemic. And this was also her thesis topic during her final year, which also interestingly happened during the pandemic. And so Shefali is very interested in health disparities, research related to health disparities amongst minority communities, South Asian healthcare, mental health, and cannabis research. So I'm going to hand this over to Shefali now. So Shefali, welcome, and go ahead and please share your slides, and we'll go on from there. Thank you.
Okay, so hi everyone. Thanks so much for being here. My name is Shefali, and today I'll be discussing my article, which looks at the prevalence of anxiety amongst university students during the COVID-19 pandemic. So before we actually get into the actual paper itself, I wanted to do a brief introduction, kind of looking at the mental health of students during the pandemic or prior to the pandemic, and seeing what that looked like before COVID-19 actually affected that. So mental health amongst university students has been on the rise, and this has occurred since about the 70s, but there has been an especially high increase or a fast increase since 2010. And this can be explained by a multitude of factors. One being that this is a transitional period between young people from adolescence to adulthood, and this is occurring around the same time that many students are entering higher education institutions. The probability also of psychological disorders presenting, like depression, anxiety, and stress, also occurs around the same age period, which is usually between the ages of 18 to 24 and 25. Some other factors would include academic stress, which arises from feelings of uncertainty regarding uncertainty in education, plans, examination fears, language problems, lecture schedulings, meeting deadlines, and time management, et cetera, et cetera. Then there's workload, the feeling that once a student doesn't have time to relax because their time is consumed by academic scheduling, and family expectations, which can be based on a numerous amount of cultural, financial, and personal stressors. Family members within this case usually put a lot of pressure on their students to perform a certain way so that their potential future is successful. And overall, there is this overarching fear that a student is not able to satisfy their parents' wishes. Then there is career expectations. So this is coming from the uncertainty that the academic path that a student has chosen either will be successful and positively impact their career or negatively impact their career plans. And then there's finances. Not only is it now expensive to be in school as a student, but on top of that, it is expensive to just live as a person in society. And so there are many different finances students are either having to juggle with or are just learning to mediate. Okay, so why are people paying attention now? So interest in the well-being and mental health of this population has become popular in the last few decades due to three main challenges. And this is information taken from a literature map that has looked at studies that were published between 1975 and 2020. So these three challenges include: one, an increase in the severity of mental health problems and help-seeking behaviors in students globally in the last decade, showcasing that there is an emerging mental health crisis in higher education. Then there is a psychological distress as a result, which in early adulthood especially is associated with adverse short-term and long-term outcomes. So some short-term outcomes would include poor school attendance, performance, engagement and completion of program, as well as university dropout. And this in turn will affect long-term outcomes like employment rate, result in reduced personal income, cause dysfunctional relationships, and also create recurrent mental health problems in these individuals. What's interesting is that higher education institutions actually offer a setting that really integrates academic, professional, and social activities, which are promoted alongside health and other support services. So in theory, this provides a unique opportunity to promote mental health and well-being, especially to a population that year by year, it has increased risk. However, as universities continue to expand, these social supports and these mental health services are not developing at an equivalent rate. So now let's look at COVID-19 and what that meant for students. So when COVID was announced, measures of shutdowns and closures were taken place to reduce transmission. And the effect that this has on students included the closing of many higher education institutions due to them being non-essential. So the closing of universities especially affected students' social networks. It reduced social interactions. There was a lack of social supports, and classes were changed from an academic in-person setting to online. There was also a loss of additional services and support offered through universities, as well as personal finance issues, especially for students who had student jobs within the university that were non-essential. And within the general population, psychological distress was increasing and well-being was decreasing. So we can assume that this is similar, if not heightened, in an at-risk population like students. Early articles that took data from the start of the lockdowns also discussed the additional stress that students were feeling due to large changes in their daily lives, being that they're living as a person through the pandemic while also being a student in higher education. So let's finally take a look at the article. So the premise of our study looked at understanding the prevalence of anxiety amongst university students globally during the COVID-19 pandemic. And so we performed a systematic review, which was done by myself. And then I also worked with my co-author, Kiran Saqib, who's a PhD student, and she performed the meta-analysis on our outcome. And the search period of our article data was taken from September 2020 to February 2021. So this is kind of the first year from the pandemic starting that students would be in school, especially in higher education, myself included. So within the study, after data extraction and full text screening, we had a total sample of 36 studies that were used for the final result. All studies were cross-sectional. All studies had a sample population of university students. And within the studies, about 8 different assessment tools of anxiety were used. Okay, so it's time to finally look at the results. What did we actually get? So the summary prevalence of anxiety estimate was found to be 41%, and this ranged between 11 to 89%. We also did a subgroup analysis that looked at region as well as gender-based analysis, and we found that the US had the highest prevalence region-wide, and that women had the higher prevalence within gender. However, it should be accounted for that the results of the regional summaries of anxiety might be biased due to large amounts of literature coming from China and Western countries that were first hit by the pandemic, and this contributed to the majority of data collected, as scientific articles on mental health were pretty limited during the early months of the pandemic, especially in comparison to the amount of data or literature that was being published about infectious disease and vaccines. When it came to the subgroup analysis in gender, it is seen as insignificant due to overlapping confidence intervals. And these results are actually conclusive with literature that I've read further on. So predictors of psychological distress do include the female gender, being a student, and poor physical health. However, I've looked at some studies that have said that when comparing anxiety rates between males and females, or men and women, they found that there was no significance between the rates. However, I did recently read a study that was published in 2021 that found that within the general population, women have a higher prevalence compared to men of anxiety, and this is found to be statistically significant. Okay, so let's look at the limitations of the study. So obviously, since our study used cross-sectional articles to create our data, there is going to be some bias, and you can see with the funnel plot, there was significant publication bias found. So the studies, because they were cross-sectional, the link between the outcome and exposure cannot be determined definitively, and this is because both are examined at the same time. Heterogeneity between the studies was significant, and this wasn't wholly accounted for during subgroup and sensitivity analysis, which suggests variability within the data, which is not necessarily a bad thing, but something to keep in mind. And there was also difficulty incorporating prevalence of anxiety when all the studies were using different assessment tools. All assessment tools have a different standard, and as a result, our result or our final value only relatively shows what the true value is. For future reference, there is a need to standardize an assessment tool of anxiety that can be used globally and in the context of different communities so that future reviewers could easily integrate the results. There was also a lack of data in subgroup analysis, so we cannot conclude definitively that there is a difference between regions or based on sex or gender. And especially with the sex and gender subgroup analysis, we found that we were only able to use 17 out of the 36 included studies. Okay, so the results overall showcase that the effect of the pandemic seems to have exacerbated psychological distress amongst university students. But many universities are developing or have developed numerous strategies and interventions already to support their students. So the question becomes, are these strategies actually effective? So from a systematic review that I looked at from 2019, so prior to the pandemic, that examined effective prevention programs targeting depression, anxiety, and stress in students, they found that the common elements of interventions for students used psychoeducation, relaxation, cognitive monitoring, and cognitive restructuring. And regardless of delivery format or prevention level, the results showed a moderate effect. And the results from this article did state that the ability to actually measure program efficacy was limited by a few factors, being 3. So the one was a symptom target outcome mismatches, where these are programs where patients have their most distressing symptom identified, but in reality, the symptom wasn't always properly identified. There was also disproportionately a more female sample, which is consistent with male reporting and female reporting of mental health, especially with seeking mental health outcomes or interventions. And there was also inconsistent reporting of adherence data. So if the data was self-reported, it would be inconsistent with reporting whether they were actually going through with the intervention or follow-ups were not regular or they were missed. So regardless of all of this, it does seem to show that we are delivering interventions that have a moderate level of effect. So what else could be the issue? Maybe instead we need to focus on the timeline of which these interventions occur for a student's well-being. And as always, it's important to note that early identification of mental disorders like anxiety is very vital in preventing further or more progressed illnesses of mental illness, and early intervention methods should be prioritized. But maybe there is another factor at play. So I looked at another article, another review that was published in 2021, so more recent, that looked at student mental health interventions. And it discussed how we already have enough literary evidence to link personal and academic stressors to mental health. So we have enough actual information connecting this. So what if instead we actually looked at the setting in which these outcomes take place? And that would start by looking at the culture of academia within higher education institutions. So like in the past, universities today have a maintenance of a standard of academic excellence. And this is meant to be a competitive way, a healthy competitive way, theoretically, to push students to achieve the best that they can while also doing that within their limits or within their means. However, this has kind of shifted to an extreme where there is now this development of a very high stake environment that is meant to prepare students to be part of the global economy, but in turn is changing the context in which higher education institutions function today. And this is in turn done to change the priorities, or it does cause changes in the priorities that students focus on when trying to uphold this standard. So rather than focusing on intrinsic factors of academic success, like for example, innovative learning or expansion of lateral thinking, instead students are becoming very fixated on extrinsic factors like results, GPAs, overall grades, scores, et cetera, et cetera. And as a result, in the pursuit of this academic excellence, students are ignoring social, emotional, and psychological problems that are emerging. And this just causes negative coping mechanisms to manifest. So the question becomes, what do we do to change that? We cannot obviously change the pace of the world. So instead, we could focus on providing services that reduce the adverse outcomes, so harm reduction. But on the other side, we are also accepting that the only way students can succeed is by literally putting themselves through the ringer, by putting themselves to the absolute extreme in order to get to that level of success. Not the most positive note to end on, but I thought it was interesting. But yeah, thank you very much.
Thank you, Shefali. That was interesting for sure. Thank you for presenting this research. And I'm going to take a look at whether we have any questions as yet. But I would also be curious to know, I know at some point you did mention how the culture, academic culture, is also impacting or has impacted anxiety among students. And that's a perpetual thing that happens. And one of the things you just mentioned is, you know, one way to kind of mitigate those effects is to provide services similar to harm reduction. Any idea on or any further readings on what these kind of services could be?
I think that a lot of services are already in place, especially like in the context of the University of Waterloo. So I was lucky that while I was in school, I also worked as a resident don. And so I was pretty familiar with the services that the university offered, and the counseling services that they offered, as well as support services through student groups and mentoring, were actually effective in helping students create a sense of community. But the issue arises that regardless of those services being there, there is still this overarching idea that students have that they just need to be successful and they need to push themselves to the absolute limit to. And like, it's hard for me to ignore and say like the University of Waterloo is not like that, because they definitely are. It's one of the reasons why I went to school to Waterloo, is because I knew it was very academically focused. But it also has its negative ramifications, right? So there is this balance. And I don't think necessarily that Waterloo specifically is bad for creating this environment, because now being in the real world, there aren't many people who push themselves to get to where they want. But at the same time, there is a limit. So it very much is like it's like this constant struggle there. So yeah.
Absolutely. And thank you for that response. And I do have one or two other questions, but I do see some of the questions have come up in the chat. So we're going to tackle those first.
Okay.
And so here, the first one is from Leveron. Sorry if I'm mispronouncing your name. How does a student's culture impact their anxiety, or can it? Is anxiety manifested differently based on culture, race?
I think it's just added stressors. So if you come from a culture or a background that there is almost this historic understanding that you have to maintain a level of success, or there is a certain standard that you have to maintain, then you're definitely going to experience that. And that is found more, especially in East and South Asian communities, mainly due to a lot of factors. One being issues with trying to succeed in your countries, coming to a country like Canada and wanting to maintain and secure your finances and your, your future, especially in your children. There's also coming from countries that are more disenfranchised and feeling this almost stress to want to pursue further and to make sure that you succeed later on. So if you come from, or if your family comes from areas like this, you'll feel this stress to satisfy this need. And the article that I specifically referenced in the actual presentation comes from South Asia, specifically India. So a lot of the students within that article discussed feeling that they weren't able to satisfy their parents' wishes, which were all about making sure that they had a good life, because they came either from backgrounds where they had lower income, they were in poverty, and if finances was a really big stress in the family, then it was something that they stressed about as well and made as a motivator to pursue higher education to the limit that they were getting really frustrated. Hope that answers your question.
Yeah, and yes, then definitely, to answer Lauren's question, it was basically to do with, how even being immigrant students impact your anxiety, just, the financial implications of not succeeding. That is also a huge stressor. So thank you, Shefali. And Jillian Watkins is asking, well, first of all, she thanks you for sharing your paper with all of us. And the question goes, you mentioned that comparisons across countries would be improved if there was a global tool to measure anxiety. However, do you think a global tool would be successful given cultural differences in experiences of anxiety?
I think that's a very good question. When measuring anxiety globally, especially with the type of studies that we had access to, I think that's why there was a limitation with like validity or even with actually finding the true value, because at the time during COVID, a lot of the studies we saw that were being published were done at a very fast rate to try to get the information out there. And it was mainly cross-sectional surveys with little quality assessment, or the quality assessment was not that good based on the JBI checklist that we used. So we thought that it would be more effective if in situations like that, there was actually a standardized tool that people could use, so someone could create a global prevalence. But it has to also, like you said, take into account the cultural factors that influence that. So that, I think maybe that's a focus more for qualitative, or maybe to, like, that is kind of something maybe outside of my realm, but it can be difficult to incorporate the two into one. Otherwise, it would be pretty subjective. But there should be, I don't know, it's a very hard question for me to answer because I'm not really too sure. But I think qualitative research is important in helping specifically understand the themes in which someone is experiencing those cultural effects and how serious they are. So I think that would probably be more insightful.
Okay, wonderful. Thank you, Shefali. I don't see any other questions that have come up. What I would also be curious to know is whether you've come across any other articles post-pandemic. So, we still do have COVID cases coming up, but we're not in lockdown anymore. But so after the lockdown and ever since things have opened up, have you come across any article that measures, changes in prevalence of anxiety amongst our students, given the fact that during the pandemic, some of the stressors were different, but then post-pandemic, now students now suddenly, after universities and colleges have opened up and students have to scramble to find housing, and there's a housing crisis right now happening, there's a food crisis happening, access and availability of food sometimes is a huge issue, access to safe housing is an issue. So have you come across any kind of studies that have changed, that have measured any changes in prevalence of anxiety? Just the stressors might be different, I'm not sure, but just curious to know.
I don't think I've specifically seen ones that look at anxiety, but rather stress disorder and depression. Also because like stress, anxiety, and depression all kind of come as comorbidities when looking at mental health, especially amongst university students. And it is more symptom based. So like you can say that you have anxiety symptoms, but would you be diagnosed with a disorder? There is a lot of that as well. Let's see, I do know that I've seen some articles that have discussed the stressors in which, like, coming out of the pandemic, the kind of anxiety to go back to school has been another fear. And then also there is obviously like less of a fear of dying or of getting ill from COVID-19, especially since things are more open now. But like you said, there are still those added stressors of finding housing, being able to go back to school and get an education. So I haven't really seen anything specifically for anxiety, but I have noticed that those are things I've seen in my readings. Yeah.
Yeah, wonderful. And you did also talk about the academic culture. I know we kind of referred to that earlier as well. But again, I would also be curious to know, has there the fact that there is so much anxiety and stress among students, has that contributed to any changes in the way academic institutions are looking at their own culture of, and propagating the more of the extrinsic factors of success than the intrinsic factors? And so again, have you come across any studies or any of your readings that talk about changes in culture, knowing the stressors during the pandemic as well as post-pandemic?
I think I've seen it more anecdotally, to be honest, because I have been a student going through that. So like, sorry, could you like explain a bit more of the question again? I completely forgot.
Yeah, that's okay. I mean, again, just a curious factor that, the pandemic has highlighted the inequities in education. It is just basically the inequities were already there. There were, certain students from equity deserving groups, people who weren't able to get into post-secondary institutions. Those inequities were already there. There were inequities in terms of finance, in terms of access to education. The pandemic basically highlighted those, and
extremely, yes.
Right, and so the anxiety amongst students during the pandemic was, of course, highlighted due to several factors. But then when you in your studies, you also kind of talked about how the academic culture basically was highlighted in, given that this anxiety was so much there, that the academic cultures were highlighted, and then people just kind of took a look at, well, what's happening in these academic institutions that's also increasing some of the anxiety. So I'm curious to know whether these studies that have been studies to focus on changes in these cultures in academic institutions.
Yeah, okay, so now I remember. So what I was thinking was that a lot of students are now trying to see whether or not they're actually pursuing programs or areas of interest that they actually care about. And I've seen this more anecdotally than I have like in studies, because I've just spoken with enough students that they're telling me now that they are not sure that what they're pursuing is what they want to pursue. And I think that comes a lot with initially before the pandemic, we were all kind of in this go, go, go kind of mentality to continue forward and to produce a level of success that we all kind of were desiring. But with the pandemic and it shutting down a lot of different services, as well as shutting down pretty much society itself for some time, people were able to look more intrinsically on what they actually felt that they wanted. And so I've been seeing a lot of people transition within careers, especially even with where I'm working now. I've seen a lot of people move away from fields that they were in to pursue other fields due to not feeling like that was something that they actually wanted to do. So I think that the pandemic actually made a lot of people realize that they weren't actually like doing things for themselves. They were following extrinsic values to produce hopefully a proper result. But if we are all following that same path, then are we all going to get that same amount of success? The answer is probably going to be no. So I think we're all realizing that this is something that we have to look inwards and ask ourselves, what are we willing to push ourselves to do? Because we're not going to stop this culture, especially within the economy, of going as far as we can. And because we live in a Western country, capitalism is a really big thing. So making money is very important. But looking at how people are now understanding how they can make money is becoming a new interest. So, yeah.
Yes. Wonderful. Thank you so much for all your insights and for presenting such a wonderful article for everyone. So we thank you for coming here today, and we do hope to see you in the future sometime, just to also hear more about what you would be engaged in, what kind of research you'd be engaged in, and all the best for your future. So thank you
so much. Have a good day.
You have a good day too. So again, welcome here, and I'm just going to give a bit of an introduction about Laura today, and we'll go on from there. So the topic of today's presentation by Laura is Pandemic Pressures, Examining Nuances in Parent, Child, and Family Wellbeing Concerns During COVID-19 in a Canadian Sample. And so Laura Colucci will be presenting her research on this particular topic today. Laura is a second-year PhD student in the clinical psychology program at the University of Waterloo, working with Dr. Dylan Brown in the Whole Family Lab. Her research interests include studying psychopathology and well-being from a family systems lens across individual and family-wide levels of analysis. Prior to completing her Master of Arts at the University of Waterloo, she received her Honours Bachelor of Science degree from the University of Toronto in the Specialist Psychology Co-op program, where she gained experience working in several institutions, including the Hospital of Sick Children, for Sick Children, and the Center for Addiction and Mental Health. So I'm glad we have you today, Laura, to share your experiences as well as your research. And so I'm handing it over to you, and please present your slides and we'll go on from there. Thank you.
Perfect. Thank you so much for that wonderful introduction. Let me just share my slides here. Can you see my slides okay?
Yes, I can see them.
Okay, lovely. And it's on full screen mode?
Yes, it is in the presenter mode.
Okay, wonderful. Thank you so much. So as mentioned, my name is Laura. Thank you so much for attending this presentation. And today I'll be talking about a project I conducted with a couple of researchers from my lab titled Parenting and Pandemic Pressures, Examining Nuances in Parent, Child, and Family Wellbeing Concerns During COVID-19 in a Canadian Sample. So I have three objectives for this presentation. First, I'm going to discuss current literature on what we know about how COVID-19 has impacted children, parents, and families. And then I'll talk about how I explore that a little bit more thoroughly with the Statistics Canada data set and looked into what concerns parents were having for their children and family during the early first wave of the COVID-19 pandemic. And lastly, and most excitingly, I'll share some results and discuss implications for public policy and as they relate to social determinants of health. So understanding how are Canadians impacted in the early kind of first couple of months of COVID-19, and what does that mean for us going forward and for research as well. So just jumping into the literature a little bit, we know lots of research has told us that parents and families were really negatively impacted by COVID-19. This looked different for many families, but there was also a lot of common factors, things like changes in routine, mental health disruptions, scares for physical health, vaccines hadn't come out yet. Everyone was juggling loss of hours, shifts in their work schedule, and it was kind of a season where everything was in flux and there was a lot of fear, a lot of threats external to us. And we all had to really rapidly respond, including parents who had to homeschool children, manage childcare, and also demanding work situations as well. And so what we know a little bit less about from the pandemic is how stress at different levels of the family system interact with one another. And I'll unpack that more in just a little bit. And the second thing that we don't know as much is how socio-demographic factors, things like income or job loss during the pandemic, really impacted the family, though several models of research have been proposed. So family systems theory tells us that families are systems. There's multiple interacting parts. We have children, the sibling dynamic, the parent-child dynamic, the parent well-being, and also the whole family, so that families are greater than the sum of their parts. They're more than just a number of individuals, but something that really comes together when all the members are there in tandem. And so family systems theory proposes that children, parents, and the whole family are almost like these three hierarchical levels of family functioning that interact much like gears, in the sense that they're reciprocal and bidirectional. They're constantly changing, and that interaction goes both ways. And so the family stress model, another theory of family functioning, supports that economic stress really has a negative impact on everyone in the family, and we saw this throughout COVID-19. The family stress model can also be applied to things like pandemic-related or environmental disruptions. It's been applied within the context of recovery from Hurricane Katrina, mental health stress, economic stress. So really, when families are under a burden, this is where that family stress model proposes that parent mental health might be negatively impacted, and that can make parents less sensitive to their children, leading to a less positive family environment, and can negatively impact really everyone in the family as a whole, not by anyone's fault, but simply by the burden of having to carry those stressors, particularly for parents. And so this is kind of where my research questions came in for this study. I wanted to know, if we look at all those levels of the family system, are there different ways that that stress is showing up across children, parents, and the whole family, and how so, and what does that mean? And so I had two primary research questions. The first, what is the relationship between caregivers' concerns with their own parenting, their children's well-being, and their family well-being during the early waves of the pandemic? So did those systems and levels of the family interact? Were concerns bidirectional? And secondly, how do those economic factors from the family stress model, things like job loss, parent education, child disability, parent sex, some of these influx and some of these more individual factors like parent education that are more stable, how do those things, those sociodemographic variables, social determinants of health, relate to how concerned parents were for those levels of the family system during the COVID-19 pandemic? And so Statistics Canada actually collected some data on this in the early first wave of the pandemic from the Parenting During COVID-19 crowdsourcing data set. So they asked 32,000 parents of children under the age of 15 how concerned they were about their family. And this happened in June 2020. So just for a bit of a timeline here, our first cases in Canada of COVID-19, when we first started hearing about it, was in that early winter period. When March 2020 hit, we had school and workplace closures, and then data collection started happening for this study in June. So it happened within a 30-day period, and we weren't where we are present day. So back then we didn't have masking. We weren't well experienced at what to do during a pandemic. We were still in the early waves of school closures and parents homeschooling children, and lots of workplace disruption as well. The weather was nicer here in Canada and Ontario, so we'd opened up some of our lockdown restrictions, but it's very probable that parents were still reeling from several months of pandemic-related adjustments, if you will. And so the demographics of our sample were mainly mothers. So we had about 10% fathers in our 32,000 families here. After accounting for missing data, it was about 27,000, but still a really substantial sample. Most of these parents had attended university and did not have children with disabilities, so there was some variance and heterogeneity in this sample. 40% of parents had experienced job loss or reduced hours to their employment. And really interestingly, Statistics Canada also surveyed parents about the employment structure of what things look like at home. So were all adults working inside the home? And that was about half of this sample. Were all adults working outside the home, which was about 15%? Or were adults working in kind of this mixed structure, which was about 35% of this sample? So the main construct of interest, or the most exciting part, was they asked parents, due to the COVID-19 pandemic, how concerned are you about the following for your child or children aged 0 to 14 years? So reporting on all children at once, from 1, not at all, to 4, extremely. And they asked them about all sorts of different areas of concern. So balancing childcare, physical health, mental health, feeling lonely in your own home, staying connected to children, friends and family, having less patience with your children. It's really kind of a nice motley of family variables here. And what I did was I imposed kind of the constraints of the family systems theory onto these constructs and categorized them into 3 different levels, and then wanted to map out statistically, does this work? Does this framework hold when we're looking at pandemic-related disruption with a family systems lens? And so if we just look at some statistical demographics here, or descriptives here of how concerned parents were, remembering that this was a 1 to 4 scale, we can see that parents were rating on average 2, 2.5. So on the lower end of concerns, but some of the concerns that they reported most strongly were concerns for child socialization, balancing work and childcare, and also managing children's behaviors. And really interestingly, the lowest kind of mean concern here were for children's health. That's interesting, given that at that time we knew that children were less susceptible to COVID-19 infection risk, but certainly children were really susceptible to other kinds of pandemic-related disruption. So when I modeled this statistically, I used confirmatory factor analysis in RStudio with the Lavon package. And this picture is just depicting that statistically things came out as predicted. So those hierarchical levels appear to hold it. Child concerns could be made up of the factor structure of children's physical health, mental health, loneliness, opportunities for socializing, and academic success. The parenting concerns were composed of balancing childcare, schooling, and work, having less patience with children, and managing children's behavior. And then lastly, those family-wide concerns for the whole family, that big picture piece that's greater than the sum of its parts. Staying connected to friends and family, feeling lonely in our own home, and getting along and supporting each other. So this figure just depicts that those things hung together within these levels. And then interestingly, research question number 1 was answered that there was actually bidirectional interaction between child, parent, and family-wide concerns across the board for the entire family. So the more concerned that parents were, the more concerns that parents made about children, they also had higher parenting and family concerns and vice versa across the family. And so next, I wanted to see what happened when I added in those social determinants of health that I was talking about. How do things like parent sex, parent education, experiencing employment loss or reduced hours, that family employment structure, or children's disability status affect how many concerns parents reported across the family system? And the FIT statistics were excellent here as well within the recommended parameters. And so I'll let you in onto those results as well. So specific to parent sex, really interestingly, across all 3 areas of concern, there were no significant sex differences. So mothers and fathers were reporting the same level of concern across all 3 levels of the family system. There we go. For parent education, interestingly, parents who had not attended university reported a higher level of concern for both child well-being and family well-being during this time in June 2020, with non-significant differences for parent-specific concerns for those parenting pieces. And that similar pattern was found for parents who had experienced job loss or reduction of work hours, really seeing these 2 players of concern for child well-being and concern for everyone in the family all at once, and kind of fewer concerns or non-significant differences for parenting ability during this time related to job loss. Interestingly, for child disability, parents of a child with a disability, which was 16% of this sample or thereabouts, reported higher concerns across the board. So higher concerns for their children's health, well-being, school and academic success, higher concerns for being able to manage and balance children's behavior, and also for the whole family, everyone getting along and staying connected. So really emerging this picture that parents of children with disabilities may have been under more stress or just experiencing more subjective concern during this time. And then really interestingly, jumping into those employment structure differences as well, parents of families where everyone was working outside the home, so this could have included healthcare workers, reported greater concerns for family and child well-being compared to parents where adults were all working inside the home. They also reported more family concerns than parents in a mixed employment structure. And when I thought this through, I thought this made a lot of sense because that parenting concern variable is really about that close-up in vivo parenting at home, that one-on-one child interaction, balancing work and family, being able to manage child behaviors at home, concerns for things like potentially schoolwork or even children just not having supports outside of the home. Parents working inside the home would have had a much closer picture of that than parents of all adults, where all adults were working outside the home during this time. Similarly, parents where everyone is working inside the home or in a mixed employment structure, so some in, some out, reported more parenting concerns than families with all adults working outside the home, which fits with kind of our story of what parents might have been most concerned about given their environment. And in families where everyone is working inside the home, they reported more concerns for child well-being than in a mixed employment structure. So, bringing it all together, what do these results mean? They provide support for the family systems framework when studying families in the context of COVID-19. So coming back to those three hierarchical levels, family, parent, and child well-being, all of these things are separate and distinct levels of family kind of organization. And these results demonstrate that those things interact, which is really, it kind of reflects what we already intuitively know, that families are ongoing processes where we interact, we have interpersonal dynamics, and there's give and take. There's that reciprocity and bidirectionality of interactions over time. Secondly, we're also seeing some really unique trends in the stressors and sociodemographic factors that impact the level of concern that parents are reporting for their children and family during the COVID-19 pandemic. So we found differences in parents who'd experienced job loss, parent education, whether they were working inside or outside of the home, and also really interesting findings of higher concerns reported by parents of children with disabilities. So coming down to limitations and unique contributions of this work, we currently, unfortunately, didn't have any data available on parent mental health, and the data set was cross-sectional, so we don't know anything about change over time, and we can't make causal conclusions. Parents also reported across all children, so they weren't reporting on one child specifically, and this was done by probabilistic crowdsourcing, so it wasn't a random sample. However, these results do depict that we can model multiple layers of family well-being. They advance our knowledge related to family needs during the pandemic, and it also provides some more specificity about kind of not only what are parents concerned about, but how do those social determinants of health impact what parents are just concerned about. And we can't make causal conclusions, so these are certainly bidirectional associations, but certainly very informative and interesting nonetheless. And so lastly, and most interestingly, kind of what do these results mean for policy targets? And I kind of pulled out 4 ideas. One, that we really need ongoing availability of government funding for parents and families affected by job loss, because we've shown that that actually may be related to exacerbated child and family well-being concerns. Additionally, the need for increased availability and accessibility of parent and family mental health services to support well-being, even despite experiencing concerns during this stressful time. Relatedly, the need for enhanced social and financial supports for families of children with disabilities who have been a largely affected but maybe under-recognized group during this time. And lastly, continuing to prioritize research, exploring multiple levels of the family system all at once, and social determinants of health in that context. So thank you so much for your time and your questions that will follow. I'd like to thank Jackson Smith and Dr. Dylan Brown, my co-authors on this project from the Whole Family Lab, and also the Southwestern Ontario Data Research Centre at the University of Waterloo, which gave us access as students to the Statistics Canada dataset, which I'm very grateful to have been able to use for this project. So thank you so much for your attention, and that concludes my presentation.
Thank you, Laura. That was wonderful. Thanks for sharing a deeply thought out research here. I certainly do appreciate that myself. And I know that there's one question that has come up here in the chat, which says, where can I find a slideshow? Do you have any plans to share your slides?
I'd be happy to share them to you, and you can distribute to any of the audience members afterwards. I'm excitingly I submitted this for publication yesterday, so hopefully it'll be in print soon, but I can share the slides for sure.
Yeah, wonderful. I think you could be in touch with Grace after the conference, and
For sure.
and she'll be able to direct this to people who need it. So thank you again. And as we wait for other questions to pop in, one of the questions I would like to ask is, well, can you tell us a little bit more about the need for a family systems lens in child development research?
For sure. Thank you. Yeah, I think my master's work focused on family systems theory, and it was the first time that I really understood that families are just more than the sum of their parts. And a lot of research studies just those individual parts, those macro levels, like how do mothers interact with children? What is that attachment relationship? Or how is like family chaos or just like everyone all at once impacting family well-being? And what's important is that when you only study one element at a time, you miss those other sources of change or variability that are happening in the family system. And so the family systems lens allows us to kind of, I guess, control for sources of variance and look at all the pieces of the puzzle all together, which then provides a really beautiful mosaic that's reflective of how things are in real life and gives us this like zoomed out big picture perspective when conducting family research.
Yes, that's for sure. And I'm glad that you touched on some of the policy, the future for policy, because that was also going to be one of my questions is like, what do you see as some opportunities for public policy in terms of, family development and how would we proceed? But you've already touched on that, so thank you for that. But I'm curious to know, in those 4 suggestions that you had, do you already have research that indicates that there are some, some research, I'm sorry, not research, but is there funding provided towards the family systems lens and those kind of policy opportunities? Is there any research to indicate that this is already happening, at least one of those? Yeah.
Yeah, for sure. That's a really excellent question. So I'll kind of answer it in 2 parts. I know that there's tons of research being conducted on children's mental health. So Nicole Racine and colleagues have conducted just a huge meta-analysis showing that we're in a children's mental health crisis. So that research is really mobilizing kind of availability of children and family mental health supports during the pandemic. Secondly, our lab at the Whole Family Lab at the University of Waterloo prioritizes the family systems lens in our study designs. So this is something that you kind of have to think about when you're analyzing or thinking about how to conduct research, even before you start data collection, because you have to be thinking about those different levels. It was fantastic that Statistics Canada kind of asked these questions and it nicely fit into those categories, but it's kind of like, if you bring this mindset to your research, then it follows through in the findings and research questions that you're able to ask as well.
Absolutely, and it's also kind of alludes to the fact that it's almost like the language you use, even when we talk about mental health, the language you use determines the course of the kind of interventions that you would also come to have, right? So
Yes.
What you're saying is very true. If everybody gets attuned to using that family systems lens, then it kind of becomes a bit easier to follow through with the policy, the way policy would work and the way interventions would work for different families. For sure. So I'm very glad that you're doing this research, and I really thank you for that. I don't see any other questions that have popped up, but would be very curious to hear more. And then again, we hope to see you in the future, because if you're going to continue your research in this particular, in this particular realm, then I would be curious to know how this informs policy and what kind of changes to policies, programs, services have taken place depending on using this research, right? So that would be my curiosity for sure. So thank you again for being here. And if you have anything else that you wanted to add, feel free to add it right now, or then we can conclude our discussion for today.
Yeah, for sure. I'll just make a final comment, but I think what you mentioned is just the most exciting part. Like, we always hope that research changes real people's lives and translates, like, all the effort of the data collection and the heavy lifting of this research really moves to impact policy or impacts like families at home homeschooling their children, or like, like people, real people, right? And so I think that's definitely what we hope for. And it's my vision that the family systems work really synthesizes already existing research. There's been such amazing family work that's already been done, and this is kind of just a collection of all of that work together. So thank you so much. It's been such a privilege to present and chat with you as well. And thank you. I really appreciate it.
Okay, thank you for being here, and then we'll see you later.
Perfect. Take care. Have a great day.
Bye. Take care. Have a great day too. And I'm now going to hand over the moderation for the next presentation to Jillian Watkins. So Jillian, if you could take over.
Kavita.
Yeah, not a problem. Okay, over to you.
Wonderful. I really loved that comment, Laura, that the hope is that this research really affects real people. I think that says so much about like the theme of Thrive and of the work that we're trying to like really feature at this conference. So a great intro, and I'm really excited today to be introducing Niomi and Katie, who are joining us from the Knowledge Development and Exchange, or KDE Hub. Their presentation is entitled The Role of Health Equity in Mental Health Promotion, using the KDE Hub as an exemplar. So welcome, both of you. I hope you're both feeling well today. I'm going to just read their bios by way of introduction before I pass it on. So we'll start with Niomi. So Niomi Cherney holds experience in diverse fields, including the performing arts, where they have a BFA in contemporary dance, media, and performance from York University. Academic philosophy, where they have a PhD from the University of Toronto, and more recently, social work, where they have a Master's of Social Work. And Niomi has a lived experience of disability and chronic illness, and this experience is central to her passion for health equity focused work and her role as implementation manager at the Hub. In her work outside the Hub, Niomi is a writer and advocate living and working in Kitchener, Ontario, on the traditional territory of the Anishinaabe, Haudenosaunee, and Neutral Nations. So welcome, Niomi. And I'm also going to present Katie. Katie Cook holds a PhD in community psychology from Wilfrid Laurier University. Katie is a research and evaluation manager at the KDE Hub, and a course instructor in the Social Development Studies program at Renison University College. Their research interests include mental health promotion, bodily difference, social systems, and student thriving. Katie is a passionate community advocate who lives with their two cats in the Haldimand Tract, Kitchener, Ontario, on the traditional territory of the Anishinaabe, the Haudenosaunee, and Neutral Nations. So really excited to have you both here, excited about the opportunity to learn more about what's happening at the KDE Hub. I'm going to pass it on to both of you. Niomi and Katie are going to present for, I think it's 35 minutes, and then they're going to moderate their Q&A session at the end of their presentation. So thank you both.
Thanks, Jillian, for that warm welcome. I didn't realize that I was wearing the Thrive color. But so we're ready to start screen sharing. Is that all right? Give me 1 second here and we'll go ahead with that.
There we are. Okay, just making sure my mic's on. Yeah, we're good. So welcome everyone. I will just do a very brief introduction here because we've already been very introduced in a very lovely way. So Niomi and I have a presentation today about the role of health equity in mental health promotion, specifically highlighting the KDE Hub, where I am currently at Renison University College, as an exemplar of how these sort of concepts work together. So while Niomi and I are presenting today, and we've already been introduced and our roles described. What we're presenting is really a presentation of the work of the entire Hub Secretariat. So not just the two of us, but lots of different folks who collaborate down here. I say down here because we're in the basement at the KDE Hub in our work around mental health promotion. I think this is you, Niomi. No? Your mic's off.
Perhaps people have already experienced this. I don't know how to turn my mic off and on in presenter view.
Well, that's strange. You can probably just leave it on for the whole time.
I'll just leave, yeah.
That's an issue, yeah.
Yeah, I'll leave it on. We're off to a rolling start. Okay, so today we're going to try to focus our presentation on 5 central ideas. So number 1, what is mental health promotion? And it may not be self-evident. It's a very, very new field. So the Hub is kind of pioneering in their work, and the field of mental health promotion is still being defined. So what is the role of equity in mental health promotion, and how do those two concepts work together? We're going to give an introduction to what we actually do at the KDE Hub. We're going to highlight some Hub activities, and then we're going to hopefully have a discussion and kind of concretize some take-home messages from today's presentation. So mental health promotion and health equity. So we're just going to pause here, and we're going to do a little bit of an interactive poll. So we're just going to look at some basically true or false statements. So true or false, mental health promotion addresses upstream determinants of mental health. And you're welcome to put your answers in the chat window. So you could just put T for true or F for false.
And if participants don't, we're not sure if participants have access to the chat or just the Q&A. I'm not sure if maybe Jillian can pop in and clarify that. Responses can also go in the Q&A, whatever folks have access to. We're not sure. They will not have access to the chat. Okay, so maybe responses, so you can just write true or false in the Q&A, and we can monitor, we can kind of check those out as they come in.
And I'll just give everyone, I don't know, 15 or 20 seconds to pop something into the Q&A. And then Katie, when you see it's populating, you could give a little summary.
Nothing so far. Maybe we can ask the second question and kind of get, sure. I'll let you know if anything comes up. Maybe, are you going to read the second question? And I'll let you know if anything comes up.
Oops. So which of the following is not true with respect to mental health according to the World Health Organization definition of mental health? A, mental health is more than the absence of mental disorders. B, mental health is not an integral part of health, and you can have health without mental health. C, mental health is determined by a range of socioeconomic, biological, and environmental factors. And D, cost-effective public health, and intersectoral strategies and interventions exist for mental health and mental health promotion. So which of the following is not true?
And you can just put A, B, C, or D. So far, no responses. So I'm not sure if this is a access issue or if folks are just like more not feeling like responding. That's okay too. But maybe we'll just give it a couple more seconds and see if we get any responses. Oh, we have B. Oh, I think I have to. I'm not super familiar with this function in like the webinar thing in Teams. It's giving me the option to publish or dismiss. I'm assuming publishing makes it so others can see it. Someone can correct me if that's wrong.
That's correct.
Okay, so I'm going to publish the responses. Oh, but then they disappear. Okay, oh, here we go. Sorry, everyone. We have D, whoops, let me get to the top here. We have B, B, D, B.
Okay. So B is in fact the correct answer. Mental health is an integral part of health, and you can have health, you cannot have health without mental health. So hopefully over the course of the presentation, we're kind of going to flesh out the correct answers A, C, and D. So we'll just move on to the next slide. Go ahead, Katie.
Yeah, so we just wanted to, well, I mean, first of all, with the polls, kind of gauge where folks are at in sort of like, you know, being familiar with mental health promotion as a concept and also as a field. So we're going to play, the Hub Secretariat has some of our colleagues have put together this really great video. We encourage you to check out the whole thing. Niomi's going to queue up just a portion of it, just about a minute and a bit of this video to kind of just provide a definition and like a you know, a description of what is mental health promotion briefly. So Niomi, I'll let you cue that up to our starting point at 1 minute and 3 seconds. Oh, we can't hear it, Niomi. It's really a gamble when we're relying on technology and then things don't work as planned, I guess.
My sound is on and
okay. Any suggestions from the tech folks or the organizers? Has this issue come up of why sound might not work in an embedded video? We did test it and it was working fine earlier today.
Eric, do you have any thoughts on that?
Yeah.
So check that. Oh, sorry, go ahead.
No worries. So you may want to check that the Teams is actually capturing the computer audio. It should be on the top little bar when you share the screen. Not sure if you're able to see that, but it should be there.
Niomi, are you able to see that? I know you weren't able to see that bar when you were sharing your screen earlier.
yeah, I am not able to see that bar.
Okay, so maybe because we're short on time, maybe I'll just describe. Let's go to the next
say,
slide and I'll just discuss what is mental health promotion.
Sounds good.
So we can just get moving along here. Okay, so we'll skip over the video. I highly recommend checking it out. It's available if you look at, if you sort of just go to YouTube and in the search bar put KDE Hub, what is mental health promotion? It's just a 5-minute video and it'll come up. But essentially mental health promotion, I mean, this section of that video I think we were trying to really highlight was the idea that mental health promotion is working upstream to look at, you know, systems that create the conditions under which we live and that inherently will impact our experiences of the world, including our well-being and flourishing, both physically and in terms of our mental health as well. So to put mental health promotion in the context of things that folks might be familiar with in terms of treatment and prevention, we can think of this, I'm sure you've come across this sort of iceberg model for maybe discussing other concepts in the past. And so that's really how we can think about mental health promotion, or one of the ways we can think about it. We often hear about treatment, and this isn't to diminish or minimize the importance of access to equitable treatment for folks who are either in crisis or just having symptoms, or maybe just have a diagnosis and are sort of in the maintenance maintenance part of their treatment, but that's sort of that working downstream after an issue has been identified. With prevention, we see, often programming or direct service looking to prevent disorders or maybe symptoms before they start, and still kind of often working at an individual level, not always with prevention, of course. And then we sort of look at the deeper, the sort of more foundational level we can think of in terms of supporting mental health. And this is where we get into mental health promotion, which is what we do here at the KDE Hub. Mental health promotion is really looking at promoting positive mental health and well-being in context and at a societal level. So looking at what are the social determinants of mental health that influence a person's even opportunity to have access to mental health and well-being and flourishing. Yeah, I'll leave it there for our description of mental health promotion, and I will pass it on to Niomi.
That's a really nice jumping off point when we're talking about who has access to the conditions for flourishing or to thrive and experience positive mental health. And this is tied into the concept of equity. So at a structural and systems level, health equity seeks to address disparities in the health of marginalized populations, including those affected by the intersections of race, class, poverty, disability, sexual orientation, and gender. So all the things that might create barriers to someone accessing kind of the ideal conditions for health and mental health. And I also want to point you to a quotation from a journal article by, I can't remember the author's first name, King. Health equity from a social justice lens challenges the broader political economy and explicitly identifies social injustice as a causal element in the poor health status of a particular community. So moving on to an introduction to the KDE Hub, we're going to try to kind of tie together these concepts of mental health promotion and health equity and give you some examples of what we do in our work that mobilizes these concepts. The Hub's vision and mandate. So the Hub was created in 2018, and the mandate of the Hub is mental health promotion in Canada that is evidence-informed, sensitive to diverse contexts and cultures, equitable, and sustainable. Over to you, Katie.
Yeah, so when we think about the Hub's niche, so where does the Hub exist in this sort of wheel? And this wheel is kind of it was presented in the video that we didn't get to watch, but I did discuss these ideas. You can see at the top of this circle, we have the prevention, treatment, and maintenance that I referred to as sort of when I presented it as the iceberg. These are the things that are towards the top and middle of the iceberg, and how mental health promotion is in the bottom half of the circle here, or at that foundational part of that iceberg. And really, while acknowledging that, the projects that the Hub supports, the folks the communities in which they're working and the people who are accessing these projects, of course, may be at any part of this treatment and maintenance process with their own individual experience of mental health or mental illness at any given time. At the same time, though, the Hub's focus in supporting these projects that are working across Canada are focused in that mental health promotion part. So looking at particularly systemic issues, empowerment, and creating sustainably supportive environments for all communities, particularly equity-seeking or equity-deserving communities.
The Hub has 3 central objectives and areas of contribution. We focus on creating new knowledges across funded projects that is relevant, credible, and timely. We look towards building community capacity amongst our funded projects and others who share their interests. And we work towards strengthening systemic supports that are sustainable and scaling promising approaches to mental health promotion. So now we're going to share with you some of the Hub's activities supporting mental health promotion and health equity. So these are some of the more recent things that the Hub has been up to. So this slide has a list of some examples of Hub activities. So I'm just going to pause there for 10 seconds or so to let everyone have a chance to read some of our activities. And then I'm going to draw your attention to some cross-project studies, and Katie's going to speak more about those. Okay.
Yeah, so in terms of cross-project studies, and one thing just to sort of highlight, just to kind of clarify when we talk about the projects, we've sort of nodded to the fact that these are federally funded projects. The Hub is not a funder, and the Hub does not sort of dictate how the projects do their work. But these projects are across Canada. There are currently 15 funded projects under this set of projects funded by the Public Health Agency of Canada, which also provides the Hub's funding. And so this cross-project knowledge development or cross-project studies are really aimed at developing new knowledge across those 15 projects. At the time this study was completed, there were 20 projects. We're now in phase 2, and 15 projects have moved on to phase 2 of their work. And so at the beginning of 2020, of course, we all know what happened in the world, but at that time, the 20 projects who are working across Canada were also getting started with their mental health promotion programming in all different contexts, doing all different work appropriate to their contexts. And so the Hub team at the time decided to conduct a study across projects to understand how the projects engaged with pandemic adaptation, so how they changed their programming based on what was happening in the world, to keep people safe and to acknowledge the pandemic and match up with public health recommendations and requirements at the time. And so really the purpose of this pandemic adaptation study that the Hub undertook was to explore the impacts of those pandemic adaptations and what impacts those adaptations may have had on the projects themselves, but also more broadly on the field of mental health promotion across Canada, because that's the realm in which these projects are working, as well as on equity, access, cultural safety, and child and youth mental health promotion. So the pandemic adaptation studies included 1-hour conversations with with representatives from each of those 20 project teams, and there were 2 conversations. So one conversation, and then about 6 months later, they had a second follow-up conversation. And there were a number of themes. I'm not going to go over all of the themes that were derived out of that data, but one of the areas we wanted to highlight were some of the findings related specifically to health equity and mental health promotion. And so one of those key findings that I'm going to highlight on the next slide here is that the pandemic has highlighted existing health inequities and also exacerbated challenges for equity-seeking communities in the mental health promotion world. And Niomi, if you want to forward us on to the next slide there. So some of the findings related specifically to health equity and mental health promotion within that pandemic adaptation study. There are sort of 5 main themes in our secondary analysis of this data set of the pandemic adaptation study. These include accessibility in all its forms, which essentially is ensuring that people have access to the mental health promotion programming that was taking place throughout the pandemic. So when we pivot to virtual, we have to think about who doesn't have access to virtual. Some of the projects are working, for example, in remote and northern communities who don't have either any internet or at least not stable internet connections most of the time. Collaboration, co-design, and listening to communities. So when we have to pivot, when we have to create our programming, we have to think about collaborating with the communities who we're trying to make a difference for, who we're working alongside. And then 2 of the findings that I've highlighted here with quotations include diversity within equity-seeking groups, and then asking the right equity questions. And I really want to highlight these 2 because they relate so deeply to the rest of the topics in our presentation. Diversity within equity-seeking groups was participants saying, look, we can't just say that we're doing, we're working with diverse communities or we're doing diversity, but if we're really wanting to work towards health equity, we need to look at the huge amount of diversity that exists within these equity seeking groups. So we can't just say LGBTQ2S+ folks, we need to think about the equity differences between and within that particular diverse, quote unquote, diverse community. And then the second here, the second quotation refers to asking the right equity questions. Of course, this isn't assuming that there is like one exhaustive list of like 5 equity questions that are right in all contexts. It's not that easy, but it's really looking at your context and thinking, what equity questions do I need to ask in order to do equity focused work? And so the participant here is suggesting, in this bottom quote is suggesting, like, did you ask people about their experiences of racism, ableism, etc.? Because if we don't ask those questions, we won't know what health equity barriers are coming up for people taking part in our projects or in our programming, because we just won't have that data. We won't know the answer if we don't ask the questions. And then the last finding here, which I won't go into detail on, is just the importance of relationship building with community and really building mutual trust, not just getting folks to trust you as a practitioner, but or a service provider, but also that mutual trust needs to be built. Your mic's off, Naomi.
Yes, it is. I think it's very important when we move on to looking at the Hub developed tools that we really pay good mind to Katie's highlighting of asking the right equity questions. And so in developing and in demonstrating some of the tools that we've developed, they were really working towards asking the right questions and representing the information with the lens of having asked the right questions in the first place. So I'm just going to show you an example of, this was an infographic that was developed for one of the Mental Health Promotion Innovation Fund Phase 1 projects. And so this is a grouping of the Indigenous specific projects that were captured in that first Phase 1. And the Cedar Path is an infographic that was developed for one of the projects, and it was developed with a lot of reciprocal collaboration. And it really just contains an overview of the project and the aims and development of the project, and hopefully is capturing the right questions. So down our lengthy list of Hub activities. So one of the things that we do focus on is environmental scanning and resource sharing. So that basically means that we kind of try to keep tabs on what's happening, what new publications are coming out, who is starting new programs and sharing them on social media, what webinars are happening, and we also do kind of deeper dives into specific topics, and those could look like literature searches. And so in the last period of time, we've focused on 2 main literature scans, one being the impacts of the pandemic on the mental health of Canadians, and the second one being the impacts of racism on the mental health of Canadians. And we just wanted to share like some very quick relevant data that is specific to emerging adults that came out of these literature scans. They're not meant to be exhaustive scans, they're descriptive rather than analytic, but we're really collecting information around mental health promotion in the context of the pandemic and mental health, and in the context of racism on the mental health of Canadians. So some key points that emerged, not surprisingly, in the mental health of emerging adults, negative impacts of the pandemic on social isolation, challenging academic changes, and disruption to support services and means of coping. And I'm sure none of this is new information at this particular conference, but we had quite a bit of data to substantiate this claim. And we're also, from our second review, which is still in progress, experiences of discrimination impact the upstream determinants of mental health. Not surprisingly, there was quite a bit of information on housing security as related to race and discrimination, and that having an impact on the mental health of emerging adults. Yeah. So basically, we wanted to move from here, like we've just given a lot of information in this presentation. So we wanted to move into a kind of questions and discussion period in which we could possibly come up with some examples of mental health promotion interventions and consider the ways in which they're different from treatment interventions. And those were just our kind of prompt questions to start off with.
Yeah, so maybe Niomi, I can look at the Q&A because I know you can't access it when you're in sharing mode. Maybe we can start with like a broad, like, are there any questions? We have ended a little bit early in terms of our content. So maybe we can pause and see if there are any questions about mental health promotion, health equity, or specifically what the Hub does. And then we can get into maybe addressing some of these like more discussion points as time allows. So we'll leave it open now. I'll open the Q&A and I'll keep my eye there. Are there any questions about the things that we have covered so far? Our plan was to invite folks to turn on their mic and or camera and ask their questions, but I don't know that that's a possibility in like webinar mode. So if not, you can pop them in the Q&A and I will watch your comments come up here. And I guess one thing we can highlight. Oh, sorry, go ahead.
I was gonna say maybe I can get us started with asking a question, and then people
Great.
can start to populate the Q&A. And just wanted to confirm too that you're right that folks watching are able to type in questions, but not ask them out loud.
Okay.
So thank you so much for sharing all this information about the really fantastic work that the Hub is doing. As you were talking about the work, the background work that you're doing to understand the impact of the pandemic on mental health, you mentioned some of the important health equity issues that were coming up included the need for collaboration and like asking the right questions of equity seeking groups. And it made me think about or wonder about how much of the projects that you're engaging in are like participatory research projects, like how involved are the folks that are, you know, your target audience able to be involved in really the design and collection of data and all of those things. So I thought maybe you could talk a little bit about that.
Yeah, it's a great question. So it's an interesting dynamic, first of all, because the projects themselves are not research projects. They're providing mental health promotion programming in their individual context. So like, for example, Niomi shared the slide that was a list of the Indigenous-led, various Indigenous-led projects with one of them highlighted in the infographic. So really they're seeking to create meaningful change or have meaningful outcomes within whatever their context is. So for those projects, it would be working within their local Indigenous communities that they are themselves part of. And so the way that, and then the pandemic adaptation study itself was conducted by the Hub, because research is one of the things that the Hub does. The Hub does not provide direct programming. We do that sort of in addition to some other things, we do that sort of list that we presented, and one of those was creating new knowledge, which is, you know, engaging with research across projects. So hopefully that distinction is clear. In terms of so our research is with the projects themselves, not with the people, the service users using engaging with those projects. When the projects themselves, you know, do their own evaluation or, you know, maybe a research project, it's really up to them, and we don't. The Hub doesn't control, certainly, the methodologies that they use. I will say the projects are right now developing their evaluation plans, and from what I can tell, many of them are using a participatory approach, not just for evaluating how they're doing and how their work is going, but also for even creating their logic model and theory of change, and even outlining like what outcomes are we even going to have with our activities. Some of the projects are even using sort of a co-design approach in terms of that evaluation process, while other projects, you know, hire an outside maybe a consulting firm or an evaluation firm to come in and do the evaluation, which may end up being slightly less participatory. So really how the projects engage with their research and their evaluation of how they're doing is up to the projects themselves. If that makes, hopefully those distinctions that I made make sense.
Yeah, thank you. That definitely makes sense.
Great.
So I'll encourage folks to just, you know, pop questions in if they have any. Another thing that I was wondering about when you were presenting the initial sort of like definition slides about like how you understand what is mental health promotion, I was thinking about just how broad the like range of projects that you must be like interested in exploring and considering and working with partners must be, and like how, you know, when we think about like social determinants of health and how that interacts with mental health promotion, like just how like broad a range of things that can come up. So can you talk a little bit about, you know, how decision making is done and how you sort of target, if you can, you know, target your projects in certain directions?
Yeah, so I can speak to that. So just to clarify, we do not determine who receives the funding. That is the Public Health Agency of Canada. So once they have received the funding, then they sort of like, we are a third-party entity with whom they work, and we work to support the projects. Just to clarify that, Jillian, because I know sometimes it can be a little hard to understand. And we didn't get to show, the video has a really nice graphic of how the structure works. So it's hard to visualize without the graphic, but please do check out the video. And the other important thing to say is, in addition to not determining which projects come to us, it's also the field of mental health promotion is surprisingly small. Like, you think that it encompasses like, you know, huge systems, and it is, and because it is so upstream, you know, like the iceberg gets bigger at the bottom and you think it's really big, but when you're actually applying a mental health promotion lens, it becomes very particular, because there's many things that are included with the mental health promotion lens and excluded because of a mental health promotion lens, if that makes sense. So it's actually not quite as big as you'd think.
Thank you. Yeah, that's really interesting.
Yeah, and we have another question coming in here. I'm just gonna, I just realized it hasn't been published yet. Thank you for that, Niomi. That's, our model is complicated and it's quite unique. So we have a question here. Are there racialized team members at the Hub? No, there are not. Our Hub team is, well, I mean, I guess I can't say for people's backgrounds, but we are a white presenting team. And part of our, I guess, structure is that the Hub isn't, first of all, I mean, the Hub isn't making, as we said, funding decisions or programming decisions. That's led by the project staff themselves and the project teams themselves. And within those project teams, for example, the Indigenous-led projects are, or sorry, the Indigenous focused projects are almost entirely, there's one whose team is not entirely Indigenous, but they're led by people who are from the communities that they are serving. And then the other component there in terms of like our structure and the sort of diversity and how, you know, how the team makeup is the Hub also works with a resource collaborative. So the HRC, the Hub Resource Collaborative. And this is a group of professionals working in mental health promotion field with different areas of expertise and lived experiences and identities themselves, who sort of like act as like a standing body of consultants that the Hub can sort of go to for. I mean, it's a resource collaborative. So whether it's you know, checking in about things, whatever the case may be, asking questions that the Hub has that we are maybe not experts in. So I hope that answers that question. But I mean, the short answer is no, and the longer answer is the Hub itself and the connections that the Hub has represents a much larger group of people than just the 11 staff members at the Hub. But thank you for asking that question. It's an incredibly important one. Sorry, go ahead.
I was going to say thank you so much for asking that question. And I think it's very important. And when we're thinking about the Hub, we have been considering the question of neutrality a lot recently in our work. What does that mean? Because technically we are a neutral entity in between other entities. And so we've been thinking carefully about that. And that we do not, like as Katie said, we do not hold decision-making power. And I think that's really key in considering this question of who is represented in the Hub. So thank you so much for the question.
Yeah, always a question that needs to be asked: who's at the table, and really not even just who's at the table, but who even created the table, right? Like whose table is it that we're even at? And these are questions that we're constantly I don't want to say grappling with, because it's not like makes it sound like it's a fight or something. Questions that we're sitting with at the Hub and really critically asking ourselves and each other. Let me just go back to the Q&A here. Oh, no new ones, I don't think.
There was a comment from Kalpita. I think it was in response to the question you posed about examples of mental health promotion interventions. Yes.
Yeah, so examples of mental health promotion interventions: universal free education, subsidized housing, community gardens, to name a few. Absolutely. Things that are sort of, you know, working at that environmental systems level. And this is really one of the interesting things I'm thinking about, like the projects that the Hub supports as well, that there's so much diversity here. I mean, you can think about the difference between like community gardens versus universal free education. They don't seem like they might be in the same bucket of anything. They're so different on the ground. But in terms of like supporting flourishing, and not even just like, you know, providing universal programming like free education, but also actively working to look at inequities. So if there are particular communities who have had unequal historical access to whether it's education or housing, it's not just providing the same support to everyone universally necessarily, but it might be providing additional extra support to communities who have been historically oppressed or marginalized. It's that sort of difference between equality and equity, right? So that's kind of how those health promotion and health equity kind of can sit together when we think about some of these examples, these great examples that you've provided.
Yeah, those are really great examples. And I was going to echo the need for, like, when we talk about universal programming, to turn that into a really MHP lens. I'm going to kind of draw out what Katie said. To turn that into a specifically MHP lens, what you're going to need to be looking at are the barriers that have been posed, like that have been faced by people trying to get access to education for many, many years. And so a universal free education program is going to need to have built-in systemic supports that actually ensure that it is available and accessible to the population that it's trying to serve.
Mm-hmm.
But those are great examples.
Yeah, any other, I guess, additional questions, or if folks want to go into the sort of our conversation, is additional examples that you've seen, maybe directed specifically at the student population or at the university in general, related to mental health promotion specifically, or like I said, any additional questions that folks want to ask or engage in is also more than welcome. As we've said, we acknowledge that our model is unique, and so it can also be like Niomi and I both started at the Hub at the beginning of April, and I think there are still times when we're like, oh right, that's how that connects to that other thing, right? That's the role of the resource collaborative versus the secretariat or whatever. Like, it is a unique model, and understanding us as not a funder and also not a service provider, but supporting across projects in a, as Niomi said, it's a loaded term, but a quote unquote neutral way is very unique, not just in the realm of mental health promotion, but just, you know, in general. No last minute questions popping up. We can end 5 minutes early, but of course we love to, I was gonna say we love to hear ourselves talk. That's not true. We love to engage with folks and answer questions.
I'm curious if anyone has thoughts on how, because it took me a long time to understand how mental health promotion was different than a treatment intervention. So I'd be curious to hear if anyone has thoughts or takeaways from the presentation today about how those two things are different.
Mm-hmm.
Maybe I'll just say I was struck when you were presenting by the fact that a lot of mental health promotion work intersects with people who are engaging in mental health treatment. And so I imagine that sometimes, I don't know, kind of muddies the water in terms of like how you would define something that's strictly mental health promotion versus a mental health treatment program.
Yeah,
absolutely.
That's a great question. And often it's true that you cannot have one without the other, because you can't, mental health promotion interventions have a much longer, like the scale of their outcome measures is longitudinal. It's not, you cannot measure outcome in the same way that you can measure a treatment outcome, or arguably, I think treatment outcomes should be measured longitudinally as well. But often when you have a treatment program, it's a very short efficacy turnaround. So you can't begin a mental health promotion intervention where a population is clearly having daily crises. And so those have to be addressed or somehow built into the model as well. So you're right that it's a very slippery slope, but I think that it begins with, it's like the treatment intervention is secondary to the structural and systemic underpinnings of the mental health promotion intervention. And so that it's more like you flip the iceberg, and so the iceberg like melts this way. If that's, I don't know if that's a terrible analogy or not, but
well, I think a really good example of what you're saying, Niomi, like from the pandemic adaptation study data, one of the projects that the Hub supports works with newcomers and refugees. And during the pandemic adaptations, like sort of conversations, one of the things we heard was, given the context of the pandemic especially, is that the folks they were supporting, because again, the Hub is not doing the direct support, but this project, which is, largely works in a peer support framework with folks who are also newcomers and refugees themselves, supporting newcomers and refugees. They were saying, look, our people that we're supporting are dealing with multiple double traumas, right? They're dealing with the trauma of where they come from, particularly folks who are refugees who might be coming from a war context or a violence context. And now, they've landed somewhere that maybe is safer for them in Canada, but now we're also dealing with the trauma of pandemic and, being higher risk and, maybe losing family members. And so that's an example of, those are the real tangible, like, crisis things that are happening in people's lives, while this project is also doing their mental health promotion programming. And what this sort of leads into, I see a comment here, would you also support projects that support upstream aspects of mental health promotion? That's 100% what the projects are doing. We don't choose the projects that we support, so they're receiving funding from the Public Health Agency of Canada. So they're, they went through the application process in phase 1 and then again in phase 2 of saying, here's what we want to do, here's how it's mental health promotion, here's how we'll evaluate that. Do we get the funding? Public Health Agency of Canada says for the projects that were funded, says yes, you get the funding, and then the hub supports. That's when we, as a hub, actually learn about the projects, is after they've received the funding from PHAC, from Public Health Agency of Canada. And there actually is at least one project that looks at food security. Or at least there was in phase 1. I think they're also in phase 2. So that's what the projects, they are. Yeah. So the projects are looking at, that's exactly what they're doing, is they're looking at those upstream factors. And also, I mean, as Niomi alluded to, this sometimes makes measurement difficult, because how do you say you're having a systemic level impact when you're, on doing the work on the ground and you need to evaluate your work as you go, but looking at policy changes or food security, changes in increasing food security is tricky to measure, and that's one of the roles of the hub, is supporting projects in figuring out how to measure those things. I'm offering a workshop for them later today in defining outcomes for preparing to do evaluations, because these things are really hard to pin down and evaluate when we're working at that systems level. We're right at 11:55, actually 11:56 now, so we won't take more time. And Niomi, unless there's any wrap-up comment you had?
No, I just wanted to thank everyone so much for attending our presentation tonight. It's nice to share with the University of Waterloo community. We're sort of tucked away in the basement of Renison College. You can come visit anytime.
We have an espresso machine down here.
We have an espresso machine. So, I just wanted to thank everyone for attending and to take this nice opportunity to build cross-departmental or cross-campus. I was looking for the word. Cross-campus connection. So thanks so much to Thrive for having us.
Thank you both so much for coming and sharing this work with us. I think it's really clear that the work that you're doing is providing a really, I think, essential support to really important mental health promotion work that's happening across communities. And that, what you were just saying, Katie, about that piece about supporting the learning about outcomes, the project work of these organizations that maybe don't have the tools within to understand the impact of their work, but we know that there is such an important impact happening. So I just think it's fantastic that that this organization, that you exist and that you're doing this work.
My name is Ashley Ryan, and I'm going to be moderating the next block of presentations for our lovely Student Mental Health Research Conference. Before we move on, I just want to remind everyone about the resources available to both students and faculty and staff. Grace has put them on the slides right now, and I believe she's going to be popping them in the chat as well, including campus wellness, Empower Me, occupational health, things like that. So things to keep in mind for the future. So I see that our first presenter is here, so I will tell you a little bit about her. So Fatima Wasif is our next presenter, and she is a doctoral student in the clinical psychology program at the University of Waterloo. Her research aims to gain a deeper understanding of the influence of social systems and executive functions on subjective well-being. She hopes to pursue a career as a clinical neuropsychologist, working with children, adolescents, and their families. Her presentation is entitled "The Contribution of Executive Functioning and Emotion Regulation to Well-Being and Psychological Distress in University Students." And I would like to just give a heads up that we will have a Q&A session with Fatima after she's done presenting. Go ahead, Fatima.
Great. Hi, everyone. I'm just going to share my screen. Okay, can everyone just see the slides?
Yes.
Okay, wonderful. Okay, so hi everyone. Today I'm going to be talking about emotions and cognitions and how they influence well-being in university students. So university is a dynamic environment, and it's one in which students set and pursue and achieve a variety of different goals in many different domains, including academic, social, and career areas. So for example, aiming to get a specific grade in a class, or perhaps networking to expand work opportunities. So we know from past research that goal achievement is positively linked to well-being, and well-being is an important outcome for students in undergraduate education in particular, because it's on the opposite end of the spectrum from psychological distress. And psychological distress is quite prevalent within undergraduate populations, in that it's also much higher, it's prevalent at much higher rates than the general population, and as many as 30 to 50% of post-secondary students report experiencing symptoms of stress and anxiety and depression. So students, like other demographics, do vary in the level of well-being that they report. And so the central question that really motivated this work was trying to understand if we can meaningfully predict student well-being in order to really advance our understanding of how we might be able to improve it within this demographic. And so keeping in mind sort of the salience of goal-directed behaviors during undergraduate education, we did choose to look at two factors that support pursuing and achieving goals. And those two factors we thought would be good candidates as potential predictors of well-being and psychological distress among university students. And so the first of those factors is executive functions. And executive functions really refer to the interrelated cognitive abilities that facilitate engagement in adaptive behaviors during goal pursuit. So three sort of main core executive function abilities are working memory, inhibitory control, and cognitive flexibility. Working memory really involves holding and manipulating information in mind. It's what allows us or helps us to keep track of goal-relevant information. Inhibitory control refers to the ability to stop yourself from taking goal inappropriate action, or to inhibit thoughts that might not be directly relevant to the goal that you're pursuing. And cognitive flexibility is also called mental shifting, is the ability to kind of hold two or more concepts in mind at the same time, or to switch between thinking about one thing to the next. And from these three core cognitive abilities arise more higher order executive functions like reasoning, problem solving, and planning. In tandem with these abilities that help us to regulate cognitions to support goal achievement are emotion regulation abilities. And emotion regulation is really a catch-all term to refer to strategies that individuals use in order to sustain, dampen, or enhance their emotions in pursuit of specific goals. So there are two strategies that are quite well known within the literature for emotion regulation. The first is cognitive reappraisal, and the second is emotion or expressive suppression. Cognitive reappraisal really involves reinterpreting or re-evaluating a situation that's likely to prompt an emotional reaction. Emotion suppression is more centered or geared towards inhibiting emotion-focused behaviors. So if you think of an example where you might be engaging in public speaking, like giving a class presentation or giving a Thrive presentation, I suppose, if you were to engage in cognitive reappraisal as the emotion regulation strategy, it would involve something like thinking about the public speaking or the presentation as a chance to practice your skills at public speaking. On the other hand, if you were engaging in emotion suppression, it would involve something like trying to mask your nervousness during a presentation. So we know that both executive functions and emotion regulations are related to goals. And we know that goals are linked to well-being. But what we're unsure of, or what we can't really speak much to, is whether executive functions and emotion regulation directly influence well-being and psychological distress. And we know even less about how they might jointly do so. And so, over the course of two studies, our main aim was to gather more information about how those two factors might directly impact student well-being and psychological distress. So in study one, we had two main questions. The first was, does the type of strategy that students employ to regulate their emotion as well as their executive functions uniquely predict undergraduate mental health concerns or psychological distress. And by prediction, we're really trying to understand if the variation in well-being, or in this case, psychological distress, is being explained by these two factors. And then also, if there is a relationship between emotion regulation and psychological distress, is the strength of that relationship influenced by the individual's executive functions? So to answer these two questions, we recruited 210 students from the University of Waterloo's Zona participant pool. And these students completed questionnaires that assessed their emotion regulation strategies, and we focused on cognitive reappraisal and emotion suppression in particular, their mental health concerns, and then also the difficulties that they may be experiencing using their executive functions in everyday life. And so what we did was we employed a type of data analysis called moderation analysis. And what moderation analysis does is it constructs for us a model that explains how much of psychological distress, how much of that variation in psychological distress among students that we observe is explained by the effects of the difficulties with using executive functions in everyday life, the type of strategy that students are using, so if they're using cognitive reappraisal or if they're using emotion suppression, and the interaction between the executive difficulties that students experience and the type of strategy that they're employing. And so what you're seeing on the screen in front of you is that this model accounts for about 40% of the variation in psychological distress that students report, and that's a significant amount of variation that's being explained. What you also see in more simpler terms is that those students who report experiencing greater difficulties in using their executive functions in everyday life also report significantly higher psychological distress, and those individuals who endorse using cognitive reappraisal less endorse more psychological distress, considerably more. Now, that interaction term here is also significant. It's a bit harder perhaps to just understand what that means. So we're actually going to take a closer look at it on the slide right here. So here what we have is we have psychological distress on the y-axis, and on the x-axis is the level of use of cognitive reappraisal as a emotion regulation strategy. And the three lines that you're seeing represent three groups, and they're split across the frequency of experiencing executive function difficulties in everyday life. And the split is low executive dysfunction, average, and then high executive dysfunction. So what we really see here, I'm going to try to use the laser pointer and hope that it works, is that for students in this group who are reporting low sort of difficulties with using their EF abilities in everyday life, they do report consistently low psychological distress, regardless of how much they endorse using cognitive reappraisal as an emotion regulation strategy. But for undergraduates who experience either average or greater difficulty with employing their executive abilities in everyday life, the more that they endorse using cognitive reappraisal as an emotion regulation strategy, the less psychological distress they experience. And you can see that in both these lines, in the downward trend in both these lines as you go across. And those effects are both significant. So there is a meaningful impact of using cognitive reappraisal in terms of the level of psychological distress that students are experiencing. So study 2 is really an extension of study 1, and we're asking identical questions as we were asking study 1, but we're replacing just looking at psychological distress to looking at affective well-being. And specifically when I say affective well-being, I'm talking about the amount of positive affect and negative affect that students are experiencing. So to answer these two questions, we recruited about 169 students, again from the University of Waterloo's Zona participant pool. And these students completed identical questionnaires as they completed in study 1. So this is a different group actually. The questionnaires were identical between the two studies, but in study 2, there's the addition of 2 new questionnaires. The first one aimed at gathering more information about the frequency with which students are experiencing positive and negative emotions, so things like joy or happiness or sadness or nervousness. And then we also introduced a questionnaire that assessed their sort of goal-centered values And so here I'm presenting a very similar sort of explanatory model as study 1. But here, what we're predicting is positive affect, so variation in positive affect among students. And what we're really seeing is that none of the predictors, none of our chosen predictors really do a good job with explaining those differences in positive affect across individuals. There's no significant effects at all. But for negative affect, the story is a bit closer to us to what we saw with psychological distress, in that those who are experiencing more executive function difficulties are also reporting significantly greater negative affect, and that the interaction between executive difficulties and then cognitive reappraisal in particular is also significant. And again, if we look at that interaction further, replicating that same analysis from study 1, but replacing psychological distress with negative affect on the y-axis, what we see is that for individuals in this group right here, is the uppermost line, who really report experiencing greater difficulties with employing their executive functions in everyday life, the more they endorse cognitive reappraisal as their chosen emotion regulation strategy, the less they experience negative affect. And so you can see that downward trend in that line right here, where the low endorsement of cognitive reappraisal is associated with higher negative affect. Average is lower than the low average cognitive reappraisal is lower than low cognitive reappraisal, and the lowest negative affect is being experienced by those who endorse high cognitive reappraisal strategies. And so the question really is, what is the big takeaway from both of those studies? And so generally what we can say is that cognitive reappraisal strategies really do help shield individuals from psychological distress and negative affect. And this effect is especially true for those vulnerable to EF difficulties. Practically, what that means is perhaps that student support at universities can look into offering workshops that really teach emotion regulation strategies, and that those strategies should perhaps be focused more on cognitive reappraisal. And there's many ways in which those interventions might happen. So I just have 3 examples of the ways in which we might be able to enhance cognitive reappraisal among students. So for example, one way is self-distancing. So self-distancing involves reevaluating an experience, an emotional experience, by visualizing yourself as a third-person observer. So if I'm in a situation, I'm trying to reevaluate myself in it, I might not say I was doing this or that. I might refer to myself as a third person. Fatima was doing this, she's doing that, and kind of reframe it for myself that way by distancing myself from that situation and then reevaluating it. The second is temporal distancing, and in this one, participants, think about their perception of an event, but from the perspective of themselves in the future. And we might say, okay, think about this event, but think about yourself a year from now, or 5 years from now, or 10 years from now, and then reevaluate your the way that you are really thinking about your performance or the way that you acted during this event or situation. And the third is positive reframing, which doesn't necessarily include thinking about a negative, perhaps, experience in a positive way, but really it speaks to thinking about what you might have learned from a negative experience or what you might be doing differently in the future. So thinking of it as something to build things from, to take things away from. And I also want to emphasize sort of like the end note from these suggestions is that these workshops need not just be aimed at people or students who are experiencing mental health concerns or who are maybe more vulnerable to EF difficulties, because executive functions and emotion regulation are really relevant in terms of goal achievement, in terms of learning, in terms of engaging academically. Those things are important for all students. They're a factor in every student's life, especially in academic sense. And so there's value in these workshops, not just for particular groups of students, but for student life in general and students overall. And with that, I'd like to thank everyone for listening, the CAN Lab at the University of Waterloo for all of their support with this study, the University of Waterloo itself, and then also our funding source, which was the Social Sciences and Humanities Research Council, so SHARC. And I will end the show now, and I'm happy to take any questions.
Great, thanks so much, Fatima. That was like very interesting research and very important research. I found that super interesting. Some of the parts I'm in sociology, and I feel like I saw a little bit of hints of where certain theories that I deal with it might bleed into as well. So like Fatima suggested, we're opening the floor now to Q&A. So feel free to type your questions in now in that Q&A chat right at the top there, and we can start addressing those. Am I frozen?
I think you're good.
Okay, I was like, I think Fatima, because your camera is frozen, so I was like, oh no, did my internet cut out?
Oh.
I do have a question actually while others are thinking about what they might want to ask you. I know we talked about, well, you talked about like some future directions and implications. Do you have any suggestions on the top of your mind of like what other researchers might be able to do in the future on this topic, or what you might be interested in doing in the future related to this topic?
Yeah, I think one thing is there is this focus on these two strategies, and that's because traditionally they're sort of exemplars, like prototypical examples of something that you can employ before a situation happens, which is like cognitive reappraisal, or something you employ while something is going on. But recent research that's come out has shown that there's other strategies for emotion regulation. I think there's like 5 different areas along a kind of emotional timeline where you might be employing strategies to manage your emotions to better suit like task completion. And I think there's probably a lot more to say about how each one of those strategies could factor into well-being and psychological distress. And I think the other bit is there's not a lot perhaps connecting executive functions with emotion regulation in this specific context, just because sometimes we think of emotional control as a type of executive function, so that's something else separately. So perhaps something more that merges those two together. And even in terms of intervention, like if there's something that I don't think that there's a cohesive sort of idea of particular intervention techniques that work, or how long they might be able to work, like, or if you can shift, for example, to one sort of strategy for regulating your emotions than the other. So I think those would all be like great directions to get into.
Oh, that's great. Like directions and suggestions for future. Okay, we have a question in the chat by Robin Hesh, and it says, great presentation. A lot of the strategies you're presenting remind me of research I've read about resiliency. Do you have any thoughts about how what you've presented could be utilized to enhance student resiliency?
Yeah, of course. I think with resilience, I'll be like honest, I'm not quite well versed in the resilience literature, but I do think that some of those things about like gaining control over a situation or being prepared for it in terms of reframing things could be valuable. And if you are aware of a situation that you're going to go into that might be emotionally powerful or something that you might be nervous about, if you reframe it prior to it, the emotional valence of it might go down a little bit. And if you keep practicing it, I presume that helps build up some of those coping skills and strategies and make yourself like more resilient or more able to stay in that situation without being uncomfortable per se.
So we have 2 other questions so far. The other question is, it says, I'm wondering what factors you controlled for when you were looking at the impact of cognitive reappraisal, for example, test scores or other stresses in student lives.
So in terms of stresses, we didn't do like a student stress survey, for example. We kind of gauged how much stress that they might be experiencing from the questionnaire relating to mental health concerns. So it's like a SCL, like it has a bunch of symptoms that can speak to stress in general, not just in directly sort of the test scores or kind of academic domain, but outside of it. And when we think about cognitive reappraisal as a strategy, it's more so trying to understand if that's the way that how much of the things that we associate with cognitive reappraisal people are already employing. So we don't necessarily put people into groups and have them train, for example, to be appraising things a certain way or the other. We just based on how we give them a score on, okay, they're using this much already or this much already, like this much emotion suppression and cognitive reappraisal. So it's all really survey based. So it's kind of like they're not, the things that we control for are things like gender or age, that sort of thing.
Thanks. And the next question is, would you say emotional suppression is more of a good thing or a bad thing? It says, I would have assumed that now socially we try to teach ourselves not to suppress emotions. Are you able to outline what emotional suppression would look like?
Emotion suppression could be like, for example, if I'm here right now giving this presentation and I'm really nervous and I feel like, oh, my voice is curving, I might try to like laugh it off or something, or do like something that I'm trying to do that masks how I'm feeling in the moment. I'm already experiencing the emotion and I'm just trying to make it less obvious that this is the way that I'm feeling. So it's more of like a response focused strategy. And honestly, I wouldn't call it good or bad. It's just a strategy to deal with emotions. Of course, in the context of this, it seems like cognitive reappraisal is the better emotion strategy to go with in order to handle those like negative affect and psychological distress more strongly. But that's not necessarily to like demonize other ways that people might be able to handle emotions. It's really just to employ the technique that seems to be working best for you in terms of making sure that you're in a good place with or feeling comfortable with the way that you're feeling in certain situations. So if you're in a situation where it feels like, oh, I'm gonna like feel really badly perhaps when I'm speaking publicly and I'm gonna struggle really to inhibit how I'm feeling, perhaps the way to go is, I already know this thing is going to make me nervous. So how about I think about it and I'm going to practice this. It's not really a daunting situation. It's just a way for me to like make use of my skills, that sort of thing.
That makes sense. There is one more question, but I think that we are on track to move on to the next, but I will publish the question in the chat in case, Fatima, if you can see it, if you want to answer it on the side there. Thank you so much, Fatima.
Yeah, thank you so much. Can I close my camera?
Okay. All right, so I see we have our next presenter here, so I will introduce her. So next up we have Beth Grant. Beth is a first-year master's student in the School of Environment, Resources and Sustainability here at the University of Waterloo. Beth did her undergrad degree in the same program with a joint major in social development studies. She recently published her undergraduate thesis research on the mental health impacts of climate change on local youth in a peer-reviewed journal, and is excited to continue learning and making contributions to the field through her graduate research. In her spare time, Beth enjoys hiking, camping, baking, and live music. Beth's presentation today is titled Coping with the Climate Crisis, Investigating the Mental Health Impacts of Climate Change on Youth and Exploring the Efficacy of Voice Intervention. All right, go ahead, Beth.
Thank you. Yeah, can you all see and hear me okay?
Yes.
Perfect. Okay, let me just hopefully share my presentation. Okay, and can you see my slide okay?
Yeah, we see them.
Perfect. All right, I'll get started then. Yeah, thank you for the intro. The research I'll be presenting today is based on my undergraduate thesis project. As mentioned, we recently got a chunk of this research published in a peer-reviewed journal, which was a really fun journey, a really difficult but really fulfilling journey. It was co-authored by Robert Case from Renison University College at the University of Waterloo, who also supervised some of this thesis research as well. Awesome. Okay, so this undergrad thesis research had two related aims. One aim was to investigate the impacts of climate change on the mental health and well-being of youth and young adults in and around the region of Waterloo. The other aim was to explore the potential of using photo voice, which is an empowering and engaging method of data collection based in participant photography and self-reflection, as an intervention tool for managing the mental health impacts of climate change and empowering participants. So those were the two research questions I looked at. For my methods, we approached the study using a mixed methods approach, including an independent photo voice activity and subsequent focus groups, as well as a pre and post intervention survey. Participants were required to be between 16 to 23 years of age and had to be involved in a local climate action network or an environmentally related club in the University of Waterloo community, or they had to be enrolled in an undergraduate environment or sustainability related program. This specific community was chosen as they could be categorized as youth and young adults and were also hypothesized to have been exposed to increased mental health impacts of climate change as a result of their climate related studies or extracurriculars. So some of the surveys that I used included the Adult Hope Scale, which is very well established in the literature, developed by Snyder et al. In 1991. And then I also used a climate anxiety scale that was more recently developed by Clayton and Carazia in 2020 to measure levels of hope and climate anxiety before and after the photo voice and focus group intervention. Photo voice participants were provided with 2 prompting questions. So the first question, does climate change impact your mental well-being or sense of happiness? If so, how? And then the second question, in spite of the climate crisis, what gives you courage for the future? Participants were asked to capture photographs and write accompanying descriptions based on those prompting questions. Virtual focus groups were then hosted to allow photo voice participants to come together, share their photos and written works, discuss emerging themes among their experiences, and then partake in the process of meaning making and data analysis. You'll actually see some of the participant photographs and quotes in the subsequent slides of the presentation. So if you see any beautiful photography, it's not mine, it's some of my participants. So the initial survey results found that 88% of respondents have noticed a change in a place that's important to them due to climate change. 66% have had a nightmare about climate change, and over half of respondents either never or rarely feel hopeful for the future in relation to climate change. Those were some of the most impactful findings that we found. And from the thematic analysis that came from the focus groups, we had 3 broad themes that emerged. So the first was encounters leading to mental health impacts. The second were the mental health impacts themselves. And then the third were sources of resilience, which we kind of understood and defined as what gave participants the ongoing ability to live and function despite the mental health impacts of climate change that they were experiencing. So the most frequently cited encounters that led to mental health impacts were witnessing changes or deterioration to places of personal importance, which included landscape changes, loss or displacement of species, and some intense weather events. So the participant who took this photo captured this beautiful picture of an ice-covered plant at the river near their home, where they used to skate in the wintertime and swim in the summertime. And they have this quote here, after 2 floods in 2017 and 2019 and unstable ice, the river serves as a frequent reminder of climate change, rather than a place of comfort and relaxation. While I cherish the memories I have, I wonder if future generations will have similar positive experiences. The next most common encounter that led to these mental health impacts was educational exposure. So in this case, that occurred through their environmentally related post-secondary programs. Participants explained that studying and researching change and loss due to climate change makes it an inescapable reality. So one participant encountered these effects while working on her thesis, saying, "It takes me a long time to get something done because not only am I processing through the data, I'm also processing through these devastating feelings of grief and loss. I wish there was more support for that in my academic experience." Consideration of future generations was another encounter that led to the mental health impacts of climate change. Participants expressed concern about whether they might have the same environmental opportunities or bear witness to the same landscapes one day. So this is encapsulated in this quotation as well. "My brother just had a baby in November, and that has been a huge joy in my life. But it also, at the same time, was heartbreaking because I think about how when she gets to be my age, she might not get to see the snow-capped mountains. These places that I really want to bring her to might not be there." So that's kind of captured in this photo as well. Okay, so eco-grief was a frequently cited experience that was described as a heavy feeling, deep sadness, the loss of something you love, trauma, and the tangible grief of inheriting a dying world. This particular participant took a creative approach and used cards from a card game to encompass their feelings within the photos that they took. So they said, there's a sense of eco-grief that I have towards all living beings and landscapes that we are going to lose. A lot of my formative experiences have happened in outdoor places, and it worries me that future generations may have diminishing opportunities to do the same. Eco-anxiety was also a commonly referenced experience that stemmed from threatening landscape changes, uncertainty for one's future, and concern about the intensification of potentially catastrophic climate change impacts. So this coastally located participant said, when I consider the impacts that just a 1-foot rise in sea level can have, there is a certain level of anxiety. An anxiety that is intensified when I consider the lack of action or protection that these resources are afforded locally. In the face of such an action, it can be hard to enjoy the resources which may be damaged beyond repair in my lifetime. Some other experiences that were cited by participants include solastalgia, guilt, hopelessness, anger, identity loss, and some functional impairments. So it was a very broad reach for sure. Okay, so when asked what gives them courage for the future despite the climate crisis, participants offered a diverse array of coping strategies, including spending time in nature, a sense of community, taking action, avoidance, and humor. So the most frequently cited coping strategy was to spend time in nature, which was associated with captivation, peace, harmony, hope, calm, recharging, and strengthened emotional connection. Encounters with species were perceived as very important, emotional, and profound moments. One participant said, "This is why forests give me courage for the future, because it's a constant reminder of ecological processes still working in our favor." Another explained how seeing the great blue heron reminds me that not all is lost and that I should enjoy my time in nature rather than worrying whether it will last, focusing on just observing the things around me while they're here. Community was the second most highly discussed topic in terms of coping. So some of the sub-themes included future generations and Indigenous knowledge. Participants spoke of the resiliency that comes from that sense of community, the power in putting aside differences and coming together for the greater good. So one participant who you see on the slide here spent some time as a camp counselor and would lead kids in feeding the chickadees, which is what's captured in this photo. Some other sources of hope were political and environmental action. Small-scale individual actions were mentioned, such as growing your own food, eating less meat, but also larger-scale systemic actions were discussed, including conservation, urban biodiversity initiatives, and the creation of accessible green spaces. One participant's encounter with an endangered caribou, who you see on the slide, was also a call to action for them. And then avoidance and sense of humor were also mentioned and used as coping mechanisms. So participants also acknowledged both facilitators and barriers to resilience. So privilege was stated by several participants as a facilitator of resilience. Several types of privilege were named, including the opportunity to travel and work in nature, close physical proximity to natural spaces, physical health, and privileges based on intersectional identity. A lack of discussion and support around the mental health impacts of climate change within post-secondary education institutions was the most frequently noted barrier to resilience. Another barrier that participants discussed was the stigma and lack of validation of emotions that they were experiencing in their academic work. They also mentioned some compounding mental health issues, including pandemic-related stress, seasonal affective disorder, and other pre-existing mental health concerns. Participants remarked that a lack of access, whether geographically or monetarily, to outdoor spaces and sustainable choices is a troublesome barrier to many of the coping mechanisms that they deemed important for maintaining resiliency. Okay, so was the photo voice intervention effective? When asked in the final survey if the photo voice activity and focus group had a positive impact on their mental health in relation to their thoughts about climate change, 2 participants and the treatment group said that they strongly agree, another 2 said that they agree, and 1 participant said it had a neutral impact. 100% of respondents thought that participating in the photo voice activity and focus group was a meaningful and empowering experience. So some subjective positive responses there. So why does any of this matter? This research might help to foster some much needed conversations about the mental health impacts of climate change being experienced by today's youth. particularly those studying climate-related programs at post-secondary institutions. Participants expressed a desire to see conditions on their campuses improve, recommending the development of an undergraduate course on the topic, peer support groups that openly discuss these experiences. Students want to hear their professors addressing these implications of their studies and acknowledging the mental toll of environmental work. And they want to see more experiences to engage in those sources of resilience, such as time spent in nature, community building, and taking action. So those sources of resilience should be further integrated into programs of study, both in the curriculum and the physical campus spaces. It is also of the utmost importance that the root issue of the distress, which is climate change, is addressed both on the individual scale, but also by broader organizations and institutions and parties in power. And with aspects of community building, creative self-expression, and the potential for integrated action, photo voice methodology could prove useful in fostering resiliency and be directly implemented either into educational or therapeutic settings. So the results of this study suggest that photo voice may be a promising intervention to manage the mental health impacts of climate change experienced by youth and young adults. However, further research on the efficacy of photo voice methodology for this purpose, using larger sample sizes to strengthen validity, is required. Further research and action is necessary, particularly in the context of post-secondary institutions, as limited research has been done to understand the impacts of the climate crisis on mental health, and even less has been done to understand how we might begin to address these issues in practice. But an investment in the well-being of students and climate activists and researchers today is a step towards securing a healthy planet for tomorrow. And that's the end of my presentation. I know I crammed a lot in there, so let me know if there's any questions or follow-ups. On the screen there, you can find me on LinkedIn. You can also find the full thesis study on the repository at UW as well. So I'll stop sharing my screen so I can see all of you.
Awesome. Thanks so much, Beth. That was a really interesting presentation, and I really love seeing all the different pictures that your participants had sent into. And like it really hit home with me because I too, like I go camping at Killbear Provincial Park every year, and every year I go there and there's something that's been damaged or massively changed due to our changing climate. And it stresses me out. So I totally see why this is a highly important topic. So yeah, as Beth mentioned, we're opening the Q&A now, so feel free if you have anything on your mind to ask Beth. Now is the time. You can type them in the Q&A chat on the side, and then we can address those. I guess, so I know you're just starting graduate studies, right?
Yes, just in September, just very fresh, new, starting out as a student again in first year.
Exciting.
Yeah.
Are you looking to, like your graduate research, is it going to be super close to what you did for your undergrad, or you're thinking of taking a different route?
It's fairly connected, actually. It's part of a larger multi-year study that a couple profs in the School of Environment Resources and Sustainability are undertaking. But my project is basically going to be investigating what emotions undergraduate students in environmental studies or sciences are experiencing throughout their degree. So I think we're going to try and take some subsects from a grade 12 sample, beginning of undergrad, end of undergrad, and then potentially post-graduation to understand what emotions they're associating with their degree and the impacts of those emotional experiences on their learning or motivation or retention in the field of environmental studies. So very cool. Sort of similar field, a little bit of a different question, but yeah.
That's awesome. Oh, we have a question here. The question is, well, the images and quotes you shared are really powerful. I'm curious as to whether you think a photo voice project on climate change would be as effective if used in non-student populations or different generations.
Yeah, great question. I would say, from my biased opinion, yes. I found photo voice to be a really helpful methodology to use. It has been used in a very wide variety of communities and issue lenses in the literature. And I think definitely in terms of multiple generations, it's very accessible and can be really an engaging way to bridge the gap between sort of like citizen science and the people in the communities who often are experiencing the impacts of climate change most directly, with the people who are making the decisions in the community, who maybe are in, positions of power. So in its traditional application, that's kind of the goal, is that you at the end would share your findings with those folks in power to hopefully be able to inform decision-making processes. So I think definitely, yes, it has been used in a really wide variety of applications regarding climate change and work. It's really great at the local community scale. And I think really, yeah, you can engage any generation. I think you just might have to be mindful of the technological aspect depending on the generation, right? And what technology they're comfortable using. With my sample, they just all went out and used their cell phones, and that was totally fine because they all had cell phones or cameras or laptops that they could capture these things on. So that just might be something to consider. It's just the accessibility of the methodology.
Yep, totally makes sense. Keeping in mind, yeah, the ability of the generation that you're looking at and just adapting it to apply. That makes sense. Any other questions anybody else has? Some might be typing them.
No worries.
Is there anything else that on the top of your head that you think would be really interesting for like future researchers to go into? I know you mentioned at the end, so if you don't have anything on the top of your mind, that's totally fine. But if you do you have any suggestions?
Yeah, I think it would be amazing to try and involve students in the actual implementation of resilience boosting strategies. I have a lot of like follow-up questions and thoughts on the ways that we should be considering like the development of curriculum and maybe the emotional impacts of what we're teaching and how we plan to actually address those. I think in practice, environmental education and education in general tends to do, at least at UW from my experiences, tends to do a really good job of informing students on all of the data, research, information, theories, concepts that they need to know. But in terms of climate change, we don't tend to also address okay, that was a lot of that was sort of depressing and very difficult to emotionally sort of navigate. And it seems like a missed opportunity to not then discuss the impacts that information can have on individuals and communities and how we can incorporate resilience boosting strategies to make sure that our students are not only very informed, but also that they have the tools and knowledge that they need to be able to cope with that information that they're teaching and then learning and dispelling to other people. Yeah, I think it's just as important to make sure that we're sending out informed individuals as it is that we're sending out resilient individuals who are going to be able to continue in this field of work and make change and persist despite all of the challenges and the weight of the information that often they have to carry and engage with every day. So I don't know if that really answered the question. I think that might have gotten a bit off base,
No,
but
I think it does.
just some
No,
thoughts,
that's
for sure.
That's a good point. And yeah, guys, great suggestions. And something else that kind of stuck with me too a little bit, something that started your presentation, you mentioned something about like people in grad studies, if you're in a topic that might stress you out, like if you're working on the topic, it's not just like the stress accommodated with doing the research, it's also like how the topic impacts you as a person and having to face that every single day. Like, for example, like I do crime research. So like even I experienced that a little bit in that field as well. So yeah, it's just, yeah, very interesting. I'm not seeing any other questions. So thank you so much, Beth. A great presentation.
Yeah, thanks for having me. It's been great.
I know we're a few minutes ahead of time, but not too much, so I will hand things off to awesome Melissa Patorka, who will be moderating the next session.
Thanks, awesome, Ashley. Welcome, everyone. It is my pleasure to introduce the next group of presentations. This next one is going to be about the Campus Assessment Tool, a youth-led participatory research project. There are 4 folks joining us today. I will introduce each person and share a bit of a bio. So first is Jerica Little. Jerica uses she, her pronouns and is a postdoctoral fellow working jointly with the University of Waterloo and JAC.org. She received her PhD in Public Health and Health Systems at the University of Waterloo and was the lead researcher supporting the UW Committee on Student Mental Health. She's continuing her work in the area of post-secondary student mental health by developing the CAT student survey and has 2 adorable cats. Stuart McHenry uses he, him pronouns and is the knowledge translation lead at JAC.org, where he works directly with youth to improve mental health systems on campuses across the country. Prior to joining JAC.org, Stuart was involved in the academic labor movement and completed his master's degree in migration and ethnic relations from the University of Western Ontario. His master's research and community organizing experience continue to inform the work he does with JAC.org today. Erin Siwi is the Peer Health Education Coordinator at the University of Waterloo, where she develops programming for students and promotes wellness on campus. She is also a Human Resources Coordinator for the Canadian Red Cross and works to support their initiatives. Erin is graduating from the Professional Master of Education program at Queen's University this spring, focusing on student support and the decolonization of health education. Lastly, but not leastly, is Lama Abdallah, and Lama is in her final year of Health Studies program at UW with a specialization in health research and a minor in gerontology. She volunteers as a peer health education team lead, where she promotes mental health and wellness on campus by organizing public health campaign and events for students. She's one of the co-leagues for JAC.org's chapter at the University of Waterloo. She's also a member of the Campus Wellness Student Advisory Committee. Thank you so much for joining us all today, and I'm really looking forward to your presentation.
Awesome. Thank you for that introduction. Just gonna wait a sec. Oh, it looks like we got Erin on too, and Lama, I believe, is here as well. So I guess we're good to go if you want to queue up the slides there, Jerica. Okay. I'll get started. So hello, everyone. Good afternoon. Thank you all for being here to hear our presentation. And thanks to the conference organizers for having us here to discuss the important topic of campus mental health. So we're from JAC.org, and our presentation is titled The Campus Assessment Tool, a Youth-Led Participatory Research Project. So before we start, I'd like to acknowledge the land I currently occupy, Toronto. I'm located on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I also acknowledge that this land is covered by Treaty 13 with the Mississaugas of the Credit. My 3 co-presenters are all working out of the Waterloo area, which is located on the traditional territory of the neutral Anishinaabe and Haudenosaunee people situated on the Haldimand Tract, the land granted to the 6 nations that includes 6 miles on each side of the Grand River. These lands are also now home to many diverse First Nations, Inuit, and Métis people. So as we gather here today to discuss topics of mental health, we would be remiss to not name the impacts of colonialism on mental health. We recognize the impacts intergenerational trauma, negligent resource extraction, and systemic racism have on the health and well-being of those Indigenous to these lands. We have all arrived here in different contexts, but as settlers of these lands, we commit to the process of reconciliation by unlearning the ways in which we perpetuate colonial erasure and violence. We will continue to critically assess our relationship with the land, decolonize our practices, and speak up against acts of racism and colonial violence. We support the rights of Indigenous peoples to self-determine, self-govern, and have equitable access to these lands. Okay, so a little bit about Jack.org. So Jack.org, we're a national charity focused on training and empowering young people to improve mental health literacy and take action to change the mental health landscapes at their schools, in their communities, and across Canada. So one of the ways in which we equip youth to do this work is through the Campus Assessment Tool, or CAT as we'll refer to it, where we at Jack.org provide young leaders at university campuses with a comprehensive framework, research expertise, and coaching to help them document, analyze, and make sense of the mental health services, resources, policies, and practices on their campus. Groups of student advocates that participate in campuses work with us, the Jack.org staff, throughout the year to complete the research, and it can be done at any post-secondary institution in Canada. So far, 35 campuses across the country have participated in the CAT, with U Waterloo being one of them in the most recent cohort. So as we get into the presentation, Jarek and I are going to provide an overview of the project, while Emma and Aaron will be speaking to the specific findings at the University of Waterloo. Okay, so two main components to the CAT. The first is an audit framework, which I'm going to go over, and then the second portion is the student survey, which Jerica will cover. So as you can see in the graphic here, the audit framework is broken down into 4 sections. So the first section is just an environmental scan of available resources. Most students are able to find this information online through various school web pages. So this includes like an overview of the campus, so the various mental health services that are available to students both in person and remotely. As well, we look at things like insurance coverage for mental health practitioners off campus. Then the second section examines service provision and the processes in place at the wellness or the counseling center. So this looks at things like staffing, wait times, intake processes, referrals, and frameworks for care. And then sections 3 and 4 are more about the upstream policies and practices in place that go to promote and protect student mental health and create that environment where students can thrive. So this is looking at things like early alert systems, academic accommodations, mental health strategies, trainings that are available for staff, students, professors, and other early interventions in place so that students aren't reaching a point where they're constantly struggling and needing formal mental health care. And then for sections 2 to 4, all the information is typically gathered through interviews that students conduct with health and wellness staff. So not only are the students collecting this important data, but they're building relationships with key mental health stakeholders on campus along the way. And then all the research for this audit framework is led and completed by the students. So that's it for the audit framework. Hopefully that overview was helpful, and I'll pass it to Jerica, who's going to discuss the second part of the tool, which is the student survey.
Okay, I am unmuted, so correct. Okay. Well, next to mention the second part of the project is the student survey. And so while the audit framework provides a really thorough overview of what resources and services and policies are available on a campus, it doesn't really give us insight into how students are interacting with them or not interacting with them, as the case may be. And to fill that gap, we need to get information from students. So the survey is designed to address that gap by doing a broader survey of the student population, specifically focusing on service use, service awareness, and for those who have used services, the satisfaction with the services received. And at the same time that we're gathering this data, the other novel aspect of the survey is that students are involved in virtually every process, including both research, implementation, and knowledge translation. And so it allows them to meaningfully engage in service evaluation and quality improvement on campus, kind of following a participatory patient research model that other health systems are using. And the post-secondary campus is a health system and should be recognized as such. They are performing valuable health services. And so at UW, they are a little bit ahead in terms of engaging students. Students are engaged in many different ways through advisory committees, as well as the JAC chapter, who you'll be hearing from in a little bit on their findings for the audit framework. And to just give you a brief overview of what's kind of included in the student survey, we model it after the Anderson-Newman behavioral model of health service use. And that kind of posits that service use outcomes can be predicted using 3 types of information. So the student survey will be focusing on those predisposing factors. So things like demographic characteristics, academic status, if you're a first year or fourth year, your awareness of services might be different, your own health beliefs. So what you've heard about services or what you believe about services will also influence how likely you are to use them throughout the future. But ideally, the primary factor that should predict service use is the need for mental health services. So in an equitable system, if you need mental health care, you receive mental health care. And what the survey will allow us to do is kind of see where those strengths exist. So I know UW has done a lot of work on improving access to all kinds of services, like for depression, anxiety, stress. But we might be able to see if there are some gaps where those exist as well. And then we'll also pull in information from the audit framework to see which institutional characteristics predict service use. And speaking of the audit framework, I want to pass the presentation along to our 2 stars today. Our JAC chapter leads Lama and Aaron, who did some incredible work on the audit framework. And they're going to walk you through that now.
So as part of the JAC.org campus assessment tool, our research was split into several sections. The audit compiled information on mental health services, resources, policies offered on campus, as well as institutional level characteristics of the mental health system to provide data about mental health services. We looked at accessible resources for students, programs with peer-to-peer support, and inclusive and culturally appropriate resources. Waterloo has multiple initiatives and events to promote positive mental health and well-being for students, including various in-person and virtual helplines and text-based services and video counseling options. Examples of support include peer-to-peer support. For example, the University of Waterloo has several programs like MATES, which provides services to students who are experiencing social difficulties and transitional challenges adapting to university life or to different cultures. They also offer RAISE, which is a student-based service for education, advocacy, and peer support and community building. For Indigenous students, there is a counselor for Indigenous student support, and the Waterloo Indigenous Student Center holds events, cultural activities, and more services for our Indigenous students. There are also supports for students like the GLOW Center, the Women's Center, and the Sexual Violence Prevention and Response Office. We spoke with the manager at Counseling Services to understand different policies and activities related to mental health and examined policies and procedures and asked how these different policies influence mental health on campus. To provide more support to students, there are formal partnerships in place and referral pathways to off-campus services such as Empower Me, Here 24/7, and the Sexual Assault Support Center. With these referrals, staff at Waterloo provide different levels of empowerment, including by giving a list of potential services, by a clinician helping make that referral, by either helping the student make the call, calling together, or sitting in on appointment with the patient to help them connect with outside resources. For staff and DONs and other peer leaders, there's free mental health training available to support students, as well as free mental health training to provide more support and increase advocacy work. There are also many options for increased education and a variety of resources for students to access. We were happy to discover in our research that more peer support programs and educational seminar options were available than we had originally anticipated and expected.
Erin, you just need to unmute yourself.
Thank you, Melissa. Sorry about that, everyone. So overall, the university does offer a big variety of supports for students and for staff. We did identify 3 main strengths and areas of growth from the CAT information. So to start off with our strengths, we love that there was training for instructors, TAs, students, and others who are part of the UW community. Some of these included more feet on the ground and the recognizing and responding to a person in distress workshop. There are also a lot of options for students to choose from for support, including peer-to-peer support like MATES, on-campus resources, off-campus partnerships, and other referral options too. We really looked into accessible resources for students, programs with this peer-to-peer support, and ones that were inclusive and culturally appropriate. We loved how many multiple initiatives and events that there are to promote positive mental health and well-being for students. Our third strength too was we loved the proactive approach. The people that we spoke to mainly talked about recognizing that all students may be at risk, regardless of their current academic performance. So ensuring students are aware of the resources available to them and making sure that they have that knowledge if they are in crisis is a really main focus. For areas of growth, one thing that we talked about was the communication of resources to students. So for example, developing a convenient list of all the resources available to students that they can just quickly refer to and creating a clear website for contacting them. The availability of information can be a little hard to understand and how those services are linked and how they work. A more central hub would just be very beneficial. We also would like to encourage instructors to participate more in optional opportunities such as presentations, seminars, and certificate programs to be able to better support their students. And our third one was that we want to empower students to reflect on their own mental health and reach out if they need help. We want to make sure that they feel comfortable, included, and safe doing so. But from our discussions with different people working in mental health at the university, it seems like many of these changes are already in progress or starting to be planned. It really made us feel like the university is on the right track concerning student mental health and coming up with actions that we can work on as a JAC.org chapter as well. We're really happy to see with all the changes that seem to be occurring. It seems really significant for student mental health right now.
Next, I'm going to go over a few reflections that our team came up with from the student perspective of participating in the CAT. So the first reflection is just how important it is to include students in mental health planning at schools, and that projects like the CAT and like JAC.org allow for student needs to become known on a system-wide level, which can lead to more comprehensive and student-centered program development, which is something that we believe in as a chapter. The second reflection is that collaboration between students and staff on topics like mental health allows for stronger discussion. And there's multiple examples of this type of collaboration on our campus, including JAC.org CAT and the Wellness Collaborative and the Student Advisory Committee for Campus Wellness. So definitely on the right track for involving students and staff in these discussions together on the same team. Number three is, again, the need for a central hub of information. Just from trying to gather all this information from different sources on campus, we found that we had to interview a lot of different departments and we had to go to a lot of different websites. So compiling all that information into a central place would be very beneficial from the student perspective. And the fourth reflection is that it was really comforting to hear that our university has a lot of available training for instructors and TAs and peer leaders to promote mental health and wellness, and that we're starting to encourage our staff and our peer leaders to get more educated on how to support students.
So overall, we are really happy to work with JAC.org over this. I think the students that participated really gained some great experience conducting research, interviewing, and advocacy planning during this process. We also liked having the opportunity to examine all of the existing resources at the university. We learned a lot about peer-to-peer support, even health insurance and counseling options. This project really let us kind of build a foundation of information to share with our students and build more awareness. Our initial challenge during this was accessing all of the information required for the CAT. We had so many people working in mental health willing to really step up and help us. So building these relationships has really helped us to understand our mental health landscape. For our action plans and next steps, we personally hope for JAC.org and for peer health education to use the data from the CAT to inform all of our advocacy work with students for improved mental health promotion, policy, and service provision on campus. We hope to kind of seize this opportunity to adopt inclusive and appropriate programs for students that focus around decolonizing health education, ensure student and faculty representation, provide and create resources focusing on health literacy, and become more proactive rather than reactive in seeking supportive partnerships and educating students. In terms of our future goals, we also identified promoting resources and accessibility and awareness, increasing educational seminars and training, especially regarding equity-seeking groups for culturally sensitive or appropriate counseling, and advocating for mental health training to be more highly attended by staff and by students. So our main goal is to just continue to build successful outreach programs, participate more fully in campus-wide events to increase engagement and education, and empower students to access the resources that are available to them.
Okay, so I'll just wrap up with some of the next steps for the project overall. And so just coming off of what Lama and Erin were saying about the audit framework, there is some amazing work in there. They really covered like every aspect of anything involving mental health across UW, and it was an enormous amount of work. So I really highly recommend that everybody, after the presentation, contact Erin to access a copy of the framework so you can see all of the different information that they gathered. For the student survey, we are implementing that in November and again in March, and we will be doing a random 25% sample of students because it's a new survey, so it's a pilot study, so we want to initially start a little bit smaller, make sure the survey is reliable and valid, and then look into making a larger dissemination period later. But for now, some of you, if you are students, may receive the link next month. After that, we will be working on a data report that summarizes information from both the audit framework and the student survey. And we'll be giving that data report to Erin and to Lama. And so if you would like to see the results from both of these sources combined to get an overview of what is going on campus, again, you can contact Erin and Lama to receive that. That should be available in January, and then we will update it in April to include the Wave 2 survey results. And if you just want more information on the project going forward in general, you can contact the JAC chapter students, who at this time are Erin and Lama, myself and Stu at jac.org. And then we are launching a new webpage for the CAT at jac.org/CAT. There will be the annual report that covers all the schools that participated and have more information on the project. And so if you do want to contact us for more information, here is where you can do so. And I think that will conclude our presentation. So thank you, Stu, and then Erin and Lama again for all the incredible work you did.
Wonderful. Thank you so much, Jerica, Stewart, Erin, and Lama for that great presentation. It's a very timely and relevant presentation and a really exciting project. I'm now going to encourage everyone to put their questions in the Q&A, and I will be happy to read those out. While we're waiting for that to come in, maybe we can have, I found this very interesting. I work in campus wellness and think, wow, this is information that we should get in front of people. And so I just was wondering, how do you plan to get some of, beyond this conference, this information in front of some of our decision makers who can hopefully kind of mobilize resources and make sure that what is found and has been expressed by students can be realized. And anyone can jump in and answer that question or share thoughts.
I can jump in. I know that Jerica's survey as well is going to just be a huge part of getting the student voice kind of out there and getting us to recognize it. So I'm really excited to see the results from that. I think on a smaller scale, just for kind of empowering students, we'll be using this information for peer health education in our seminars and in all of our events, just to help with resource recognition and hopefully empowering them to take those steps themselves.
Great, thanks, Erin.
And then we should also be sharing the results at various different mental health conferences, the Canadian Institution for Campus Mental Health. I think that's CICMH. I get my acronyms mixed up. Certainly that one and a few other conferences going forward. We will release publications once they are ready, both through our website and also through a couple of academic journals. We'll be sharing them consistently through the JAC chapter and the Wellness Collaborative and the Peer Health Education team. And our knowledge translation leads may also have some additional communication channels. But I think those are a lot of the main ones.
Great, thanks.
Yeah, I think you covered it there, Jerica and Erin combined. I think the combination of like the local at Waterloo along with the stuff that we do to disseminate on a more national scale. So thank you for that.
Thank you. I'm also curious as to, is Waterloo one of the first campuses to do this? Or how many other campuses have been involved? And are you finding kind of, well, I'll start with that piece first.
So Waterloo is going to be one of the first to pilot the new survey. So we piloted the campus assessment tool back in 2018, 2019, but it's gone through a lot of iterations, and we're at a point now with Jerica on board to have a much more rigorous survey with hopefully some really strong data there. And then the audit framework has kind of changed throughout the years. So we've had 35, including the ones that are participating this year, 35, but with kind of the current iteration of the survey, this is the first year of that. That answers the question. Was there another piece I'm missing?
Yeah, I think I was moving on to another piece, but yeah, whether the audit, like if you're finding similar trends across in other institutions with the auditing process.
Yeah, I think the national report does like a fairly good job at kind of highlighting some of those trends. So you can for folks in the audience take a look at jac.org/cat. But I think like wait times tend to be a consistent issue across the country, is something we're seeing. I think as more and more folks are doing the tool, we're seeing more like mental health strategies, more early alert systems, like kind of concerted and kind of centralized efforts to like protect mental health on campus. So yeah, those are a couple maybe off the top of my head of like trends that we're seeing. But yeah, definitely feel free to contact us for more of the kind of like conversations around what we're seeing on more of a national scale. Again, we only have like a sample of campuses, so we can't quite make like national or sweeping conclusions, but we are starting to to see themes emerge from the years that it's been done.
Great, thank you so much. I'm realizing that it's already time for me to move on, and my only real job for today is to keep us on time. So while I'd love to engage in more conversation with you, I just want to say thank you and encourage all of you to reach out to this awesome team. Thanks so much. So the next presentation, it's my honor to introduce Vidya Shweta Dewan, who is going to be presenting for us today on Ayurveda healthy practices to restore mental health. Vidya Shweta has a PhD and is a doctor of Ayurvedic medicine trained in classical Ayurveda from esteemed universities in India. She offers training in Ayurveda along with consultations globally. Her mission is to make Ayurveda accessible to everyone in Canada and to promote health and wellness by simplifying Ayurveda. Dr. Shweta started her health coaching company, Ayush for Life, in Waterloo. She is also a trained certified doula with Dona International and volunteers with Breastfeeding Buddies of Kitchener. Her specialization includes pulse diagnosis, mental health restoration, marmoth therapy, and Ayurvedic dietary and lifestyle management. Thank you so much, Vaidya. Happy to pass it over to you.
Thank you so much. That I am going to share my screen shortly. Am I audible?
Yes, you are.
Okay, perfect. Just a moment. Okay. Let me know when you can see my screen.
I can see it.
Okay, perfect. Thank you so much, everyone. Welcome, everyone. I really appreciate your time. I'm going to start my presentation by reciting a sutra, which is a very important part of our traditional practice. Ragatirogan satatanushatan asheshikaya prasitan asheshan Atsukya moharatitan jagana yo purvu vetyay namostu tasmai. I bow down to the God, the Creator. I bow down to my parents. I bow down to the Ayurveda classics. I bow down to my teachers and Guru who taught me this wonderful science. And here I am in front of you to share few superficial overview of what Ayurveda is. It's a whole new fields to explore when it comes to Canada, when it comes to practices, holistic practices that are especially catering to mental health outside of India. So Ayurveda is one of the oldest healthcare system originating from India. It's around 5,000 years old. And there's a huge landscape, huge medical system of learning Ayurveda. There's a 5.5 year course when you're starting when you're starting to learn Ayurveda. So I'll try my best to simplify and cover this up in this short period of time. So let's by the end of this presentation, I hope you get few insights on what all to incorporate in your life in order to stay calm, in order to stay grounded, in order to be present and aware of your surroundings. So let's move on. What is Ayurveda? Ayurveda is basically a big healthcare system from India that has huge, let lay emphasis on huge on body, mind, and spirit. So when it comes to being healthy, it's not about the physical component of your body. It also entails your mental health, your spiritual health, your psychological health, your emotional health. And you all might be aware of this definition when it's who is a healthy person, when WHO coined that health is not an absence of disease, but presence of a person being happy as well. And I feel proud that when it comes to being a swasthya basically in Sanskrit means being healthy. So when it comes to talking about being healthy, Ayurveda focuses on your mind and Ayurveda focuses on your spirit. There's a beautiful sutra in Ayurveda which is called Swasthasya Swasthya Rakshanam Aturasya Vikar Prashanam Cha, which is the first sutra. So basically Ayurveda, when we talk about learning Ayurveda, there are two prime true crime books or classical texts from where we learn Ayurveda. One of them is Charak Samhita, and the second one is Shushruta Samhita. Primarily, of course, there are so many other books that came along after these Vedas were introduced. So the first, lesson that they teach you is you need to focus on the preventive side of your health so that you don't land up in, getting a disease over time. So the main focus, the main first half while you read Ayurveda is focus on the preventive aspect. And then if you do get, ill or you do get a disease, then focus on the treatment or management part. So that's the beauty of, learning Ayurveda. The word Ayurveda primarily is made up of two words. It's Ayu, which means a healthy life, and Veda, which means the knowledge. So science that tells you how to live healthily is called Ayurveda. And I'm aware of this fact that yoga is quite I would say quite prime when we talk about doing some exercise. Those who are not interested in going to a gym opting for yoga. Everyone knows about yoga, but little do people understand that yoga and Ayurveda, they are sister sciences. They are twin, sciences. Their philosophies are very much similar, and both have impact on each other when it comes to being healthy, when it comes to being swasthya. Now, the next part is, okay, we know what's the definition of Ayurveda, but how does Ayurveda work? Like, how can it help in what are the basic, principles of Ayurveda? How does it help in restoring our mental health? To understand it, we need to have an open mind where we are not looking Ayurveda, a non-Eurocentric, medical practice through the lens of the mainstream science. If someone is diagnosed as depression, there is no any treatment of depression in Ayurveda, but we can decode it that someone is diagnosed as depression in Ayurvedic health parameters, and then we can assess that based upon Ayurvedic diagnostic parameters and come up with a solution, Ayurvedic solutions, right? To need to understand that, we need to understand the basics, the fundamentals of Ayurveda. And if you have come across this word more than often, Ayurveda, you might have come across, if you Google, there's so much content out there. Some of them are, authentic content. Some of them are just, author's opinion. There are a lot of words or keywords that you find associated with Ayurveda. One of them is Tridosha or Panch Mahabhut or Ayurvedic body quizzes. You might, land up in just exploring those quizzes on a website. Okay, let me find out what my body constitution is. Then there is concept of Nadi Pariksha or pulse diagnosis. And then there is Panchakarma or cleansing therapies. There is lots of, information going around on the internet when it comes to cleansing, detoxification. Now, where do these all land up when it comes to Ayurveda? So first things first, I'll cover this up in a small piece, but there are like, whole chapters when it comes to understanding the doshas, three doshas. So three doshas and Pancha Mahabhut, basically they unite, they intertwine. So what Ayurveda says is we all in this whole wide world are made up of 5 basic universal elements. And what are those? Those are ether, air, fire, water, earth. These are 5 basic universal elements. And the combination of these elements, they form 3 doshas in our body. So if I were to, if I were to just cut, myself in half, I won't be able to find all those 3 doshas. They basically manifest in the form of all the physiological functions of the body. So what I mean is the space and ether element, they unite to form Vata dosha. The water and fire element, they unite to form Pitta dosha. And water and earth element, they combine to form Kapha dosha. Now, if I were to just, of course it is more than that, but if I were to give one keyword to each and every dosha, what word would I pick? I would pick movement for Vata dosha. So basically every movement in your body is based because your Vata dosha it's working. Let's say it's working. And anything related to digestion or metabolism is related to Pitta dosha, and anything related to anabolism or union of 2 things together is basically Kapha dosha. Now, how does this help us? Like understanding the basics, but how does this help when it comes to understanding the mind and mental health? So Ayurveda says that every person has different cognitive mind maps. Every person is different. And in order to cater to find a solution to different mental health problems, we need to understand that cognitive mind map in order to provide the best customized solution to every person who is having some kind of mental health issues. And I'm going to discuss this in a minute, where I will discuss 3 cases with you, and if you look at those cases, you might relate that, okay, this sounds like someone I know from my circle. This is very much familiar, and it will be interesting for you to know that Ayurveda has customized solutions as well as generalized solutions for mental health. I'm not going to talk about Nadi Pariksha or Panchakarma, since these are something which need another session or so. But yeah, these are the common terms that you might, keywords that you might end up knowing while searching for Ayurveda. So one of the most common, again, terms that comes up with Ayurveda is tamasic diet or Rajasic diet or Sattvic diet, or while you're searching yoga, they emphasize on having a Sattvic diet. Anything which is fresh, anything which has energy, anything which has prana in it, basically helps you understand your mind better and be aware of the surroundings. So eating, all the processed food, eating, again, meat-based diet, or eating fermented foods, they come in a different categories of food. Not necessarily that they are bad, but they just, they have divided according to yogic and Ayurvedic philosophies. Diet play a very, very important role when it comes to your mental health. So Ayurveda focuses on eating Sattvic diet, especially for students, which will primarily entail all the fresh fruits of warm cooked food, anything that you like, which is warm in nature, anything which has good source of fats in it, for example, ghee, that is Sattvic diet. And then there are lifestyle changes. for example, dinacharya. Ayurveda talks about the concept of dinacharya, which is basically, incorporating daily routine, having a routine, and that too on a consistent basis, and doing them consistently will help in having more focus and clarity on a day-to-day basis. And of course, there are herbal interventions in Ayurveda. Different herbs are given by Ayurveda experts, Ayurveda professionals. And last but not the least, for which I'm going to talk about in detail, is the marma therapy. Marma therapy, and I'm going to help you identify those energy points in the body. So the three cases that I was about to talk when it comes to your, mental health issues. So Kim, she's 15. She has, from a mainstream perspective, she has been diagnosed with anxiety. She has fear of darkness, has disturbed sleep. Sleep issues are there. There are pains. Sometimes the day is good, sometimes it's bad. This is case number 1. Okay. And I'm going to talk about the Vata balancing measures after this slide. Then let's talk about case number 2. The person is 23 years old, corporate attorney, has anger issues. He's very intellectual, but he's restless. He indulges in more spicy food, drinking, have more is sexually very, very active, and stays late at night, and has problems with hyperacidity. So this is another, case to look at. And then there is a third case, Martha, she's 20. She has, again, been diagnosed as bipolar depression. She has alternating mood of periods of low mood and extremely high energy periods. Sometimes she feels sad, sometimes she feels worried, doesn't have an eating schedule, her sleep is all over the place, and sometimes has headaches, sometimes stomach aches. So from a mainstream perspective, these are different diseases, diagnosis is different, and so would be the management of these mental health issues. But if they were to opt for Ayurveda, you would be surprised. All these three cases has a typical, like all the different systems, the physical systems and the emotional system in the body can be related to or mapped down to these 3 doshas that I talked about earlier. So once you are able to diagnose, low mood or, extremely high periods of high energy periods, the eating schedule is all over the place, sleep issues. Once you diagnose all these things and map down to, okay, this person needs Vata balancing lifestyle or Vata balancing measures, this person needs Pitta balancing, and this person needs Kapha balancing. You would be surprised there is no any single medication that can give them the relief. However, if we do some interventions when it comes to diet, when it comes to lifestyle, and when it comes to meditation techniques, all these problems, the patient themselves tell the Ayurvedic practitioners that there's huge relief in their problems. For example, if Martha were to go to a doctor, mainstream doctor, and say that she's having headache or she's having stomachache, there will be a list of investigations going on. And then based upon that, maybe she would be given different medication for her stomach aches and different medication for her headaches. But when it comes to Ayurveda, just, having a correct diagnosis, of course, when it comes to what kind of dosha imbalance she is suffering from, the dosha-associated measures can be given to the patients to help them get relief with their mental health issues. And meditation on the top of that is just, I would say, generic solution that that is now more common in Northern Hemisphere when it comes to US, in Canada. So meditation is just, there are customized meditation techniques too for each of these 3 cases that I mentioned. So one of the generalized solution for mental health issues that we can talk about is marma therapy. What is marma therapy? So let's talk about marma therapy. Marma therapy is basically the energy points on the body. Those energy points are the gateway to where different, these are gateway to your neuroendocrine immunological energy points, gateway to the energy. And according to Ayurveda, when this energy gets blocked, you suffer from disease. However, if you stimulate them on a consistent basis, like on a daily basis, you open up those channels which are blocked, those energy channels which are blocked, and then that's how you can prevent all these mental health issues that can take a heavy toll on your mental health. So these are the benefits. There's normal functioning of all the 3 doshas that comes in. There's enhanced immunity in your body and overall general well-being, the happiness, all the factors that I talked about, the physical component, the spiritual, the mental, all these, they get in line. I'm going to help you identify these 5 points, and I'll be very, very quick. The first one is the Stapni mud. Now, how to locate the Stapni mud? It's between the center of your eyebrows. And if you want to go along with me right now, that is fine too, because I always love my marma therapy sessions. So what you have to do is take your thumb, right, left, doesn't matter. And you have to stimulate this in an upward movement. Now, if your friends are in Hindu or Indian community, you might find that they wear a tika on their forehead. So that's quite common. Hindu practices and Ayurvedic practices, they really align themselves. So when you stimulate, and this middle of the forehead, basically from a mainstream science, there are important anatomical structures behind this. Glabella, the center of forehead, it's the union of various veins, nerves, muscles, arteries, veins. They all intersect. This is a very important part of human body, and from a yogic perspective too, philosophy too, this is the center of third eye or Agya Chakra. So when you stimulate this point, you're basically anything which is, if the energy is blocked over here, it gets stimulated and this channel opens up, which is again very much needed in order to prevent yourself from overthinking, and again, please be aware that you do not have to see through the lens of mainstream science how Ayurveda works, because the basics are totally, fundamentals are different. Like you might think how this thing over this short act can really help in overcoming mental health, but this is the fact because this has been practiced in India for years and years now. So take some oil, have a night routine, take some almond oil, coconut oil, just have them on your fingertips, and then just stimulate this Stapni mud 15 times at night. So before going to bed, have a consistent period of time, like night time that you are going on bed, let's say 10 p.m. So do 10 minutes before bedtime. It just takes, hardly 3 minutes, 2-3 minutes. So 15 times you just stimulate this Stapni mud, with positive energy, that this is going to be very, very, you're taking a preventive measure in order to heal yourself, right? And person suffering from, anxiety, suffering from insomnia, suffering from overthinking thoughts, the trail of negative thoughts. All these people are the best eligible people to start, practicing this.
Dr. Shweta, I'm so sorry to interrupt you. I appreciate what an impossible task it is to try and share with us this fundamentally different way, and it's resonating so much with me. I'm interrupting you only to let you know that probably wrapping up in the next minute would be great. I'm sorry, I know that's not easy. And I'm going to encourage folks, so we can finish hearing what you were saying, to include their Q&A in the chat, and we'll make sure it gets to you. And please reach out directly to Dr. Shweta, because this has been very enlightening.
I appreciate your thoughts. Absolutely, I'll wrap up in next 2 minutes. So this is first one is the Tapni Marm, just in between the eyebrows. That's the first point. The next comes the Shankha. So basically, those people who wear specs, just like me, wherever the specs, they hang on your ears, or you can, see the last of your eyebrows, the pulsating you feel is the Shankha Marma. That's the point. Or if I were to say, when you feel headache, frontal headache, you just keep, by default, your body intuition is to keep your hands like this, right? So that's the point. Like, your body intuition also knows, like, what's that point which will help you get relief of that headache. So this is, take some oil, almond oil, coconut oil, and just, try to stimulate this point. Again, you can do this 15 times, right? And again, this takes, 30 seconds or so, and that's it. So this is Shankha Marma. Then comes the Adhipati. Now, you might, again, I'll go back to, if you have Hindu friends, you might have seen when they visit someone elder in the family, they will try to touch their feet, and then the elders, they put their hand on their, head. So basically, this is the point where there are hair whorls, right? The whorls of the hair, they turn either left or right. That's the point I'm talking about. The posterior fontanelle is the Adhipati Marm, right? So you take your fingers and just try to stimulate them, with oil, without oil. That's absolutely on your discretion. And you just try to stimulate this point 15 times. This is, again, very helpful in keeping you, grounded, very helpful in keeping you calm, especially when you include this in your nighttime practice. Next comes the Utchepa Marma. So basically, your eyebrows, where their shape changes, is the Utchepa Marma. Don't confuse it with the Shankha Marma. Shankha is on the sides of where the eyebrows end, and where the eyebrows bend, these are the Utchepa Marma. So you just, stimulate it, close your eyes, stimulate it for 15 times, and we are good. The last but not the least is the Phana Marma. Phana Marma is basically on the nasolabial fold, so on across your, nasal passages, olfactory nerves, muscles. These pass through this important, there's ethmoid sinus and frontal sinus above. So basically, you are, with your pinky finger, you are stimulating these for 15 times. And that's it. First is the Tapani, Shankha, Adhipati, Utchepa, and Phana Marma. These are the 5 points. If and a generalized solution, if you incorporate, marma therapy in your nighttime practice, I promise you that you can really do a lot when it comes to your mental health, overthinking. And of course, there's no there's always a customized solution for everyone when it comes to Ayurveda. And I know I was a little rushed. I'm sorry, but I tried to simplify it as much as possible. I'm still a student. I studied this for 13 years of my life, and I'm a third generation practitioner from my family, but still I'm learning. What I'm trying to say is incorporate them and you will see the results. If you want to reach out to me, please feel free to contact me. This is my email address. I really appreciate your time. My special shout out to Wellness Department, University of Waterloo, who gave me this opportunity to share this presentation with you all. Thank you so much. Thank you. I really appreciate it.
Thank you so much, Dr. Shweta. It was so great to hear from you, and I'm sorry we were tight on time. There was no way to do that justice in such a short period of time, and hopefully we have other ways to continue this conversation.
Hi, everyone. Welcome back. Thanks for sticking around for this last session, and we have some very exciting presenters. So I'm Jennifer McCorston. I'm the Associate Director of Health Promotion and Campus Wellness, and I will be, I guess, the moderator for the next several sessions. So we're going to start first with Karolina Kaminska. Karolina, are you ready? I just want to make sure you're ready before I do your intro.
Hello, I'm here. I am ready.
Oh, perfect. Okay. Is it Karolina or Carolina?
Karolina, thank you.
Karolina, perfect. Okay, so Karolina is pursuing her PhD in Public Health Sciences as a second-year student in the Faculty of Health here at the University of Waterloo, working under the supervision of Dr. Chris Perlman, and is interested in researching how to improve the services to people with concurrent mental health substance use disorders. So Karolina achieved her Bachelor of Health Sciences and Master's in Health Systems at the University of Ottawa, and has since worked with several national and international nonprofit healthcare organizations that have provided her with a systems level perspective and experience in research analysis and program evaluation. So we're happy to have you, Karolina, and I will hand it over to you now.
Wonderful. Just going to share my slides, of course. Let me know if you see it correctly.
Yes, I can see it. So we'll just make sure, yeah, now you're
all good? Okay, perfect. Thank you very much, Jennifer, for that lovely introduction. So my name is Karolina, and today I'm going to be talking to you about the 4-pillar approach to Canadian drug policy, looking at its implementation and impact, and looking at some examples in the student context. So to begin, what do we mean by substance use? The substance part of the term substance use includes a range of products like alcohol, tobacco, cannabis, and controlled drugs. The use in substance use falls on a spectrum ranging all the way from non-use to beneficial use, lower risk use, higher risk use, and substance use disorder, otherwise known as addiction or dependence. Many connections exist between substance use and mental health. For example, substance use disorder is a diagnosable mental disorder as identified in the DSM-5. Additionally, there is a high level of co-occurrence of substance issues with mental illnesses. In terms of drug policy, Canada has had several drug-related policies over its history, but it wasn't until 1987 that the first national level drug strategy was introduced. Over the next decade, updated phases were implemented, but it wasn't until 1998 that the 4-pillar approach was introduced. This 4-pillar approach consists of prevention, treatment, harm reduction, and enforcement, all supported by a strong evidence base. Broadly speaking, prevention tries to address substance use before it becomes an issue. Treatment supports individuals engaging with available treatment and rehabilitation options. Harm reduction reduces the negative consequences associated with substances while meeting people where they are at and not assuming that abstinence or recovery is necessarily the goal. And enforcement covers the legal perspective associated with substances and drug trafficking. So back to the timeline, since 1998, the four-pillar approach went through some changes, including the brief removal of the harm reduction pillar between 2007 and 2016. In 2016, it was reintroduced into the Canadian Drugs and Substances Strategy, which continues as the federal Canadian drug policy we have today. I left a box at the end of this timeline with a question mark because despite the four-pillar approach we have, there has been increasing focus and interest in harm reduction approaches. And I would like to leave you with the question about whether we may be seeing a policy that focuses primarily on harm reduction in the future. So with regards to the implementation of the current Canadian Drugs and Substances Strategy, or CDSS for short, here are some highlighted articles which discuss positive and negative perceptions. So the first describes how, although there is anecdotal evidence of positive outcomes, there were several barriers that led to constricted implementation and inability to produce performance measurement results. The second criticizes how, although this strategy theoretically considers four pillars, the structure of the four-pillar approach may not actually be reflective of best practice and may be a product of political influence instead. The third article looks at CDSS in the context of the opioid crisis and describes how, although many activities were completed to respond to this crisis, there still remain many service and system level gaps. In terms of impact, evidence suggests that this policy does not respond to individual risks, needs, or social determinants of health. CDSS is not being implemented equally and further propagates the criminalized approach dominant throughout Canadian drug policy history. It also continues to exacerbate inequities, stigma, and does not address lack of availability of prevention, treatment, and harm reduction services. As I previously mentioned, there is growing interest in focusing more on harm reduction approaches as a solution to the CDSS. One argument for harm reduction approaches is that they are at minimum as effective as abstinence-based approaches and at maximum more effective. Various harm reduction treatment options are producing positive outcomes for patients and systems. Application of harm reduction to other sectors, like law enforcement, have the potential to further expand public safety and reduce death. Harm reduction is also effective at addressing stigma, which is a major issue in the field of mental health and addiction. Okay, so that was a bit of a quick introduction to Canadian drug policy. So now switching over to the student context. On this slide, I have listed some literature that provides insight into the prevalence of substance use among students. From the first and top source, we see that a high proportion of junior high and high school students are already trying various substances, including cigarettes, alcohol, and cannabis. From the middle source, we see that a relatively high proportion of college and university students misuse controlled substances, including pain medication, sedatives, and stimulants. And from the bottom row, we see that a not insignificant amount of youth aged 15 to 24 suffer from co-occurring substance use and mental health disorders. Naturally, therefore, we want to know, within the context of this four-pillar approach, what is being done across Canadian campuses to try and minimize harms associated with substance use, misuse, and addiction. Thankfully, there are many notable examples existing across the country. Here, I have highlighted just a few, so I'll go through them right now. So for the first on the left, for example, is the Post-Secondary Education Partnership Alcohol Harms, or PEPA for short, which is a pan-Canadian network that developed a system-level framework for addressing alcohol harms on campus. Various professionals make up this network and use it to exchange information on initiatives and take their learning back to their schools to improve education, prevention, and harm reduction efforts. The second notable example is UBC's Harm Reduction Team, or HART, which consists of students and provides on-campus education, training, drug checking, and recovery support for their peers in need. The third example is the Know Your Drugs 101 toolkit, which was developed by the Canadian Students for Sensible Drug Policy Toronto chapter and which is a document that helps inform students on safer drug use. The fourth example is a research study that came out of CAMH, which looked at police involvement in emergency mental health transfers from university health clinics to hospitals. This study produced recommendations around having less police presence around campus and having less use of handcuffs on students. Lastly, Good to Talk is an Ontario-wide helpline for post-secondary students needing to talk to someone about mental health and substance use issues. And here at University of Waterloo, we also have many initiatives and governance structures concerning substance use and mental health. On the slide, you will notice a variety of student-led teams and collaboratives to increase awareness and harms associated with substances on campus and to improve wellness among the student population. So these include the Campus Wellness Substance Use Team and Substance Harm Reduction Group, as well as the Campus Wellness Collaborative Mental Wellness Priority. There are also several local services listed on our website, including a Rapid Access Addiction Clinic and Impact, which is a partnership between police and crisis team workers on campus so that a mental health support worker accompanies police at every emergency call. In addition, various committees and policies are focused on substance use and mental health at UW. If you are interested in learning more, you can click the link to any of these items listed on this slide. So obviously, despite all this great work being done, there is always room for improvement, as we saw in the critique of the CDSS. I have provided here a few ideas of areas where current initiatives could be further improved. They include further promoting current initiatives, expanding existing policies and governance structures, having a comprehensive camp drug strategy, explicitly using harm reduction or furthering the use of harm reduction and leveraging more of performance measurement and evaluation. I've also made mention of having more training available, as well as further leveraging existing practices from other campuses to improve impact of UW initiatives. So with that, I am finished. Please find my contact information here if you have any questions or would like to get in touch. I have access to any of the references if you would like to have more information. So thank you very much for having me.
Okay. Thank you. Thank you, Carolina. Really good history there. And I really appreciated even understanding, or I wasn't aware that harm reduction was removed from the policy for several years before put back in. So just a question for you then is, in your experience from reviewing all of this framework and all of the moving pieces of it, for young people, what would be your opinion of what might have the most impact? Is it policy level change, like pricing and things like that? Is it education that influences individual level behaviors, or is it really addressing root causes and underlying reasons like mental health and other reasons why young people might engage in substances, which I've read some literature around, like especially in rural areas, it's often because of there's lack of other opportunities for things to do, like physical activity and things. So like, do you have an opinion on if we could only start or really concentrate our efforts in one area, what it would be?
Oh, that's a big question. Obviously, I'm on my sort of journey to learning about this field more. So I have a couple ideas, but I'm sure as I continue in my PhD, that will become a bit more refined. I mean, I think the first thing, at least what I'm focusing on, so it seems prominent in my mind, is just being able to access any sort of help or services to begin with. So depending on sort of the level of need that you have, having the ability to talk to someone and just have someone assess whatever help you do require. So even if you're at that that side of the spectrum where you're not using as much, or you have other sort of kind of other issues, or kind of, as you mentioned, like physical activity, maybe that might require a bit of a different approach to help. Whereas, if someone was able to assess you when you are your use is a bit more heavier and you are experiencing a bit more harms, having access to someone who can direct you towards tailored approaches that would help you in that area, I think that would be a great first step. But obviously, I think it's also kind of dependent on context. So like if I was looking at a rural community versus maybe like this University of Waterloo student campus population, it kind of depends what that context and that population is dealing with more. So yeah, I would yeah. There's a lot of answers I could say, so I think I'll just leave it at that for now.
Okay, thank you. I'm just waiting to make sure that I'm spotlighted. Oh, there I go. Okay, thank you for that answer. So I think from looking at your slides, what is assumed is that the largest substance use in young individuals is alcohol. But like, where is the province in an integrated comprehensive alcohol policy? Because it is the one that seems to be, maybe this is my opinion here, sort of ignored on a large scale, right? Alcohol is very normalized. It's very much part of the Canadian experience. And so do you have any thoughts about sort of where alcohol is in terms of a more national strategy, and maybe even why we don't have really a comprehensive strategy around that?
Another big question. So I am not as familiar with the alcohol side and sort of specific substances. What I can say is that I have seen at least frameworks, like comprehensive alcohol frameworks, sort of spearheaded by national organizations beyond the government. So actually that slide that I was showing with PEPA, so the partnership education post, I can't remember the exact acronym, but yes, I know that they worked as part of their network with organizations across the country to develop a framework that is trying to address alcohol harms, specifically with students and campuses, I believe. So at least they have. And I know that they work with like the Canadian Centre for Substance Use and Addiction, which connects itself to Health Canada. So I feel like, at least what I'm familiar with, it seems that some strategies or frameworks to understand the problem and how to address it exists, but it seems to be a little bit like arm's length away from the government. But I could be wrong. Maybe there is something that I just haven't come across yet.
Okay. Thank you.
Thank you.
Yeah, thank you very much for that really informative presentation. Okay, so we're going to move on now to our next presenter, which is Dane Maurer-Vackel. Hi, Dane, how are you?
Hi, good. How are you? Can you see me and hear me?
Yes, we can see you. Okay, so I'm just going to give Dane the proper introduction here. So Dane is a PhD student in the public health sciences, conducting research in mental health systems and policies. Dane's research background is in health psychology, psychiatry, addiction medicine, and primary mental health care. And he has a wide-ranging methodological interest from comparative health systems policy and implementation science to scoping and systematic reviews. So Dane's current research focuses on contraband of tobacco and vaping products, poverty reduction interventions in primary care, publicly funded psychotherapy services, and the implementation of collaborative primary mental care health care models. So I'm gonna let you take it away, Dane.
Okay, I'm gonna attempt to share my screen.
Sure.
I hope it works.
Yeah, I can see it there.
Okay, excellent. Just going to. Okay, you can see that still? All right, excellent. So thank you for that introduction. The only thing to add to that, the intro, is that, like Caroline, I'm also supervised by Dr. Chris Perlman. So today I'll be presenting my proposed doctoral research entitled A Research Protocol for the Development, Implementation, and Evaluation of a Toolkit of Mental Health Care Quality Indicators for youth with bipolar disorder. So bipolar disorder is a complex illness involving episodes of severe mood disturbance that cause an individual to cycle through periods of depression and elevated mood. And it's one of the leading causes of disability globally, and is also associated with increased rates of premature mortality because of medical comorbidities like suicide. And pediatric bipolar disorder affects approximately 2% of youth under 18. And there's some evidence to suggest that there's large peaks in incidence within the 15 to 24 age range. So this population is particularly relevant to emerging adults as well as the student population, given that their respective age ranges coincide with high prevalence and incidence rates of many mental disorders, and that includes bipolar disorder. Sorry, I'm just having issues with my slide. There we go. That's the right slide. Okay. According to the World Health Organization, quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes. And in order to gauge progress on this front, researchers can engage in performance measurement activities using quality indicators, which are summary measures that can provide comprehensive understandings of quality of care. So in a sense, they can describe how well the system is meeting the needs of the population in question. An example of a quality indicator would be something like rate of hospital admission as first contact for mental health and addiction for children and youth. And in the Ontario context, there's been a movement in recent years in the adult mental health care sector to develop these quality standards that that theoretically can speak to clinical best practices. A lot of this work's been undertaken by Health Quality Ontario for a variety of mental health conditions, including anxiety disorders, major depression, schizophrenia, and alcohol use disorder. But despite this progress, there is a scarcity of literature focused on understanding and evaluating the performance of the child and youth mental health system in Ontario. And so as a result, there's a lack of quality standards for this population. In particular, there's no standards for bipolar disorder in youth in particular. So given what I've just described, my doctoral research will begin to sort of try to attempt to fill this knowledge gap by developing, implementing, and evaluating a set of mental health quality indicators for youth with bipolar disorder in Ontario. So moving forward in this presentation, I'm simply just going to say this population to represent youth with bipolar disorder, so I'm not repeating myself constantly. So my work will consist of three aims. So firstly, I'll establish a working knowledge regarding the health service utilization patterns of the population. Secondly, I'll refine a set of quality indicators. And finally, I'll attempt to quantify and operationalize the proposed quality indicators. So there exists a great opportunity to develop these quality indicators in the Ontario context using INTRI data. And so these are health system data that include over 50,000 longitudinal assessments of youth accessing care across 90 Ontario community settings between 2015 and 2021, and about 100,000 longitudinal assessments of Ontario inpatient psychiatric settings between 2011 and 2021. So as an example, the INTRI Child and Youth Mental Health Instrument is used for persons aged 4 to 18 in mental health settings at admission, at discharge, and also when there's a clinically significant change in the person's status. So the data collected from this tool can be used to support the development of quality indicators. And so I'll just briefly go through the three studies that I'm proposing, and I'll just provide a bit of an overview of some of the methods and what we can learn. So the first study, as I mentioned before, the aim is to establish a working knowledge regarding health service utilization patterns for the population. And I'll use health system data available through INTRI, as I mentioned in the previous slide. I'll employ longitudinal quantitative methods to examine these patterns of health service utilization. So I'll identify cohort of persons aged 12 to 25 with a bipolar disorder diagnosis in Ontario, I'll identify their needs at admission, and I'll examine changes in these needs across episodes of care. And so in theory, the variation observed in these needs and outcomes will help identify potential quality domains that I'll examine in study 2, which I'll outline in just a second. So I hope people can see the table here on this slide. This is an example of part of a results table. I just cut sort of like the top half of it from a study that used intra-eye data. So here at our Big B and colleagues, we're examining the risk and protective factors for substance use among youth with mental health conditions who receive community-based or residential care services in Ontario. And so in this table, they display their bivariate analysis of factors associated with substance use in the 14 to 30 days prior to assessment for their community sample. As you can see, there's several characteristics along the left side capturing they're captured on the left side, but they're examining proportions across their community sample by gender. So I won't go into too much detail, but just to say that one of the trends that they noted is that the proportion of youth who use substances significantly increased as age increased. So it was at 5% for youth aged 12 to 14, and that jumped up to 36.8% for youth aged 17 to 18. So I just provide this as an example of what, some things we can learn from intra-eye data. So for my proposed work, I'd be looking at a different population. Obviously, as I said before, I'll be looking at bipolar disorder, and this is a population that hasn't yet been studied using intra-eye data. So it will be fairly novel, I hope. Study 2. So this study's aim is to refine a set of quality indicators. So here I'll be employing a qualitative study using a Delphi method, which is essentially a process that researchers can employ to reach group consensus on a topic of interest. So I'll survey a group of experts with extensive knowledge of the health service and clinical care needs of the population. So my participants will include, but not limited to, clinicians, health administrators, patients, family advocates, and others. So in addition to questions about their perspectives on the key domains of quality, of healthcare quality, I'll show these participants the results from study 1 to help sort of facilitate conversation, deliberation on potential quality indicators. And then the stakeholders will also be provided with a draft of potential quality indicators and ask for their ratings on meaningfulness, and that will help us sort of refine what we think could be reasonable quality indicators moving forward. And then going on to the third study. So this final phase, I will employ quantitative approaches using the data from study 1 to evaluate validity and reliability of the identified quality indicators from study 2. So as you can see, these studies sort of build on one another in a logical way. So these analyses, which will be conducted by comparing results across facilities in Ontario, will include several things, but just a couple to note: retest reliability of the quality indicators, as well as validity comparing facility rankings across the province. So ideally, the final result from these 3 studies will be a set of outcome-based quality indicators that are meaningful to key stakeholders and also feasible to measure using existing health assessment systems. So ideally, they would be feasible, action-oriented, and also be able to be implemented in a meaningful way. So to the best of my knowledge, this would be the first set of studies to investigate this population with the idea to incorporate the creation of quality indicators. And through this work, clinicians, health administrators, and decision makers will have a more well-defined measurement system that they can use for evaluating health system quality for this population. Also, at a more sort of systems level, policymakers will hopefully be able to gain a bit of insight as well, and hopefully can help improve their ability to make evidence-informed policy decisions for this population, potentially others that are comparable. And lastly, but probably most importantly, this will hopefully create a scenario where youth and their families can be confident that when they do need high-quality services for their mental health, that they can get that if they need it. So just to wrap up, I think this work presents a great opportunity to improve health service quality for the Ontario youth bipolar disorder population. And in turn, I would hope that it could also positively impact their quality of life. So that concludes my presentation. I have my references here if anyone's interested in further reading. And yeah, I'll stop there.
Great. Thank you, Dane. Really interesting, and I invite anyone to put questions forward very specifically about your research. And I think what resonated with me when you were talking about quality indicators is in campus wellness here at the University of Waterloo. We've embarked on our own journey of developing a performance measurement framework with some KPIs, some key performance indicators, and it's been a real struggle to measure outcomes of mental health. So we found it easier to measure things like how many people are coming through our doors, what's the wait time, some of the process indicators of satisfaction, but the actual outcome indicators are really hard to figure out what those should be. Do you have thoughts about what why we as a healthcare system are really struggling to actually quantify outcome, and is anyone doing it well that you've seen in the literature, any other countries, or any thoughts about that?
Yeah, that's an excellent question. I wish I had a good answer. I'm fairly early on my journey in terms of entering this research space, so I honestly don't have too good of a picture. But I mean, I would hope that there would be we can either use data or create data for quality of life measurements, reduction of symptoms to the degree where they're living without the issues that can present itself at either end of the spectrum for this population at least. I don't know. I'm not sure. I wonder, is there anything more that you can teach me about it? I don't know.
No, I think that's good. That's why it makes me feel better that we're in good company with a researcher who's also struggling in this area, that we're also in the same boat, that, as we said, it's difficult. Is outcomes about symptom reduction, or is it other things, quality of life for individuals with mental health concerns? So thank you. One more question I have here is the data from the Interarray about health systems self-report data? And is there any concerns about the data accuracy, I guess, when it's self-reported, if it is self-reported?
Yeah, that's a good question. So the tool that I mentioned that this other study used, the Child and Youth instrument that I plan to use as well. That's a good question. I haven't had a really good look at it, so I'm not sure. But I would think that a good portion would be self-report. But again, I'm not sure. Just to go back to the previous question, actually, there may be issues with confidentiality of sharing data for youth that are under 16 or something like that. That may also be a limitation in terms of actually having the data to create those indicators that would be more meaningful. So that just sort of came to mind. But
yeah, thank you.
If you learn more about it, shoot me an email and let me know, and I'll read a paper or two. I love that.
Yeah, well, again, I think it's a struggle because all of the research that I think some of our internal group has looked at is outcomes is often measured as satisfaction. And so is a client satisfied with the service they've received or their health, and I think we're struggling with, is satisfaction an outcome or a process? So maybe people can ponder that as we move into our next presentation. So thank you so much, Dane, for that. Very interesting. Good luck with your research.
Thank you. Good luck with your work too. I'm going to stop sharing my screen.
So we're going to move now to Asta Priya. I'm just making sure that Asta is on the line here. I see them. So we'll just wait till they pop up. Oh, great. Hi. Okay. So Asta has a Bachelor of Science in Health Studies and specializes in public policy and international development. She's currently a master's student in sustainability management here at the University of Waterloo. And her work experience includes being a graduate teaching assistant and researching for Waterloo's affordable housing group, as well as working with the Housing Innovation Lab to connect research with looking at homelessness and mental health. So her passions are improving health policies, so that's great to hear, and making healthcare more accessible and equitable for all. And she inspires to bring change to others, and in her free time enjoys running, fashion, and traveling this beautiful world. So hopefully you've been able to get back to traveling since some of the pandemic restrictions, but I will hand it over to you to talk about your research.
Awesome. Thank you so much for that introduction. And yeah, luckily I have been able to travel a bit, so it's been nice. So I will just start with sharing my screen. So I just want to make sure that it's good and it's sharing. Okay, I think I'm good to continue. So yeah, I just want to say hi, everyone. I hope you've been enjoying the conference thus far. So as introduced, my name is Asta Priya, and I'd just like to share my research on improving public health policies to improve providing better mental health care in small-scale fisheries. So yeah, to begin, this is just like a quick overview of like my presentation and the aspects of my research that I will cover. We're going to go over the abstract, the problem statement, objectives, literature review, methods, results, and the conclusion. So yeah, to begin, I want to give you guys all an idea of what this research revolves around. So it is that small-scale fisheries pretty much need help. They support over 90% of the 120 million people engaged in captured fisheries globally, but due to their strong reliance on their surroundings, like the environment, they are in very volatile positions, especially with climate change up on the rise. So this ever-changing nature leads to a lot of social, economic, and environmental vulnerabilities, and they put millions of individuals at risk for negative impacts, especially severe mental health consequences. So with poor mental health, there is like a huge detriment to the livelihood of the fishers itself, and if untreated, can even lead to death. Currently, there is a lack of aid available in these communities for adequate mental health care, and so my research serves for this purpose exactly, and to create like some health policies that can better aid individuals who are suffering in these communities. And we aim to do that by improving the actual local public health, and then improve the response of the local governments or community or institutions. And all this is in turn to pretty much reduce their vulnerability and increase their viability. So before we continue, I also want to share this video with you guys to just kind of like show you the context of small-scale fisheries.
Asta, I'm not sure we hear if we're supposed to be hearing on the video.
Oh, sorry, is the voice not working?
No, we're not hearing any sound, which I know we may have had problems with earlier.
Oh, I'm not 100% sure. Sorry, because on my end, I hear the video like playing on full volume.
Okay. So
was there any?
Our IT person said you want to make sure Teams is capturing audio. I'm not sure. So when you share screen, on the top of your screen, there's a little bar that says give control. Let's try that.
Okay. Yeah, I see that as well. There's a little bar. So could I just give control to
I don't know, Eric, if you want to jump in and.
Yeah, sorry about that. I mean, we can skip the video if it causes
Beside the give control, there should be a computer icon, and that's what you want to click, and that should allow your teams to capture computer audio.
Okay, is it working now?
Yeah. Oh.
Okay, perfect. Sorry, I'll just. Thank you so much.
Globally, it's estimated capture fisheries support 120 million livelihoods, and 90% of those working in this sector come from small-scale fisheries. These fisheries play the biggest role in maintaining food security and providing livelihoods, welfare, and social protection safety nets in some of the most impoverished communities around the world. The majority of the catches from small-scale fisheries are consumed locally. However, they also play an increasingly important role in commercial capture fisheries supply chains. Despite their importance and contributions to community well-being, small-scale fisheries continue to be marginalized and are outcompeted by the interest and supply chain's dominance of the large-scale industrial sector. However, there are opportunities for these fisheries to grow and expand. But to do so, they need support from responsible businesses. With the United Nations Sustainable Development Goals providing a platform to create a sustainable future for all, seafood businesses have an opportunity to push this development agenda forward. Through engaging with and supporting the world's small-scale sector, these fisheries have a chance to operate in the global seafood markets, increasing the equitability of internationally traded seafood, as well as delivering benefits to coastal, resource-dependent communities.
Yeah, so despite like the technical difficulties that came with the video, I just think it was really important to show it because it kind of shows that how socially marginalized these small-scale fishery communities are, that not only their importance, but their existence is unknown to the rest of the world. A majority of people aren't even sure what small-scale fisheries completely entails, and this is a very common rhetoric with the Western world and people outside of small-scale fisheries. So it's really important to kind of just see their context. And then as seen in the video itself, it really showcases that there's a need to help these individuals and that they're really being ignored right now. So by helping them succeed, we will be able to help the world succeed. And then exactly with that, I want to move on to the problem statement. So why is this research even necessary to conduct? And that kind of comes with the idea that small-scale fisheries are one of, again, the most vulnerable systems in the world. An estimated 5.8 million fishers earn less than $1 a day. And most of the people who live with mental health problems will also live in poverty, which is associated with inadequate housing and poor nutrition, which further contributes to their poor mental health. So it's just like a cyclical storm that they're stuck in. And then also mental health is quite a taboo topic to discuss. And then there's also a lack of understanding with it. And with that lack of understanding, it results in a severe neglect of the concept itself. So A lot of these individuals are also way less likely to ask for help due to their anxiety, psychosis, or depression. And more so, on average, they are less likely to have a regular primary care health provider that they can see. The perceptions and lack of knowledge in the healthcare practitioners, especially in places like India or other parts of Asia, really makes them even less willing to help individuals who are suffering from mental health. And then developing countries in general are really lacking financial, political, and social resources that they need to organize funding into the public health care. And all of this really makes it difficult to implement solutions for care. And therefore, there's a huge lack in governance and policy. But obviously, you know, just because it's hard to deal with doesn't mean that we can ignore it. So the policy neglect that is faced by small-scale fishers really needs to be mended so that we can ensure continued resilience. And then just as I continue talking about the rest of my presentation, I really want you guys to all kind of think about, you know, like, what does mental health mean to you? Or what does mental illness mean to you? What are those words? How do they make you feel? And obviously, you're more than welcome to write those thoughts down in the chat if you'd like to share, or if you just want to self-reflect, that's great. But as we're kind of reflecting on that, I really want us to be thinking about how we can all really agree that holistic health means good mental health well-being as well. And this is like something that we all want in our lives, and we all feel it is necessary to be productive and happy. And then, of course, you know, our fishers deserve the exact same respect. So yeah, according to World Health Organization, in just North America, 1 in 5 individuals experience mental illness in a given year, and more than 50% will be diagnosed with a disorder at some point in their life. And now imagine how that statistic would change in a developed or third world country that is severely lacking resources. Obviously, you know, it would like significantly increase in places such as India that are faced with extreme economic, political, and environmental turmoil. And this situation really describes like the livelihood that our small-scale fishers are living in. And pretty much, this is another summary of just kind of like the current situations and problems that are contributing to poor mental health of fishers, as well as the lack of care for them. So these factors, along with migration, institutional change, lacking biodiversity, declining in fish catch, and even disobedience of, you know, global fishing rules and lack of governmental support really causes small-scale fisheries to be a vulnerable socio-ecological system. But obviously, this also just really highlights the need for resilience in small-scale fishers, as it will allow them to withstand, adapt, and cope with the changes that they are constantly facing. So the overarching research question for my thesis and this study is how can local government health policies be improved to provide better care for mental health issues in Chilika Lagoon, India? And then these are the main 3 objectives that this research will aim to target, and they are listed here as well. But briefly, it's going to entail defining mental health as a major vulnerability within the small-scale fishing community, specifying the negative impacts, as well as in uncovering the influential drivers that relate to mental health prevalence. But the main objective of this research will be objective 3, and that is really creating a set of recommendations to inform on best practices within mental health policies, and that they can employ into their own governance and hopefully create a better response to mental health care. And as for the literature review, so there are the 3 major domains, and it goes from vulnerability and viability, which will kind of entail defining vulnerability, and then also it will showcase how the signs of mental illness that one possesses can really be also used to determine the degree of vulnerability that one has, and vice versa. The mental health literature will help uncover the existing economic, environmental, and social contributors to poor mental health for fishers, and as well as the intense negative impacts that it has on their livelihoods. And of course, understanding understanding these impacts of mental health really will help create better solutions for governance and viability. And obviously that will relate to the most important domain of literature, which is really being able to give us guidance on the best practices in mental health policies. And then obviously with that, comparisons to other countries and systems will be used to find commonalities for successful and effective health policies that lead to better coping mechanisms. And as you can see, the literature domains are really divided and separated in connection to the objectives themselves. And yeah, so obviously as the literature review was conducted, it was really revealed that this is a gap in the literature. There is literature on mental health and there is literature on small scale fisheries, but there is no literature right now talking about mental health in small scale fisheries. And this is like a huge deficiency that lies in the literature. And then because there's no literature about it, you know, there's nothing to talk about how they're affected or their negative impacts, or even how, again, health policy can be used to improve their livelihood. So this research will kind of focus on generating the necessary knowledge to bridge that gap. This is the conceptual framework that's outlined here, and it's taken from the World Health Organization's best practices on mental health policies, and they will be used to guide the recommendations that the research will create on, again, bettering the mental health policies. It will mostly just include reducing stigma, increasing practitioners' education, and ensuring stakeholders are all collaborating with the same vision. As for the methodology of this research, it will involve a secondary data collection that will be done through an exhaustive literature review, and that will help with objectives 1, 2, and 3. So especially objective 1 will be fulfilled through this because it will show that the negative impacts from major vulnerabilities equate to the same symptoms of mental health, and then those connections will be solidified because if the effects are the same, then you can say that they are equated to each other. And then the household questionnaire and the global survey will target gaining insight into the barriers present and the needs of the fishers in the study itself. So the household questionnaire involves 53 questions, and the global survey is actually just 1 question, but they all revolve around asking the fishers about their mental health needs. And it's really important to have these surveys and these questionnaires because, of course, we will have literature that shows, in theory, these are the best mental health practices. But the primary data collection will really reveal the million-dollar question. You know, what did the fishers say that they need? What do they want to see in their own community? And analyzing this will also help ensure cultural competency within the study as well. And then as well for the global survey, it will be sent out to about 12 countries, 6 in Africa and 6 in Asia. And then with that, you know, identifying central paradigms and philosophical underpinnings is a critical aspect of the research process. So as outlined here, it shows that the philosophical aspect of this research is transformative and post-positivism because it really has the objective for change and it's surrounding a change-oriented nature. The ontology is consistent with interpretism because the phenomena under investigation relies on human thoughts and beliefs, specifically the fisher. And then the epistemological consideration is that of an objectivist researcher who also states that it is possible to largely eliminate any sources of bias, ensure validity and reliability through robust design checks, and continuously evaluating the process. And then, of course, ethics are always a very important part of qualitative research. So this study will ensure to follow the code of ethics and the TCPS, the ethical code for research involving humans, very thoroughly because we want to make sure that there's no harmful effects to the research participants. And along with that, the respective results, the expected results are all going to be in line with the objectives. We hope that each of the results we receive will be able to fulfill each and every single one. So as of right now, the research is in data collection phase. So the because I'm not able to physically go to India myself. So we have hired like a field researcher in Chilika Lagoon who is familiar with the environment, the people, and really the cultural aspects of Chilika Lagoon to carry out the data collection, such as the surveys and the global aspect. So the analysis is set for another date, but it will pretty much involve the use of Navivo to gather and discover common themes found in the raw data. Also, a coding method and a frequency coding will be used to kind of really narrow down on the common themes between all the data collected, and then therefore suggest the best practices possible in mental health policies. And yeah, with that, like, of course, the major goal is the set of recommendations, and the method is pretty much guided by this main objective. And it's also going to really include feedback from the fishers, which is obviously a huge highlight, is that, again, we really want to make sure that their voice is heard and their needs are prioritized throughout the research as well. And then with the creation of these guidelines, it's pretty likelihood, that over 6 million people will be helped to some extent at the minimum, to over the 100 million people involved in capture fisheries globally. So that is why these recommendations will be made with careful thought and input from all the stakeholders, academic and local. The existence of these set of recommendations, yes, it's novel, it's unique, it's kind of out there, and it might be even a little far-stretched, but if it is used correctly, it has the potential to affect the livelihood of every single small-scale fisher out there. And yeah, just to kind of wrap up, as a concluding thought, I just want to add and emphasize the fact that it is really time for a change, and it is time for a transition. It's time that we bring focus onto the pain and suffering of the individuals in small-scale fisheries, because honestly, no one of us deserves better care compared to anyone else in the world. We are all human, and we all deserve to have systems in place that support us when we need it. And hence, as I face a strong, at least academics and fortunate Canadians in front of me today and during this conference, and my other great presenters, I urge us to work together to help those who cannot help themselves, because at the end of the day, mental health matters. Thank you so much. And then if anyone wants more readings or anything, my references are listed there as well, and I'm happy to share them. But yeah, thank you for listening to my presentation.
Thank you, Asta. That was really interesting, and I'm going to admit an area that I would have never given much thought to before. So thank you for bringing that to our attention, and thank you also with your last concluding comments to really bring back a focus on equity and the fact that it is everyone's right to earn a sustainable living, but also have mental health, safety, and security with that as well. So thank you very much. Because we're running short on time, then I think what we'll do, if individuals have questions for Asta, can they reach out to you directly?
Yes, please. I would definitely appreciate that. I can send out my email or phone number, whatever helps.
That'd be great if you want to just pop that in the chat, and then participants can see that. So thank you so much. I look forward to hearing about the results of your research. That's wonderful. Okay,
thank you so much. Thank you.
Yeah, thank you. We're just wrapping up, and just really great content today. I think this had such for the 3rd annual Student Mental Health Research Conference. It was so nice to have a lot of UW graduate student researchers here talking about such interesting and important research. And I want to thank those presenters who brought us research on whether it was healthcare strategies to substance misuse issues, to trauma, to looking at equity, to looking at COVID and mental health. So a lot of great topics. And I also want to thank the moderators who did a great job making sure things went smoothly and behind the scenes. And a special thank you also to the planning team, the Thrive Conference planning team. They put a lot of work into this. And again, a special thank you to Grace Wong as well, because Grace has done a lot of organization behind the scenes. And thank you, most importantly, to all of you that joined us today. And we hope that you found it very interesting and informative. And so just to wrap up before I hand it over to Jim, I'm just going to talk about, this was part of Thrive. This conference is always part of Thrive, which is around building a culture of well-being and encourages us to speak openly and honestly about mental health. And the 3 goals of of Thrive, again, are around expanding mental health literacy, building healthy habits and self-care, and also fostering a supportive and inclusive community. So hopefully we're working towards achieving our goals at U Waterloo. I know Grace is going to put, if she hasn't so already, I'm just going to check, making sure she's going to put in the chat a short survey that you could give us feedback about the conference and anything else. And maybe Grace can also send that out after to all registrants in case people had to pop off early. And so now I'm going to hand it over and introduce Jim Rush, who's our Vice President, Academic and Provost. And I know, Jim, at your time at the university here, you've always been a huge supporter and advocate for mental health and a champion for prioritizing student well-being. So I'll just hand it over to you for some closing remarks.
Great, thanks very much, Jennifer. Can you hear me?
Yes.
Oh, very good. Yeah, thanks to you for that introduction, and I'm really grateful to have the opportunity to join you today to add to your comments of thanks to presenters and organizers to close out the conference, and by recognizing the huge amount of work that went into making today's event a success for the third annual time, I might add. And so that's another little legacy that developed as this came from a recommendation in the PAC SMH, and was realizing one of the goals of that. It wouldn't have been possible without the contributions of the presenters for the past years, or those today who's really stepped forward to share their innovative work or their ideas about student mental health and well-being, and that's really central to enhancing mental health literacy across a broad variety of topics. So it's really great to see that breadth and spectrum of topics, and in helping students to build healthy habits and self-care habits. There's always something to learn that's relevant from even the most diverse of the presentations. So thanks to the volunteers and the staff for all of your impressive efforts in delivering the conference. That the work that you do really provides a much needed space, I think, to be able to have that wide-ranging conversation. That is one way that gives us as a collective an opportunity to learn and to foster the supportive and inclusive community that we aspire to at Waterloo. Throughout the disruptions brought on by COVID, you've continued to make students and their well-being a top priority, both in terms of service delivery program supports in this conference, which managed to launch and survive during those years. So it's really a great expression of the commitment that the community has. Finally, I want to really just thank the attendees who took the time to participate in today's events. Your participation really does help keep focus on student mental health here on the campus and beyond the boundaries of the campus. The conference is a really important part of the commitments, as I mentioned, that were made by the Committee on Student Mental Health to begin with, and outlined in the Okanagan Charter in the Wellness Collaborative Priorities and in the commitment to the national standard for mental health and well-being for post-secondary students, all of which we have joined and committed to as an institution. So I just want to further recognize that it's great progress, great community on the campus nationally and internationally that's being built around that. But we all recognize that there's still a significant amount of work that lies ahead, and that work will continue to change because the conditions, the environment, and the stresses will continue to change and evolve, not only here at Waterloo, but much broader. So in really decidedly realizing our commitments to student mental health and well-being, it's also healthy, I think, to recognize that it's a process, and we're never going to be at the end of it. And so bringing new ideas and innovations in to the conversation, such as happened through today's conference and other venues, we've heard information on that from many members of our community who face systemic barriers and are interested in building and maintaining positive mental health. In many ways, those challenges relate to what I started this part of my comments on, and that was the impact of COVID-19 on mental health. But even absent COVID, there's a need for continuous watch and continuous development and improvement in the area. It's not the end of our conversation about student mental health, I guess, is the point. It never will be. But through initiatives like this and many others, you're really helping Waterloo to lay the groundwork for long-term changes to ensure that the learnings continue and to keep student mental health at the forefront of what we believe is an institution that's committed to building on great ideas. I think it probably goes without saying with what I've said so far, but the mental health and wellness of our students is a key priority, both for the university and for me personally, but more importantly in the role that I'm here today representing for the university as a whole. And I'd like to conclude today just by highlighting the important focus on lived experience and the promising practices in student mental health and well-being that have been shared through that lens, as well as the innovations in programs and services and research related to student and emerging adult mental health. What we heard today will be part of the foundation for further dialogue and action locally, and as has been referenced throughout beyond. So, you know, society, as we all appreciate, is transforming at a rapid pace. And we all need to have the tools to thrive. At everyone in the university community requires those tools. So let's commit to keeping our momentum and our conversations going. And I just want to again extend my sincere thanks to all of you organizers and participants for providing a venue for continuing that conversation. Thank you very much.
Okay, thank you, Jim. Thanks for joining us today for your closing remarks. And I believe that's the end of our conference. Thank you to everyone again. And we hope you stay well, stay thriving until we meet you again next year, and maybe start thinking about what other great presentations you could encourage for next year's conference. So a special thank you there. There's a slide there for all of the contributions, and take care and have a good evening, everyone.